Before we start, we would like to request all, please keep your mobile phone on silent mode and do converse on your phone outside the hall. The academic session will be in a flow. There won't be any lunch break. You will find the food court at Nirvana restaurant. While returning back to Hall A, also do visit the trade exhibition and stalls. A very warm welcome to all the distinguished dignitaries, delegates, speakers, my seniors, colleagues, and friends. IP Raigar takes great pride in organizing the top ranked academic event, the 31st Mahapedicon and 3rd West Zone Pedicon 2021 from 26 to 28 November 2021 in a hybrid manner. Physical conference will be taking place in Hall A, while Hall B and C has been reserved for the virtual events.
To start our proceeding, we would like to start with the lamp lighting. I would like to call distinguished guest Dr. Bakul Parekh sir to please come forward. Dr. Jain, please come forward. Jain, Dr. Davadkar sir, Dr. Upendra Tijudekar sir, Dr. Gangolia sir, Dr. Archana Joshi madam, Dr. Purna Kulkarni madam.
I would request Dr. Bakul Parekh sir.
Thank you all dignitaries for doing the light lighting. I will request you to please sit up. Please be seated. Thank you.
The caduceus, one of the popular symbol associated with medical profession, was the symbolic star of the Greek god Hermes. The serpent's ability to change from a lethargic stage to one of rapidly active symbolizes the power to convalesce from an illness. Hence, the serpents have been a popular symbol of healing itself. The caduceus, with its central staff and twinned snakes and feathered wings on top, has uncanny similarity to Kundalini. a subtle energy system practiced since ancient times in India. Caduceus and Kundalini teach us that the physical and mental healing can only be complete with awareness of our inner consciousness.
Dear delegates, now we begin with the very first event of today, which is by UNICEF, which is Urban Newborn. For this session, I would like to request Dr. Jayant Upadhyay sir, who is a Vice President West Zone 2020 of Central IIP. He is a the chairperson of this conference and chairperson for scientific program. I would like to call sir on the dais. Also, I would like to call Dr. Bakul Parekh sir, Dr. Upendra Kijodekar sir, and Dr. Khaninder sir on the dais. I request Dr. Jayant Upadhyay, Dr. Jayant sir, to introduce the panelists.
Hello. Am I audible?
Yes, sir.
Good morning, everybody. As we know, UNICEF has always been a big force in taking care of the children all over the world. We are very happy to have a UNICEF session in this third West Zone conference, Pedicon and Mahapedicon. We have a session on urban child, urban newborn, as the first session to start with this conference. The moderator of today's session is Dr. Khanindra Bhuyan, who currently works as World Health Specialist in UNICEF Office of Mumbai. He is a medical doctor with MSc degree in epidemiology from London School of Hygiene and Tropical Medicine and diploma in STD and AIDS from Thailand. He will be moderating today's session on urban newborn by UNICEF. I welcome Dr. Khanindra for this session. We have Dr. Bakul Jayant Parekh, our visionary president of 2020, who is a man of DIP. He is a professor of pediatrics, and he is well known as Bakul Bhai in entire IIP field. So I welcome our past president, our visionary past president, Dr. Bakul Jayant Parekh. Please give him a big hand. I have a pleasure and honor to introduce Dr. Upendra Kijodekar, who has just now been elected as president for 2022, president of Central IIP. He is a practicing pediatrician in Navi Mumbai. He has very keen interest in infectious diseases, nutrition, newborn, and so many fields of pediatrics. We all know him. Now he will be known henceafter as the president of Central IIP. I welcome the moderator and all the panelists, and I request Dr. Khanindra to start the session on urban newborn. Dr. Khanindra, please.
Thank you. First of all, I'd like to thank profusely to IIP for giving us this opportunity. For UNICEF, is it okay if I sit here or? Okay, I should take out the mask. Okay. So first of all, big thanks to the organizers of IIP for UNICEF, the prevention of neonatal mortality and priority for the health program. So I have a very short presentation on the urban newborn care, especially in the context of Maharashtra. As all of us know, India and the state of Maharashtra is committed to the achievement of the Sustainable Development Goals, and the SDG 3 is related to health. And the targets for the different components of the SDG 3 Some of those has already been achieved. Some of them are yet to be achieved in Maharashtra. So the first target is to reduce the maternal mortality to less than 70 per 100,000 live births. The second target is basically ending the preventable deaths of newborn and under 5 children to less than say 12 per 1,000 live births in case of newborn and less than 25 per 1,000 live births in case of under 5 children. Then ending the epidemics of AIDS, tuberculosis and malaria and other neglected tropical diseases is another target. We'll not go to the other elements or other targets, but basically in this sustainable development goal, the achievement of universal health coverage through the primary health care is one of the key agendas. As you know, Maharashtra is the birthplace of the primary healthcare movement in the Millennium Development Goal or in the Health for All by 2000, because the primary healthcare movement in Zamfed area that actually guided the global primary healthcare movement. And now after 2018 Astana declaration, the primary healthcare has become again one of the most critical priorities. And currently all the partners, the government, we are trying to achieve the universal health coverage through primary healthcare by 2030. If you look at the urban profile, Maharashtra is one of the most urbanized state in the country. In 2011, about 45% of the population lived in urban areas. Now, probably it is more than 50% of the population who live in the urban areas. And we also have the largest urban population of about 50.8 million. That was as of 2011. Now the number has definitely gone up. And most importantly, a huge proportion of the urban population live in the slums. So almost 20% of the slum population in the country, they live in Maharashtra. And in cities like Mumbai, almost 40% or more than 40% of the population live in slums. And if you see the overall, say, maternal mortality ratio as well as the under 5 mortality rates in Maharashtra as compared to India, we have done very well. There has been continuous reduction in both maternal mortality as well as the under 5 mortality. But even now, we have about, say, 41,000 children who die every year. And again, we have about, say, 24,000 newborn who die in the first 28 days of birth. And most of these deaths are preventable. And about 900 mothers, they die every year. And COVID-19 pandemic has actually increased the mortality rates of both under 5 children as well as maternal mortality, because we know that all the developmental indicators have been actually taken backwards, or there has been a slowdown in achieving all these indicators. If we look at the overall under 5 mortality and the neonatal mortality in the urban areas in Maharashtra, the mortality is less than the rural counterpart. However, the overall percentage or the overall aggregate that we have, that masks the situation that the under 5 mortality and the neonatal mortality in the slum population or in the poorer section of the society is probably much higher than the state averages. And if we see the institutional delivery and the postnatal care, the situation is better in the urban areas than the rural areas. On the other hand, the early initiation of breastfeeding as well as the exclusive breastfeeding in the rural areas is better than the urban areas. Urban areas, actually, the coverage is much lower. In terms of the child vaccination also, the rural areas do better or have performed better as compared to the urban areas. In terms of the childhood malnutrition, the prevalence of stunted children and the wasted children and underweight children is still very high in Maharashtra. Overall, the child malnutrition levels are slightly better in the urban area, but it is still alarming because the percentages are far too high. In case of anemia, the anemia is slightly lower in the urban areas as compared to the rural areas. And these are some of the challenges for the urban newborn care that I'd like to highlight. in the urban slum population, still there is high delivery at home. Then again, the prevalence of low birth weight babies is much higher in the urban poor. There is also low demand for services and weak community to service provider linkages. There is high utilization of the unqualified practitioners. The situation is worse in the slum areas. And as we have already seen, the infant and young child feeding is lower in the urban areas. The public health infrastructure is relatively poor in the urban slums. And there are a lot of unidentified and unlisted slums which are not recognized by the government. So many of the services are not available there. And there is relatively weaker coordination between the different functionaries in the urban areas. And the frontline functionaries like the ASAs and the Anganwadi workers and the ANMs, these are relatively weaker in the urban areas. That is why many of the national programs are actually slowed down or they are not properly delivered in the urban areas. And finally, what UNICEF has been doing in the urban areas, actually, we have supported the urban routine immunization strategy development in 2020. And we are also supporting the Municipal Corporation of Greater Mumbai for the urban primary healthcare. And we have completed the gap analysis in 410 urban primary health centers, and including the maternity homes in the urban areas. And we have also developed a 3-year proposal for strengthening the urban primary healthcare in Mumbai. And also we have started the labor room quality improvement initiative in 8 maternity homes in the Municipal Corporation of Greater Mumbai. So basically that is a presentation that has given a brief overview of the urban newborn health situation. Now over to you as to how we can are prioritizing the rural section in the urban areas.
So good morning, friends. First of all, I thank the organizers for giving me this opportunity to be here in front of you. And as rightly presented, that urban newborn has its own problems. If you compare why we are discussing urban newborn, because if you compare with rural, we always feel that urban people are more accessibility to the healthcare, good healthcare, and there should be a good improvement in the indices. But unfortunately, in cities like Mumbai, we have 41% urban, that is your urban poor. Nowadays we call slum as urban poor, rather than that slum. And these children are one less access compared to one rural indices. And why so? What we have felt in our practice in the last 40 years is that most of the time they are the working parents, mother and child, or mother and father. So they never register themselves in first trimester. They will register either in second or third trimester. Secondly, most of the time the delivery occur by dies or those other health workers rather than the doctors themselves in the hospital in these urban areas because they are daily wage workers. So they cannot afford getting admitted in hospital. Thirdly, now if you look at those rural urban areas, they are on the hills, in very unreachable areas. So they don't have transport to go to the hospital at the right time. And when they reach the hospital, again, they may not be getting the facilities immediately. So all these factors, plus the non-affordability of the cost of private doctor, heads up. And that's how they end up in the hospital or at delivery at home at last time. And that's why a newborn doesn't get proper attention by a person who is well trained in neonatal resuscitation. That's why, if you see, under 5 mortality, the 41% is formed by, more than 50% is formed by neonatal mortality. And in that neonatal mortality, most of the deaths are either premature or asphyxia and sepsis. So all these things are preventable. But then they have to reach in time, and they should have an access, equitable access to the healthcare, which is not happening in urban areas. The rich people and the middle class people may go to the hospital, but those urban poor people, they are not having that accessibility, they don't have the transport facility, they don't have the money. So we have to work on that part. This can be done by increasing the capacity building of the doctors who are practicing there. they can be reached. Or we can always associate ourselves with some rickshaw association or some of the social association of the corporator of that area. And they can arrange for a 24-hour transport if required with a contact number which is one point contact by which they can get guided to the proper facility. That is true. Thirdly, we should also make increase the awareness among the parents that if they don't take treatment in time and they don't teach it, ultimately they are going to suffer. The child is going to suffer and directly family is going to suffer. So all these things taken into account, I think we have to act at various levels to get back to the good indices. If you want to really reach activity by getting below 12%, we have to really work on urban.
Yeah, good morning, everybody. At the outset, let me thank the organizers and my dear friend Dr. Jain Upadhyay, the conference chairperson, in particular, for inviting. In fact, yesterday only I got an invitation to participate in this session, and Dr. Bhuyan and I worked together when I was Maha-IP president. So we have a long-standing association with him also. So great to be here with you, with IIP Raigad, and congratulations for hosting it in such wonderful circumstances. We are already considering ourselves to be in post-pandemic era. Okay, talking about the neonatal care, one of the very important parameters. All of us want to have India to be called as developed nation, enough of developing nation. And the first and foremost, as Bakul Bhai said, that one of the indices which needs to be improved upon is neonatal mortality. No doubts about it. We have NFHS data, the National Family Health Survey data. The 4 was already out, 5 in part, but yesterday we have a complete nationwide data. We are always proud to be from Maharashtra, one of the states where people compare rest of the states, apart from Kerala and some indices, some of the states. We are doing good in almost all the indices. But then when it comes to neonatal mortality or under 5 mortality or infant mortality, we have to still catch up for the best, better than the best. So what we need to understand is certain factors, as you and me as pediatricians, what can we do is 2 parameters which I feel are extremely important is early neonatal care. As Bakul Bhai said, when you're talking about neonatal care, you cannot segregate obstetric care and neonatal separately. So all these issues need to be addressed with OBGY societies. And fortunately, we have good relation with them also. And we need to have every mother registered first and foremost. If you want to reduce the neonatal mortality, every mother has to be registered. She has to have complete antenatal visits, whatever she has to have. The vaccination is on schedule. So everything goes hand in hand. That is very important. And we are doing great because almost 95% of our mothers are registered. That's a great figure to have. If we improve to that 100%, I'm sure the neonatal mortality is going to go down. We know that 3 most important parameters are asphyxia, prematurity, and sepsis. In fact, the urban neonatal care, there was a study done in Mumbai, published in 2015. 75% of this belong to all these 3, and roughly 25 is this. So asphyxia, prematurity, and severe sepsis are the causes of death. And almost all of them are quite preventable. I won't say completely preventable, but if you have a registered mother, everything detected in time, I'm sure that if she's delivered in hospital in time and then proper neonatal care. So every delivery has to be attended by a qualified neonatologist. That needs to be done. And we are talking about urban, so it's quite possible. Though we are not talking about certain unreached population like one in hilly areas or so on and so forth. The second parameter which I feel which is under our control is early initiation of breastfeeding. Now, I'll give you 2 figures. We need to have exclusive breastfeeding for 6 months. All of us know that. And we did great. Let me tell you the figures. NFHS 4 data showed that we had figures of 57.6% exclusive breastfeeding and NFHS 5, 71%. Excellent jump. So 71% looks little respectable. I always feel that why in India we cannot still go to 90 and 100%. Okay, that's a far-fetched dream, maybe unrealistic, but then at least we have done better. But let me tell you at the same time, in the same breath, that my early initiation of breastfeeding rates were 1 point better than the exclusive breastfeeding, but have come down. So from 57%, we have gone to 53%. So why there is a 4% drop? Because we are not yet extremely serious about that early initiation of breastfeeding. Some of you may ask, Dr. Upendra, what is it so much about that early initiation? 1 घंटे बाद क्या 2 घंटे 4 घंटे के बाद सब settle होने के बाद? No, it is not so. The factors apart from the immediate advantages to the mother, that the oxytocin release, the uterus getting contracted, less chances of hemorrhage. Forget that. The bond, emotional, ठीक है, वो भी बाद में हो सकता है. But more importantly, if there is a single factor which is going to affect the neonatal mortality in toto, it is early initiation of breastfeeding. So I say always, pota tun, pota var. The baby has no business to go under radiant warmer. Why a normal full-term cried immediately birth has to go to a radiant warmer? Then there is umbilical cord gets cut, bathed, and then again given to mother. एक घंटा आराम से चला जाता है. So it is not required for a full-term 3.5 kg 40-weeker baby to go under a radiant warmer for observation. May it be LSCS, may it be any sort of delivery. So the point all of us need to just take it everywhere, wherever we are practicing. And after delivery, the mother has to have, and the baby, everybody knows about the breast crawl video. If you have not seen, we must see that. Baby has natural instincts. Baby is extremely alert after delivery. So we have to give complete advantage, and that baby has to go to the breast and start feeding. The only another practical point is we should not rub and clean the hands of the baby. The hands and nails have meconium, and the smell of nipple areola and meconium, the hands, is exactly same. So the baby has natural tendency to go over towards nipple and start feeding. Such a simple line. You don't have to do anything. You need not put baby to the breast. You just have to put the baby on the mother's tummy, and then the baby starts crawling towards it, and within 1 hour, it has been proven by everybody, within 1 hour, the baby starts effective breastfeeding. The second advantage that we have, we need to know, is the biota, the microbiota on mother's abdomen, the skin gets transferred. It's extremely protective to the baby. So that needs to be taken care of. What are we worried about? Early neonatal mortality deaths, pneumonia, sepsis, diarrhea, and more importantly, hypothermia. So baby's thermoregulation is taken care of, microbiota taken care of, complete food, we talk colostrum first, vaccine. So everything is taken care of. So as pediatricians, wherever we are going for delivery, we must tell all our OBGY colleagues to start initiate early breastfeeding in 1 hour. I think if we take care of, because crying immediately, all of us have done, we do resuscitation, we do that, of course, but then we somehow forget about it. So we talk about when the urine was passed, when the meconium was passed. Do we ever ask when we go for neonatal round when the feeding was given? Do we एक तासामध्ये बाळाला दूध पाजलं होतं का? हा प्रश्न इतका important आहे. So first urine, first meconium, similarly that first cry, of course, and then we should need to ask about feeding also. So if I think pediatricians take care of that, this is one of the important factors help us to improve these parameters. And then going ahead, apart from this, as Dr. Bakul Bhai said, that certain urban population was unreached. So let me tell you the Navi Mumbai experience, the collaboration, the public-private partnership. So we had something called as Sure Start project, which was in collaboration with NGO, and of course Navi Mumbai Municipal Corporation also pitched in. So we offered our services, all pediatricians. Every primary health center of Navi Mumbai was, each one targeted one, and then we went and did every weekly. Our services were offered. What it did, OBGY colleagues also came. So the high-risk pregnancies were picked up. So they were, all eclampsias, all GDM mothers, everything was, sorted out. So the mothers were picked up in time. So the delivery happened in institution. The baby cried immediately. So all these factors start reducing. So that's why one has to collaborate with the local organization wherever we are practicing. And then we can, I think, probably get into a better shape that when we are talking about reducing the better urban neonatal care, all these factors will come into play. I think we'll put on some more points as the discussion goes ahead. Dr. Jain.
Thank you, Dr. Upendra. Thanks to organizer. As have already been enumerated by my learned panelists, Dr. Bakul Bhai Parekh and Dr. Upendra, NFHS data shows that the mortality, infant neonatal mortality as well as infant mortality and other mortality indicators, they are improving, but we are not up to the mark as far as our national standards are concerned. We are gradually approaching towards that. The discussion is about how to improve the neonatal mortality and what are the factors as far as urban newborns are concerned. Now, as has already been said, that perinatal, prenatal, perinatal, and neonatal, these are the three phases which we have to watch to improve the neonatal mortality rate. Prenatal part usually taken care by an obstetrician aided by a pediatrician. Perinatal part is a joint venture, and postnatal is entirely a neonatologist or pediatrician's domain. Now, three important causes is prematurity, hypoxia, and sepsis. Along with that comes the congenital abnormalities and other things which affect the neonatal mortality. Now, as far as prematurity is concerned, prenatal checkup, prenatal visits, early recognition, early intervention, and treatment accordingly definitely helps in improving the neonatal mortality. Perinatal mortality, as far as is concerned, asphyxia is an important factor, and here comes the role of first golden minute of intervention, where pediatrician or a neonatologist has to intervene uh, actively and take care of that first minute so that transition from fetal to neonatal breathing is established. Pediatrician plays an important role. Postnatal sepsis, early recognition, early intervention, early treatment is the key role. Here comes role of rational antibiotic practices as well, where it helps in improving the mortality, taking care of the baby properly, and making a smooth transition. Breastfeeding, very, very important, as has been highlighted by Dr. Upendra. I would like to mention kangaroo care, which is going to be which is always an important factor in initiation contact with mother with a premature or low birth weight baby, maintaining the body temperature or euthermia, as well as initiation of the breastfeeding. As far as nutrition of the newborn baby is concerned, breastfeeding has an immense role, always has been emphasized by so many faculties in every conference. So coming to urban newborn is a different entity, especially post-pandemic period. In urban population, there lies a big chunk of rural population in the form of slums. The problems, the dealings with them, their handling, their intervention, and their management is altogether a different ballgame. Children or newborn belonging to upper or middle class strata have approach to healthcare services, whereas the slum newborn, they don't have this efficient approach to healthcare services. So it's altogether different ballgame. The strategies need to be planned to help this population who lives in slum to take care of their problems. Dr. Bakul.
Ultimately, I think the discussion today is about bringing down the indices in urban newborn. And when we talk of urban newborn, higher middle class and upper class, there is no problem. They are always having. So we should concentrate our discussion on urban poor in their newborn. And that is where the accessibility, affordability, and equity are missing. And that's the reason. That's where if you target. And I think that can be done by, as Upendra said, by private-public partnership or by NGOs pitching in, and some of us doctors helping them out in the mechanism. And also incentivization. I suppose if you can incentivize these urban rural or urban poor people to get themselves delivered and distributed, that may also help, because they are missing on their daily income, and that's the reason why they don't go to the institution. And if we improve the transportation and accessibility, I think that will help us. So UNICEF can play a big role here in joining hands with the local administration, local NGOs, and creating public-private partnerships.
We'll definitely explore your suggestion. I'd also like to highlight one thing. I think we have a huge problem of the low birth weight and preterm babies. And as you have rightly pointed out that the kangaroo mother care has to be promoted in a very big way. So UNICEF jointly with NNF and the Public Health Department, Professor Sashivani ma'am and Dr. Archana Pati ma'am, we have actually rolled out the home-based KMC program in the tribal areas, because in the tribal areas also the prevalence of low birth weight is very high. I think the same situation is also applicable for the urban poor because the low birth weight and the preterm prevalence will be quite high. So if we can explore the rollout of the home-based KMC in the urban poor population, I think that is another area that we can explore. One more activity that UNICEF jointly with the Public Health Department and with Bharati Vidyapeeth Medical University Pune, we have launched Nasik. That is basically the pre-conception care. And the results are very encouraging. Basically, the idea is that whether we can promote the health of the women and the men who are planning their pregnancies and thereby try to prevent the low birth weight, because very often if you look at the NFHS data also, the women's health status is very poor. I mean, more than 50% of them are anemic. 22% of them are having low body mass index or they are underweight. So we, jointly with the Public Health Department and with Vidyapeeth Medical University, Dr. Doke, implemented this intervention in 2 blocks in Nasik, and that has shown very good results in terms of preventing the low birth weight. So if we can prevent the low birth weight, that will also go a long way in actually reducing the neonatal mortality. So these are 2 additional things that I wanted to highlight.
One more important thing is the urban population, migratory population. So many people have come from rural area to urban area to earn, and ultimately they don't earn that much as required. So I think another point we can have is universal health card. If they are given a universal health card, the continuity of follow-ups can be done at a proper place. That happens.
Yes, absolutely.
And the second thing, of course, government is doing that anemia Mukt Bharat. So that also can take care of this. And multiple pregnancies, which is again, within 4, if you look at the statistics, the upper class has 1.5 children per family. Middle class is about 2.5, and the other ones are 3.5. So that also makes a difference.
Very rightly said, but whenever we talk about neonatal care, we will go one step behind and we'll say, no, first the delivery has to be proper. So the OBGY comes in. Before the woman goes to her as a pregnant woman, she's an adolescent girl. So again, the responsibility comes back to us, we pediatricians, because we cater to population up to 18 years of age. And all of us know now the transgenerational impact. Let's talk about malnutrition in general. So if you want to reduce this low birth weight, for that the adolescent female has to be well nourished. So again, the responsibility is on us, and we should remember that this transgenerational effect remains for 3 generations. Initially, it was thought that it was only mother and the offspring, but it is not so. The genetic makeup becomes so much that even that offspring, when she becomes a mother, that will also have a low birth weight baby. So imagine the enormous responsibility on all of us to ensure, because adolescent visits are so less when the patient comes to our population. So they come once in a while, maybe for a dengue follow-up or sometimes a malaria or something, or for a vaccination at 10 years and maybe later on HPV vaccine. So let's not miss on any opportunity. So again comes to that, again growth charts. So all this points to the proper health of a child who becomes an adolescent. So when they go as maybe 23-year-old woman to a gynecologist and she's already healthy, so the problems of low birth weight would be taken care of. I think that is very important. Second point I would like to draw your attention to is COVID, what it has done to. Now, 2 important points which happened in pre-COVID also, NFHS 4 data also showed that still the marriages happening in before 18 years of age is not very less. And out of that 15 to 19-year-old women become pregnant, 8% of them, 8% is a very high figure. So again, the social fabric has to change. Our concepts about early women marriage should come out of here. We have to come out of that kind of thinking. And then when we put all these points together, I'm sure we'll have healthy women who are going to go for a delivery. And talking about the kangaroo mother care, we completely, all of us pediatricians, we have been doing and we have been advocating about it from whatever capacities in our individual as well as from IIP forum. But if you want to give this message in a very strong way still, because we in fact not only tell mothers, we also involve fathers. So the kangaroo father or a grandparent, anybody can give that kind of care. But then we are all very focused about it also and equally passionate as much as UNICEF could be. So you always expect IIP's complete cooperation if you want to roll out such programs on a larger scale, just so that everybody's become made more aware of such kind of programs.
Dr. Upendra has already spoken on prevention of low birth weight babies. Uh, the same thing applies to prevention of infection also. Taking care of the safe delivery, clean delivery, prevention of asphyxia, as I already said, managing the first golden minute of the delivery, and post early neonatal period sepsis prevention by regular checkups, regular monitoring by the pediatrician or by the doctors who are working either in the urban area or in the rural area. Certainly is going to affect. Vaccination is going to play an important role. Vaccination at birth, zero polio, first dose of Hep B, and PCG. They are very important as far as preventing the mortality later on. So these are the factors we have to focus as far as urban newborns are concerned.
One point that I'd like to highlight, UNICEF played a big role in the scale up of the special newborn care units in the country. These are basically the level 2 facilities, mostly in the district hospitals. But the current recommendation of Government of India is that, or the global evidence is that the mother-baby separation, which is very rampant, should be prevented. So Government of India has come up with a guideline that the mother newborn care unit should be promoted everywhere. So that in the SNCUs, whatever mother-baby separation is happening, that can be prevented. So any thoughts on from your side, how the NICUs can be actually either transformed into MNCUs, mother newborn care units, or how we can prevent the mother-baby separation in the NICUs?
So we are also, in fact, changed thinking. Initially, it was so that we were in the NICUs, mothers were not allowed, especially for sick babies, and they had to change, and they're not allowed to touch. But you have all gone through that big circle, and all pediatricians are completely convinced that as early as possible, you make mother part of her baby's care. So if it is not so, it's extremely difficult because the baby is in the best of the NICUs in the country, and maybe for a month or 1.5 months, and you suddenly send him home, the mother is at loss. So she doesn't know how to take care. So we are all convinced about it, and we do try to involve mother right from the word go. But at the same time, you very rightly said that sometimes for some silly reason, maybe not a silly, I should not use the word, but a trivial reason, maybe the baby is kept away from mother. That we are trying to take care that as much as possible, every baby, it's a birthright of the baby, because the lactation would happen only when the baby is with the mother. Maybe somewhere there, then after every 3 hours I go and feed. That doesn't happen. The kind of bond, the kind of hormonal secretion, what has to happen. So we ensure and we emphatically say that at every forum, that as much as possible, let the mother handle the baby. So mother touching the baby is not going to spread any infection. She takes care of everything. Mother speaking to the baby, mother handling the baby, feeding the baby well, asking the mother to prepare, suppose certain, sometimes you have to give extra feeds. So that also involving the mother at NICU level itself. So that by the time the baby is discharged from NICU for whatever condition baby was admitted. So even for phototherapy, sometimes 2 to 3, 4 days, that baby is kept in NICU. I feel that those units can be there with the mother in the room. So that it's very much possible to be there, that mother and phototherapy unit, and there's some private room, even in the private hospital, it's very easily doable thing rather than asking the mother to go. So we are also, our thinking is also changing, and we also know that that factor is so important. So separating mother and baby as much as possible, we are also trying to avoid it.
So what Dr. Upendra said is about the upper class and the middle class who are going to the private clinics. Again, we are going to focus on urban poor. There, this is not going to be possible because they are daily wage earners. So as soon as baby is born and stable, mother goes to work. Because without that, they will not be able to feed themselves as a child. So this issue has to be taken. How to tackle this is a huge problem. Actually, in fact, I was working with one NGO called Sneha, which has been run by our past lead of the local development, like my teacher, Dr. Amida Pandavich. And we really addressed the issue as far as possible, but we found it very difficult because they will not be coming. Because without earning, how they will feed themselves? So this big issue remains in urban poor.
We know that baby is an integral part of mother before delivery. Not only that, the mother is an integral part of the world of the baby just at the time of the delivery and even after that. Kangaroo care, I have already mentioned, the developmentally suitable environment of the newborn baby is with his mother. The breast milk is an integral nutritional supplement to the baby. The touch, the microbiota has already been described by Upendra, which the baby gets from the mother is the integral part, and the immunity, passive immunity, the baby is acquiring from the mother is an integral part. So separation of the baby as far as possible, unless it becomes very mandatory, should never be advised. More so as far as slums in urban areas are concerned, because that is a protective phenomena. Mother stands as a devi or a goddesses for that child in every aspect of that newborn baby's life.
Absolutely. Padak sir, you were also highlighting that the human milk bank has to be promoted in a very big way. Would you like to throw some light on that?
So before that, human milk bank for the urban poor solution in my mind is to take the baby, mother should take the baby wherever she's working, like a kangaroo mother pouch. And then the problem will be solved. But then for that, we require to educate them and to explain them the importance of giving the breastfeeding continuously. That is where we are missing. Regarding human milk bank, of course, where I took over as president in 2020, one of my action plan was one human bank in one each district. AP has got 157 districts. If we have one human milk bank in every district, it will be a very great help to the ones who are not getting enough breast milk. And that agenda still remains in my mind, and I'm working on it. But of course, if you need people like UNICEF can join hands with us, it will be expedited. But ideally, we should have human milk bank in every district to take care of.
So
urban working mothers today to be sustainable in a city like Mumbai, for example, both the partners have to work to be sustainable in middle class also. So there is a separation of and there are 6 months leave are not applicable everywhere. It is only government organization for force they are supposed to do the maternity leave. Many of the private organizations they force the mothers to join. So this separation of mother and child really leads to breastfeeding failure. So I think the sole thing is to develop the crash, the concept of a child care at a workplace is a very important, starting from a smallest roadside workers to the highest corporate levels. It is not there, non-existent in this country.
actually, UNICEF, the nutrition section, they also did a lot of work for promoting the breastfeeding, particularly that Hirkani Kaksh that has been promoted in different offices, so that the lactating mothers have a breastfeeding room, whether it is a government office or a private office or a bus station or whatever. So that has been done, but many of the issues, like say for the urban poor, only the government will be able to support some of those interventions that you highlighted. So any other suggestion or comments or question from?
Government alone will not do it. We have seen over all these years. So ultimately, it has to be a public-private partnership.
Absolutely.
Even if you talk about urban poor, there are classes differences in that also. Even in a city like Mumbai, Mumbai is huge. It's like a country, in fact. So there are certain people who excessively utilize the services of municipal hospitals. Even if they can afford a little bit of, they have some money, they can go to some little affordable private hospital also, but they don't. And they excessively demand services from municipal, and those who actually deserve, those who cannot even afford a auto fare going to the hospital, they are the one who are suffering in the game. So I think we need to have little bit of balance about utilization of whatever services. We cannot, because Mumbai is more than crore population. So we have to have certain ways in which some discrimination can be done. Somewhere some charges are, there are charges and some are totally free, because there is some population even in urban, as you said, that those who are in, we know there are certain pockets. I'm just referring to Mumbai because that's a city where we were brought up. So there are certain pockets where people really cannot afford anything, and we need to help them, because unless they come at par with something basic, our mortality rates, our all parameters are not going to improve. And when everybody is at some level, then only the society becomes at large, at peace. So we cannot have somebody getting the best of every health facility and someone is totally deprived. So something has to be done wherein everybody comes at least at one level where the facilities are used by all. I think wherein the public-private partnership, UNICEF suggesting us, organization like IIP can pitch in, and then we can, because there are pediatricians who are committed, and pediatricians is one community which considers itself to be the most socially committed community, because we feel even injudicious use of antibiotic for a common cold, we feel, oh, I've done some blunder. We take so much pressure on ourselves. We find somebody like a illness, dengue, where there is no antibiotic required. Somebody writes, our eyebrows, in dengue he gave antibiotic. So as if entire society is, the antimicrobial stewardship program entirely on our shoulders, because that is how committed we are. That is how we become pediatricians. So that's why any parameter wherein you want IIP members' contribution, you're always there, especially neonatal care, early initiation, exclusive breastfeeding, complementary feeding, nutrition. So we want to ensure that when at 18 years that child leaves us, we have given a wonderful, committed, healthy individual to society. I think that is what I can put in sum, that the responsibility of pediatricians.
I can give one example. When we worked with Sneha in a place called Varshanagar, in the Crowley Park site near Vancouver, we joined hands with the Rickshaw Drivers Association. We joined with the hand cart people, and we also appointed 3 or 4 responsible citizens of that slum area to be contactable all 24 hours. So if suppose somebody has to deliver, they will contact that person, they will contact the rickshaw person or somebody, and they will carry that lady to Rajawadi Hospital. And in Rajawadi Hospital, so we had just kept a separate counter. If somebody comes like this, they should be attended immediately. And that has helped. That has helped. So like this, if we can develop some models, and then it can be taken forward all over the country.
Any other remarks or comments from the, yes, sir.
Last almost 10 years, we are trying to do it in Panvel. We could not. In spite of Rotary's efforts, in spite of our efforts. I suppose here we can take lead. The collaboration of UNICEF with IIP. If every district you support a breast milk bank, that will really help a lot. From Raigad, I can say that we'll take a lead. We are willing to take. If you support us, we can make first breast milk. I've been trying for that for last 10 years. Unfortunately, could not make it.
And luckily we have
and everything.
And luckily we have the one president who is the incoming president, so he can take up in his agenda to have one human milk bank in every
district. I think that's going to be a big leap in this.
Let me tell you, I just on 3rd of November itself, I wrote a mail to Dr. Sandhya Khadse madam, and then I've already assured her that we'll be taking up in a big way this human milk banking all over the country.
And about the services that we provide, the second point I want to make. In this whole service, first is conception of the mother. Second, she reaching the healthcare authority. And third, she's getting facility in the healthcare authority. If I divide this into two, first is in her hands. Third is in the services. And I don't think there is any substandard in the services wherever she reaches. She reaches to public service, private service. She's certain to get at least 90% of the optimum. Problem is a connect. Problem is to get her to the system, whether it is transport, whether it is communication, whether it is whatever. I think we need to focus more on that. That's more important. So we did the pulse polio program once. We reached the people, and then that made successful. Whatever program so far, the immunization program at national level, we see in the periphery, in the rural area, immunization is much more effective than the urban area. Why? Because that healthcare worker goes to every house and gives it. So I think the system should reach the people, not that we expect that slum people to reach the system. So can make some effort to reach the system, that will make more efforts.
Some key opinion leaders in society, once they understand the importance of these services, immediately the word spreads and then start utilizing, because utilization of services is also important. You just buying ventilator which is getting unused and just kept like that is of no use. So that's why utilization of services will only happen if we reach the that's what we call it.
Utilization of funds should be prioritized. At present, it is skewed. It is not equitable. So that's where I think UNICEF can pitch in.
So any other comments or remarks or any other suggestions?
The idea of breast milk banking is going on in the minds of all pediatricians and now at large in community as well. And India being a poor country and we working in the rural areas, we are little skeptical that whether the misuse of this breast milk will happen, like what is happening in the African countries and it is being sold in the European countries. So your comments on that?
See, whenever you want to do something, there are always going to be pluses and minuses. But just because of one minus, we cannot neglect the pluses. And human milk bank is a requirement. Misuse, if it occurs, we should be able to prevent it. We should come out with the checks and balances and policies. But that should not prevent us from starting the breast milk.
I'll tell you what happened in relation to human milk banking. The issue started with Dr. Sandhya Katse writing me a letter that, like for blood banks, there are statutory warnings, there are certain rules and regulations which are written and well-made policies are there, but none of that sort is there for human milk banking. So we need to have that. So I said from there we'll be taking it. So don't worry. When we talk about doing it at a mass scale, obviously everything will come into paper, and then we can go further, because just by getting some, people having some apprehensions about misuse of certain things, that does not mean that at large people should be deprived of such facilities.
There are too many hurdles in setting up of milk bank. There are too many yeses, no. There are too many ifs and buts. But if the things are standardized, the government procedures are a little bit cumbersome for setting up of a milk bank, because we try to set up a bank, we are in the process. If a apex body like UNICEF or like WHO, if it standardizes the procedure, gives the guideline, they will be acceptable to everybody. And I think it will ease out pressure of setting up of a milk bank, human milk bank.
I think regarding the government procedures, these are all very standardized and well laid out procedures. And most of these are actually formulated by the experts like you only. So if there are certain terms and conditions which needs to be revised, and it will be again the IAP who will be the right agency to advocate with the government and take the process forward.
Unfortunately, we have got many laws, but they are never implemented. So we have to look at the implementation part properly.
So if there are no more suggestions, can we just wrap up this session with a huge thanks to all the panelists and to the organizers of the IAP for giving us this opportunity. Thank you.
We thank UNICEF for taking up such initiatives, and we expect you to be with us all the time.
Sure.
Me as this conference chairman, I thank UNICEF for supporting this conference and supporting this session. Thank you very much. Thank you, Dr. Khanindra. We have a second session which is on virtual platform tomorrow between 1 and 2 p.m. So thank you, everybody.
Thank you, sir. Such an informative session. I would like to make some comment. because I'm working in Navi Mumbai Municipal Corporation and Dr. Upendra is with me. We worked in that program. Two things. One is we also do regularly neonatal mortality audit, which really helps in pinpointing where was the problem. Second thing, Dr. Mohite has mentioned about the transport. Sir, we as assigned rickshawalas and we pay for them for taking this mother to a facility. So that problem also can be easily sorted. It is not a big deal. Third thing is, there is, madam has asked about the law. Purna madam, there is already law in the Maharashtra and we give breastfeeding leave for 6 months in government setting, which is there. It is there exist. Thank you. Thank you for such a conversation. I would like to request Dr. Wagle sir to please facilitate them with the momentous at the left corner of the stage.
Our next symposium is by academic grant from SRCC Children's Hospital, Mumbai.
I would like to request Dr. Purna Kurkune madam to come on the dais. Purna Kurkune madam is a head of Department of Hematology and Oncology at BMT at SRCC. She is also a treasurer of Central IIP. Our next speaker with her is Dr. Sonu Udani madam. I would like to call her on the stage. Dr. Sujata Mushrif madam, I would like to call her on the stage. Also, Dr. Ruchira Misra, please come on the stage. I request Dr. Purna Kurkure madam to please introduce the speaker.
Children and teens are
Hello.
not just small adults. Their bodies are growing and they have unique medical needs. They usually express their concerns differently than adults do. They cannot always answer medical questions and not always patient and cooperative. Experts know how to examine and treat these young children and teens in a way that makes them relaxed and cooperative. And today we have like to hear from them.
Good afternoon to this session being academic endeavor on part of SRCC Children's Hospital, which is a multi-speciality hospital dedicated to children from 0 to 18 years in the heart of the city at Haji Ali, Mumbai. And we have many subspecialties flourishing now. We are in existence only for 3.5 years, I would say 4 years, of which almost 1.5 year was taken up by COVID. But nonetheless, we have made a lot of progress in all the subspecialty. And I'm very glad to share with you that pediatric hematology, oncology and BMT program at SRCC is thriving very well. And that is how we have decided that we will concentrate on one area, and that is hematology, oncology and BMT. And I'm very happy to introduce my colleague, Dr. Sujata Mushrif, to give her a presentation on ABC of thalassemia management. Dr. Sujata Mushrif is a consultant in my department, and she has been trained as a fellow, full-fledged fellow in hematology, oncology and neuro-oncology at a very prestigious institute in USA. And she has decided to come back, and we are very lucky to have her. Dr. Sujata.
Thank you, Dr. Kurkure. Thank you to the organizing committee for giving me this opportunity. Just going to go over basics of thalassemia management, the ABC of thalassemia management, which I think you all probably know way better than me as pediatricians. So A meaning antenatal diagnosis and ancillary or supportive care. B being blood transfusion and bone marrow transplant as a curative option. C being chelation, communicable diseases through blood transfusions and various complications that can happen in treatment of these patients. I'll go as a case-based approach, highlighting some of the things as we go along. So first case is a 6-month-old girl with normal perinatal course who was the first child of a second-degree consanguineous marriage and presented with decreased activity and decreased oral intake. On examination, she was severely pale and mildly icteric. She had splenomegaly and hepatomegaly, and a CBC revealed a hemoglobin of 3.5, a total leukocyte count of 7,500 with a normal differential, and platelets of normal platelets of 1,80,000. She was microcytic with an MCV of only 59. So she had a microcytic anemia at 6 months of age, like with a hepatosplenomegaly. Naturally, it was too early to be not used to not wearing a mask ever. So it was a microcytic anemia at a very early age. So a hemoglobin electrophoresis was done, which showed an increase in HbA2 as well as F, and was diagnosed as thalassemia major, which was further confirmed with the genetic testing as a beta gene mutation. She was started on regular PRBC transfusions every 3 to 4 weeks, and now is growing and developing well. So diagnosed early, started on transfusions. Hopefully the growth and development will be adequate without any extramedullary hematopoiesis, which will not affect her facial characteristics, her bones, widening of bones, and then hopefully curative options may be open for her if she has a sibling or a matched donor available for a curative bone marrow transplant later. So to begin with, at 6 months of age, there may be issues with IV placements and all. There may be a need for a more permanent kind of a line, like a central line. If it's difficult to get a line, we do have a baby which parents got tired of all the pricks. So we finally ended up putting a port, and the life has become much more easier managing it with a port. And they're looking at options for transplant now. So just to make a point that you don't need chelation at this age when you start. You need chelation after a minimum of 10 transfusions, which is about by the age of 2 years. It's only because it's considered that some pre-iron is necessary for brain development, and the studies have not been done under the 2 years of age group. And usually by then you have not given so many transfusions that you need chelation by then. Moving on to the second case is of an 8-month-old girl with severe pallor microcytic anemia. History was not suggestive of an iron deficiency anemia in terms of nutritional status or other examination. Reticulocyte count was raised, unlike what you would see in an iron deficiency anemia. A Menzer index was less than 13, which is calculated as a mean corpuscular volume or MCV by RBC count. And the Menzer more than 13 suggests an iron deficiency, and less than 13 suggests a thalassemia trait or thalassemia major. It's a very quick and dirty way of figuring out when you're confused whether it is a thal or this thing when you're looking at a microcytic anemia. She did have mild hepatosplenomegaly. On further questioning, actually, there is a history of 2 previous siblings who are on chronic transfusion program at Sion Hospital and have been diagnosed as thal major. Parents were very well aware. They did go through antenatal diagnosis, and they knew that this child in utero also had thalassemia. However, the parents could not come to terms with terminating the pregnancy, and they had another child with thalassemia, and that child gets treated with us. So they're keen to see if this child can at least undergo a transplant, so that the burden on the family is of 3 children undergoing transfusions every month. So of the ages between 15 years, 4 to 5 years, and a 2-year-old child. So it's quite a socio-economic as well as social burden. For the mother, it is going through with every child so many times a day, so many times a month. Case number 3 is of a 5-year-old who was being evaluated for poor weight gain and chronic anemia, despite proper iron supplementation. So the history was of constantly getting iron, but the hemoglobin never goes up below above 10 or 11. At the max, it goes to a 10. Was also noted to have broadening or prominence of the forehead and maxillary bones, but had never needed a real transfusion. So he also had pallor and hepatosplenomegaly because the mother had stopped giving the iron and had really not, he was having a growth spurt, and by this time he was about 7 or 8 hemoglobin when they came to us. So this is more likely a thal intermedia who was with, when we did the electrophoresis, had a persistence of hemoglobin F. So it didn't end up needing a lot of transfusions until this age. But it brings out the point that if you don't correct deficiency, if you don't correct the microcytic anemia after giving good dose of iron for a certain amount of time, you have to look for other causes. I mean, don't have to jump to electrophoresis as the first step for a microcytic anemia, especially if money is an issue with the patient. But at least give a trial, and then if it doesn't correct, look at it as an option. Because in these patients, the iron absorption is also affected. So giving iron can be harmful to them. You will never correct the deficiency, but you will cause some amount of iron overload in them because of the iron that you give. Case number 4 is a 7-year-old who was referred to us from Assam for a BMT to be done after identification of a sibling as a complete 10/10 HLA match. And another 6-year-old who came recently from Satara to learn about BMT because somebody else in the community had undergone a bone marrow transplant in Mumbai. So he came with his father to see us. So unfortunately, the first child was HIV positive. He had a match, but his HIV testing was not done frequently, or maybe between the 2 tests, he became positive. And the 6-year-old is hepatitis C positive. So and this has happened, the second case at least has happened in the last year during COVID times when blood was difficult to get. They had a lot of issues getting blood at that time in the area. And now we are trying to do the viral load and first treat the hepatitis and HIV. That HIV child hasn't come back yet, but hopefully when he gets onto antiretrovirals and a good viral load reduction happens, we would be able to proceed with the transplant as desired. And the same so with the child from Satara, who will need to be on some amount of antivirals for a long period of time, but it does not rule out the chance of a curative treatment. Both these children actually have 10/10 siblings as donors available. So this brings out the need for safe blood, encouraging healthy donors, voluntary donors. I was quite surprised when one of my patients whose mother always comes in because she has her blood group is O negative, and sometimes they don't have O negative available. And she misunderstood us telling that try to get donors, as if you don't get donors, then you will not get blood. So in a panic, she started looking in online and other forums. And there were actually even Google reviews and Google options to pay 2,000, 3,000 rupees. And then in a hurry and in a panic, she had actually communicated with somebody who was willing to take 3,000 rupees to donate blood. And this is in Mumbai right now. So we clearly said, don't do any of this. We don't need that. We have a donor system, but this is active even now, despite all the restrictions and everything. So the need for healthy volunteer donors has to be really, really emphasized by all of us, and we all need to be donors too. And preferably NAT tested blood. Right now at SRCC, we are practicing giving NAT tested blood to everybody. Being a children's hospital, we want to set a standard for that, but it does increase the cost of every blood unit. The blood doesn't get charged, but the NAT testing cost has to be levied on the patient. But the NAT testing decreases your window period down to less than 5 days. So which at this time is the fastest you can pick up a positive donor with an infection. So need for safe blood is as important in this care. Case number 5, an 8-year-old was referred to an orthopedic surgeon for a bony growth in the left hypochondrium. We had gone for a camp to Kolhapur. We had ortho surgery, hemonc there. An X-ray was also there, and it thought it was a bony mass. The surgeon couldn't think of anything like a mass there, but it was actually a very hard spleen. It was so hard because there was iron overload. And this, if you look at the skin had that proper brownish hue to the skin. The child was on the shorter side and was a thalassemia major with severe iron load who was getting blood transfusions because he would get symptomatic. But the chelation dosing was based on how much was available or how much was provided by the civil hospital there, based on supplies. Is the story given to me? Don't quote me or get me wrong. So he was severely iron overloaded. and needed definitely better chelation at that point and organ assessment, as well as he already had the endocrine effects due to iron overload, which were evident. Case number 6 is of a, am I on time? Case number 6 is of a 15-year-old with thalassemia major on chronic transfusion. Hemoglobin was 9, ferritin was 7,000. He again had a short stature, looked prepubertal at 15, was quite sad, had rough and dry skin and hair, had excessive urination and weight loss. He, in fact, had stopped going to school because he was getting bullied at school. Not just the friends, but even the teacher who used to call him Butkya, Chotya. So he had just decided, I don't want to go to school. I don't like this. And he was definitely different looking than the rest of the children. So again, he had a severe iron overload. All endocrine functions had been affected. Puberty was delayed. There was no change in voice. There was no growth spurt, nothing happening. So it was quite this thing. So definitely hypothyroidism, diabetes, all of this as a effect of iron overload, because iron can load all your organs, including pituitary, your adrenals, your pancreas, in addition to your liver and your heart. So a few things to assess iron overload. Ferritin, it correlates very well with the iron stores, easy to test and follow, but it varies with inflammation, vitamin C deficiency, so it can go up and down. So you have to take that in consideration whenever you're looking at jumps or falls. Liver iron is a very accurate and standard of care to assess organ iron overload, especially the liver. And we have data to say liver is loaded so much in a particular condition, your heart, your pancreas, this thing will be loaded to this degree. So, but it is the best way. It also gives you the architecture on histopath. However, it is invasive and you can't keep doing it to see whether there is a benefit, whatever intervention you're doing. You can't keep doing liver biopsies every so often. So not the best way in terms of practicality. So the next option is an MRI of the liver, spleen, abdomen, as well as the heart, which assesses organ iron overload, and based on a special software, it's called the T2 star. It gives you a number which correlates with the loading in the organ. And it's a pretty good assessment now that has been standardized. So only thing is it's not done in all the centers because the software is only with few centers or few radiology units. It is non-invasive and very good for serial evaluation. Case number 7 is of a 7-year-old boy with thalassemia major who has been on regular transfusions every 3 to 4 weeks. Last transfusion was about 2 weeks ago, but now noted to have dark urine, severe fatigue, and hemoglobin was noted to be 5 grams per deciliter. So it was not yet time for his transfusion, but he was suddenly weak, suddenly more pale, passing darker urine, hence brought to the doctor, and anemia. So this could be alloimmunization due to frequent transfusions. And here there is a need for extended matching, wherein not just the A, B, RH blood groups, but also the Kelly, Duffy, small s, and the minor ones, which need to be tested. And then the matched blood has to be given. So it is again this thing, and maybe a trial of steroids if you don't have any options to do that. So this is just a rough chart of the various chelators available, and first two, deferoxamine and deferiprone, are oral, and the deferoxamine is a subcutaneous or an IV option. There is a lot of this data is available and everybody uses it. You have to give specific instructions as to how to take the medicine, and compliance is very important. When it is taken, most of these medications work beautifully, and they have to be adjusted to the weight, to the growth of the child, to the requirement of the child. And this can be done with frequent assessments. So what is the frequency? A rough guideline of frequency is to do a CBC before every transfusion, because your pre-transfusion hemoglobin has to be around 10 to 11 at least, and that's a pre-transfusion hemoglobin. Lot of children come and who have said कि 7 है, 8 है, उसके नीचे नहीं गया तो मत आओ, वापस जाओ. So that is not okay. Just 1 minute. मुझे भी बोल दिया. Then ferritin every 3 to 6 months. I dare continuing, yes, because this is a more important slide. Ferritin is 3 to 6 months, less to be maintained less than 1,000, and more than 2,000 you start seeing complications and iron overload in the organs and all. So this is important to do every 3 to 6 months. Many reports give an ferritin less than 1,000 or more than 1,000, a value like which is not an absolute value, just more than 1,000. Please request the lab to give you an absolute value. More than 1,000 could be 1,050 or could be 5,000. So they need to do serial dilutions and give a right number to be able to follow that. So that is an important, very important point. Triple H has to be done once in 6 to 12 months. We don't do more than once a year because we only use NAT tested blood. But if any point of time there is blood transfusion that happens at another center or a child comes to us first time, we do a baseline testing. Liver function test once in 6 months, including renal function test because the chelators can have an effect. DEXA scan once in every 10 years after the age of 10 years, once a year after the age of 10 years, because there is a risk of osteoporosis with the chelators. And you also have to supplement calcium, vitamin D, and zinc in these children because these chelators affect these levels. MRI for liver biopsy once a year after 5 years of age to assess iron overload in the liver as well as its function as well as its other organ to assess or guess other organ involvement. And MRI for iron overload and echo of the heart once every year after 10 years of age. Puberty endocrinology assessment has to be done every 6 months throughout puberty with proper Tanner staging, proper annual hormone testing during puberty to see if they're maturing as expected during puberty. Fasting glucose levels annually after 10 years, PSH annually after 10 years, and ophthalmological and hearing testing because these can be chelator side effects. So these are the minimum testings that need to be done to take a holistic care of the thalassaemic child. And of course, I will let Dr. Ruchira give our curative option for thalassemia as of now. Thank you.
Thank you, Dr. Sujata. If the thalassemia is a very common entity that you come across, and if you have any other points to add, anyone or a question, we can take it up after bone marrow transplant session. I'm happy to introduce my colleague and senior consultant in my department, pediatric, Dr. Ruchira Mishra. She has been well trained in the field of bone marrow transplant in Australia, and then she has the experience of more than 15 years now, and she is going to tell us about the pediatric bone marrow transplant, the indications and how we look at it differently in pediatrics as opposed to adults.
Thank you so much, Dr. Kurkure, and thank you to the organizers for giving us a chance to present on this August forum. So while Sujata has kind of laid the foundation of saying that thalassemia needs to be managed very well if you're giving blood transfusion therapy, we all know that pediatric bone marrow transplant or transplantation for thalassemia is the only curative option that is available to them. So today's topic is pediatric bone marrow transplants. We won't limit ourselves to just thalassemia, but we will talk about all the infections or the diseases that we can cover and cure with pediatric bone marrow transplants. Because it's not just thalassemia, but as my mentor used to say, the eyes see what the brain knows. So unless you know that you can offer them a curative option, we sometimes kind of hesitate to talk about pediatric bone marrow transplants. So what exactly is a bone marrow transplant? Do you call it BMT? Do you call it HSCT? If you're looking through a journal, then you'll hear the term HSCT, or you call it a stem cell therapy, because that's also a very common trendy term that is being used right now. So we all know that the bone marrow is the kind of core of a bone that is present, and this is where that's the factory where blood is produced in all our body. So every long bone in our body has this core, which is this liquid form that is there, and this has cells which are called the hemopoietic stem cells, which have the capacity to form red blood cells, white blood cells, and platelets. So if I could get the hemopoietic stem cell and if I could transplant that to a person who needs it, whose stem cells are defective, then I can offer them a healthy hematopoietic system itself. So because it was done from the bone marrow, that is why the term was coined as a bone marrow transplant. Technically, the term is a hemopoietic stem cell transplant itself. Stem cell therapy, just to differentiate from a hemopoietic stem cell transplant, is being used for taking stem cells from different other cells of origin to cure other diseases, but not from the blood system itself. So that becomes a different modality that is quite in the research mode at the moment. A lot of trials are ongoing, but we do not have proven benefits about that. So we're going to stick to bone marrow transplant or HSCT today. And what are these hematopoietic stem cells? These are cells that are formed to the immune system of our body or the blood system. They have 4 basic actions. They have the ability to renew themselves, the ability to differentiate into different cells of blood, and to mobilize out into the circulation and also undergo apoptosis. Now, this is also important because otherwise these would then form cancer cells as well. So again, which are the people that we can help? So we go through case presentations because that's always the best way to kind of remember things. The first case that I have is a 1-year-old male child who presented with a history of recurrent coughs and colds. He had a skin rash that the mother had noticed since the age of 6 months, and recently had a CBC done by the pediatrician, who was astute enough to pick up that this was just not common cough and cold, but something else, along with that skin rash. And so the CBC showed a hemoglobin of 9.4, a white cell count of 7,600, normal differentiation, and platelets of 23,000. What is our diagnosis in this case? Wiskott-Aldrich syndrome. Yes, perfect. So this child was diagnosed as Wiskott-Aldrich. A genetic workup was sent, and so this and was then referred to our center for a bone marrow transplant. We've actually done a mud transplant for this patient. He is now about 1 year post-transplant and is doing very well. He's grown in height. He's not had any other bleeding episodes, unlike the photograph where you see that he's got a lot of ecchymosis and patches, and the rashes have also disappeared. Case 2, the one that Sujata already described, I've just changed the age. So he's an 11-year-old child, thalassemia major, only child. His peers are teasing him. He's short-statured. The parents have managed regular blood transfusions, have kept his chelation within range, but he's tired of this every day in and out. And luckily for us, we have a 10-by-10 match in the mother itself. Now, this area, particularly Maharashtra, there's a lot of history of consanguineous marriages. So we sometimes find that the parents are full matches as well. Usually we expect that the parents would be half matches because half the genes come from the mother, half the genes come from the father. But in this case, we were lucky that the mother was a match. And so he underwent a matched related donor transplant. The only reason I put that there's a blood group mismatch is, unlike liver or kidney transplants, where initially blood group was a very important factor in deciding who could donate, for bone marrow transplants, this is not a deciding factor at all. All we need is an HLA matching, that 10-by-10 matching that we see. He is now 3 years post-transplant. He has had mild GVHD skin, a temporary decrease in the marrow function, but his chimerism is all 100%. So he's doing very well. He goes swimming with his mates now, and everyone's very happy that he's actually now not requiring transfusions for the last 3 years. Again, a spot diagnosis for those over here, osteopetrosis, perfect. And the history was very, very classical in this case. The reason why we recommend bone marrow transplant for osteopetrosis, although this is a disease where the osteoclasts are dysfunctional, is because the osteoclasts actually originate from the myeloid series. So your white blood cells, the myeloid series, that's where your osteoclasts will actually mature into. So by doing a bone marrow transplant, you can get new normal osteoclasts, and they will cause the disease to disappear as well. So if I was to summarize the indications for a bone marrow transplant, normally people think that a bone marrow transplant would work wherever there are stem cells are defective, so in a cancerous condition. But in pediatrics, again, as a caveat, we are very good at treating pediatric cancers, and we really don't offer bone marrow transplants upfront except for neuroblastomas. We use it or reserve it for relapsed cases. So if you had an ALL in a second or a third relapse or a fourth relapse, that's when we would offer it. If you know that they were high risk leukemias, only then would you consider that as a transplant modality upfront. Or if you want to treat them as high risk disease, and if they relapse, that you offer it. AML or acute myeloid leukemia, again, as a high risk cytogenetics, then you would offer it. Myelodysplastic syndromes, osteopetrosis we put there, although that's not a malignant condition. Stage 4 neuroblastomas and relapsed solid tumors would be another indication. But the non-malignant list is much, much larger for us. So non-malignant conditions, which you pediatricians see day in and day out, are the reasons why we would transplant our patients. And as we said, we have 3 cell lines to look into. So you have your thalassemias, your red blood cell disorders, thalassemia, sickle cell, or other hemoglobinopathies. You have your severe aplastic anemias or the white cell disorders, or a CGD or a Wiskott-Aldrich, the platelet disorders coming in, Costman or a SCID, that's the primary immunodeficiency disorders coming in. Or you could also offer a bone marrow transplant for mucopolysaccharidosis or even refractory hemophagocytic HLH as well. You can also offer bone marrow transplants for inborn errors of metabolism. So these could be just like your Hurlers or a Hunters, like a mucopolysaccharidosis or even a MPS 6, a Gaucher's or a Tay Sachs. Your neurodegenerative disorders like an XLD or an MLD, a Krabbe's or Woolman's, and even some mitochondrial disorders as well. The photograph that we have over here is a family who had a history of Hurler syndrome in the family. They had 3 children and all 3 were affected. We did a haploidentical transplant using the father because you can see that his phenotype is very normal. And now this child is about 11 years and has no problems as well. So just looking at the data, India has a very large need for doing bone marrow transplants. We need to do at least about 2 to 3 lakh transplants a year because of the population that we have. However, at the moment, we are only able to serve about 2,000 to 3,000 transplants a year. So that number is really, really low and we need to really work on that. When we look at transplants, what is the first thing that you could help us with? When you diagnose a patient who needs a transplant, the second most important criteria is to find the donor. And that we need to find that there should be an HLA matching. So HLA is a protein that is present on the cells, which we need to match. We need to match them generally at about 5 loci. So class 1 and class 2, and that can be done by just sending it to the lab. So you ask for a high resolution HLA typing for the patient, the siblings, and for the parents, and you get this report within 2 weeks so you can identify which donor is there. Then you decide which kind of transplant you can offer them. So there are 4 main kinds of transplants. The first being the matched sibling donor transplant that you see on the left bottom corner. So matched sibling transplants are the golden standard. Everyone wants to do a matched sibling donor transplant. You have a donor who's readily available within the family. The number of complications you have will be the least, so your chances of success are the best. However, not everyone gets a matched sibling donor. Only 25% of your patients will have a matched sibling donor. So what is the other alternative you offer them? You offer them a matched unrelated donor. From the HLA typing that you've done for them, you look for a donor within the system. And there are NGOs that have databases for donors who are willing to give their stem cells. And that's a matched unrelated donor. Now, the advantage is that you again have an HLA type. So within 24 hours, you know if there's a potential donor. The disadvantage is trying to get that donor to agree, because a lot of them will go back to their doctor and the doctor will tell them, no, like a liver transplant, an organ is taken out, or a kidney transplant, your kidney is taken out. So don't do a don't be the donor. Well, we need to tell them that, yes, please go ahead. It's just like a blood transfusion, and go ahead and save somebody's life. It almost takes about 3 months to convince a donor and to get the cells from them. So 3 months are lost in trying to just do this convincing and fro and back and getting their IDMs tested. So the next alternative was to look at unrelated cord bloods. Now, I know that we have an august gathering of pediatricians over here, and there is a consensus statement on cord blood banking by the IAP itself. So cord blood banking is a very good source of stem cells, readily available, HLA typed, and you know exactly how many stem cells you're going to get. However, it's a very small dose that you get. So you just get about 3 or 4 million cells per kg for the child. And unfortunately, it doesn't work for the patient himself. Now, the way cord blood banking is actually promoted right now in India is that you store the stem cells for your own use. So you have a baby and you say your stem cells are stored for that baby's use. It's not going to help him, because if his stem cells are defective, the cord blood stem cells are also defective. So there's just no use whatsoever of those cells. So you need to be able to give them away, donate them, have a public cord blood banking kind of a system. Only then does it become useful. Now, with all these 3 modalities, we are still able to find donors for just about 70% of our population. We still have 30% who don't get a donor. And that's where the recent advances of haploidentical transplants comes into force. Knowing that the parents are going to be half matches, we know exactly we can always have a donor present. Parents will always do everything for their kids, so we know we can choose actually which donor we want, and readily available source for us. So haploidentical transplants has really picked up in India at least, and we're doing a lot of work on this as well. Now, people will also ask you about the transplant process itself. So you as pediatricians would be the first counselors for us as well. So here's another reason why we need to tell you or ask you to please tell these children that this is how its transplant's going to be happening. Do not be afraid of it and work on it as well. So the transplant process is divided into pre-transplant evaluation. where you make sure that the patient is fit for a transplant. Then we offer them conditioning or radiotherapy to completely destroy their marrow. And we infuse the cells like a blood transfusion. There is no surgery involved in a bone marrow transplant. The expertise and the kind of danger of a transplant rise in the post-transplant period, where we're waiting for these cells to grow. And that's why the post-transplant period becomes a little bit risky for us as well. And we have to keep a very stringent watch on these patients, whether they get infections, whether they get any complications to the chemotherapy like a VOD or graft failure, or they land up with chronic GVHD as well with us. So just a few data on how the transplant is working in India. The pediatric population, we've done about 5,640 transplants in the last 8 years. You will find that most of these transplants are done for hemoglobinopathies, thalassemia being the biggest quarter. After that comes aplastic anemia, and then come the other diseases. Whereas for adults, multiple myeloma is the first rank. What we've been doing at SRCC is almost similar to that picture that you see. We've done about 75 transplants in the last 2 years. THALS being our biggest chunk of transplants. We've done about 23 transplants there, followed by ALL, AML. And we've also picked up some not so common diseases like an MLD, a pure red cell aplasia, a Krabbe's disease, a JMML, and also osteopetrosis. The last transplant that we've done is for a congenital amegakaryocytic thrombocytopenia as well. And if I was to divide them into the kinds of transplants that we've done a lot of matched sibling transplants, but at our center, we do a lot of haploidentical transplants, both a haploreplete as well as a haplo-TCR alpha-beta depleted transplants. So that's the majority of the work that we've been doing. And I'm very happy to say haplo transplants, almost about 80% of them will do well. So I will conclude this presentation, and I will say that while we try to teach our children all about life, our children actually teach us what life is all about. And so it's a request for all of you to kind of nurture these kids and bring them to get them a cure as soon as they can. Thank you so much for your kind attention.
Thank you, Dr. Ruchira, for that very good and lucid overview. And as you must have gathered by now that all these conditions or all these treatments, they are very, very hectic, and they are associated with many complications, as well as many of the children with oncological conditions can present with an emergency situations and need to be attended well in a very intensive fashion. And pediatric emergencies are very common, and we are very happy and proud to be saying that we have a very excellent PICU, NICU setup at SRCC, being headed by none other than Dr. Sunil Dani, who is also a medical director of the facility and has a tremendous experience in pediatric intensive care of more than 3 decades. And she will share with us her experience and overview of emergencies in oncology. According to her, they are simply simple, and she will tell us the way she looks at this emergencies in oncology.
A tremendous job in the oncology and BMT department of our hospital. I'm going to keep it very simple, just to sensitize all of us to what happens in oncology, what happens to these patients, because they are very isolated. They stay in a closed room in like a bubble after their BMT. And it's not just BMT, but so many other conditions as well. And they only come to our attention when something happens. Also, many of these kids go out into their own homes and their villages and towns, and there they land in trouble. And at that point, they're very keen on coming back to the hospital, which may be many, many miles away or even a city away. And if their local doctors are not sensitized to their possible complications, they do land in trouble, as you'll see one of our children did. We all know about infections in immunosuppressed kids, and that is the most important oncological emergency that we face. What we try to do is to prevent a conversion of an emergency from a child who may actually be stable with an infection. Then there are mass effects, there are hyperviscosity syndromes, and there are a lot of metabolic issues that occur in oncology patients for the nasty drugs and all the stuff that they give to them. And it affects every single organ. There is not a single organ that is spared with complications. The central nervous system, the heart, the gut, the GI tract, obviously the kidney being, as you all have all heard, the canary in the mine. And there can be eye problems and there can be many other problems. Look at this 15-year-old boy, 19 months post BMT. He is at home, he's in his village, quite a few miles away. All he's got is a very mild GVHD, which is not troubling him too much. And what happens to him is that he gets an injury to his leg while playing. It's very innocuous injury. Some malampati is done. And after a few days of this malampati, he gets a high fever, severe pain in the leg, and starts becoming drowsy. At that point, instead of taking him to the closest hospital, the parents panic. They put him in a train and they start traveling 18 miles to come back to their doctors. In that train, he has seizures for about 10 to 12 hours, continuous status epilepticus. And they are just helpless and all they want is to reach the hospital. So when he comes to us, he's got E. coli sepsis in his blood, in his CSF, and in his wound, which you will see, and he's in refractory shock. Now, this wound that you're seeing is almost 1 month post getting him into some kind of rehabilitative condition. Obviously, he's going to need a lot of skin grafting, etc. But he becomes non-ambulatory, he's got CNS problems, and the rehab is taking an extremely long time. And then these children are prone to secondary infections. They are already immunocompromised from their problem, as well as from their serious infection. And unfortunately, this boy, we lost him just a few days ago. So infectious emergencies, we should have our antennae up all the time. The risk factors are obvious. They're immunosuppressed, they've got neutropenia, and they may have implants, they've got central venous catheters, PICC lines, ports, and very often in oncosurgery, maybe for bones or sarcomas, they've got prosthesis. So any of these can actually get infected. Fever is common. They're often ill-looking. They can have diarrhea. They have a lot of ulcers which cause diarrhea and superadded infection and abdominal distension. These are the common signs that we keep seeing. But the usual signs of infection, like a high fever, may be absent because they don't mount a response to the fever, to the infection. And also, when we look at them and we say source control, they often don't form pus. So they can have severe infection in their soft tissues, in their lungs or wherever, and they will not manifest with pus. So we have to be very vigilant and recognize this fast. So shock may be an early or late sign, and they tumble into shock very fast. You see a child in the morning and you think, no, he's not so bad, just give him a little bit of fluid, just bring down his fever. By afternoon, he's in shock. So they don't give you time. And subtle signs are often missed with them. The other thing that Ruchira and Sujata try to do all the time is educate the parents as to what to look for. If this happens, bring your child. If this happens, give your child this. So they continuously try to teach their parents how to handle their children. And we know the parents are the most caring and they are the ones who are going to react fastest. So it's very urgent to distinguish a well child from a possibly sick child or one that is already in shock. And assessment of subtle signs should be taught to everybody, right from parents to healthcare workers, nurses. Everybody should be involved in looking for subtle signs. Tachycardia, tachypnea, CRT, the usual signs, there's nothing different. If there is a port or a line, a culture should be taken from all the lumens of the line. They should be taken from any kind of prosthesis that may be there if it's possible. And peripheral blood cultures also, along with central blood cultures for paired cultures. So we know whether it's the central line at fault or it's another infection that's coming from somewhere else. Chest x-rays are very often not very helpful, but obviously if there are chest signs, we would definitely do one. Urine culture is oft forgotten. And often when there's severe neutropenia, you won't get pus cells in the urine. So urine culture, especially in girls, would be extremely important, and coverage of antibiotics. Now, most often I would be the first person to preach that don't rush in with antibiotics, don't rush in with antibiotics. But here is a case where they don't give you time. So you need to give what is happening within your own community and your own area. Shock can be of many varieties, and I won't go into the details, except this very odd kind of retinoic acid syndrome, which is a sepsis mimic. And the severe capillary leakage with leukocyte activation looks almost like a macrophage activation syndrome. And unless we are sensitized to it, we may actually miss it. The other common emergency we see is hypertension. It's often missed, and the first presentation of that hypertension is as a hypertension emergency with a target organ, either the heart, the kidney, or the brain in trouble. And the most common complication that we have seen with hypertension is, of course, the posterior reversible encephalopathy syndrome. And of course, the causes may be many, but the drugs are often a cause of it. They can have catecholamine release, they can be on steroids, they are often fluid overloaded. So press often is what brings hypertension to our attention. Mass emergencies sometimes are absolute emergencies because they may be causing compression of vital organs, compression of vital structures that are feeding vital organs. And one common thing that you see is tracheal compression. I think we've all seen this in our lives, a large mediastinal mass or even a small little mass compressing the trachea, compressing the blood vessels, and causing a lot of stridor. Sometimes they don't have stridor. All they're doing is trying to keep their trachea open by extending and leaning forward. So posture of a child is very important. Don't try and push this child down and make him sleep. And here you can see that how small the trachea is. It's almost closed up over here. I don't know if you can see it. You can't see my arrow, but I think that red arrow points to the trachea. The important thing about these is that, of course, you can give them oxygen, but always remember, oxygen is a double-edged sword. While it may keep you looking at 99% SATs, you can miss the fact that the child is going into respiratory failure. There's a CO2 buildup, and because the lungs are okay, the oxygen is diffusing fine. Allow spontaneous breathing, prone the child if necessary. And when we have to do a biopsy or give any kind of sedation, we try to keep the child spontaneously breathing. And intubation only if there is a crash and it's absolutely life-saving. So we need to inform our anesthetist that this kind of child is there in our hospital, and please be ready to come and help us at any time. Because the ET will only relieve the compression above the carina. It cannot go below that. So you might need airway experts to help you. Emergency chemo, quick steroids, even without a diagnosis, and use other methods. They use a bone marrow, they use blood sampling, etc., to try and find the diagnosis. Spinal cord compression, the important thing about this is if it's symptomatic and there is any kind of neurodeficit, you have to do something fast. Again, it's the same as the mediastinal compression. You may try chemo, steroids, or you may even go in for irradiation or surgical decompression. If it's asymptomatic, it might give you time. You can go ahead and do biopsies, etc. But remember that the symptomatic spinal cord compression can land you with paraplegia, quadriplegia, and permanent urinary dysfunction. So it has to be treated as an absolute emergency. I remember this boy came with just complaints that his veins were looking prominent. And we didn't know what he had. This was a long time ago. He had no other symptoms, just the veins are prominent. And when we asked the history, he said he has a hydrocele. I think he was about 17 or 18 years old. He has a hydrocele. What he actually had was a testicular carcinoma and mets all over, compressing his superior vena cava, his inferior vena cava. He was completely clogged up with mets from his testicular carcinoma. So SVC syndrome may not always be a very big emergency, but it also needs to be addressed. And the SVC gets compressed, you need to do an echo, a Doppler, but most common, you would need to do a CT angio with a good CT scan to find out what is actually compressing. Sometimes there's nothing compressing, there is intravascular thrombus, and that can be tackled either with urokinase, an interventional radiologist doing a thrombectomy, and if push comes to shove, a surgical decompression. A 12-year-old boy with hemiplegia, altered sensorium, and anuria presents to a hospital in the city, and CBC is done, 5 lakh count. He's referred to us. By the time he comes, he's pretty much comatose, and we start hydration and allopurinol, and we start mobilizing an exchange transfusion. What we want to do is leukapheresis, remove the leukocyte burden. We don't care what he has. That's absolutely immaterial at that point. We know that this is a hyperviscosity syndrome. It occurs because the serum proteins or cellular components actually make the blood more viscous, and they sometimes physically also clog up the arteries and veins. There's vascular stasis, hypoperfusion, and finally, of course, organ dysfunction. The problem with these hyperviscosity syndromes is that they're not benign at all. They cause a lot of damage. They can cause multi-organ dysfunction. They can cause multi-organ failure. They have metabolic issues, renal failure, respiratory compromise because they cause pulmonary hypertension, and because they cause a DIC, they can cause hemorrhage. Most commonly, what I have seen at least is that they've presented with strokes. Metabolic emergencies we're all familiar with. We'll only talk about a few that may not be coming into our purview. When there's hypophosphatemia, hyperkalemia, we all know what to do. Hypocalcemia occurs because of rapid turnover of the tumor cells without even giving treatment. Sometimes the tumor cells just start dying, and they're multiplying so fast that they give hypocalcemia. But uncommon and less recognized is hypercalcemia. Can be due to bone mess, can be due to PTH peptide formations. The problem with hypercalcemia is that it can be missed because we don't really think about it in situations where it comes in. Most of the time when we think about metabolic derangements, we think of tumor lysis syndrome. And we all know how to treat tumor lysis. Successfully, unsuccessfully, I don't know. But there are the Cairo-Bishop criteria for tumor lysis. And also tumor lysis syndrome, we can treat to prevent uric acid from forming. We use allopurinol. But once the uric acid is formed, allopurinol is not very useful. Then you have to go to the uric acid oxidase, like rasburicase and other enzymes. So this is something that we have to prevent. If you can't prevent it, you might have to change the uric acid into something that is less damaging. Hypercalcemia, I remember a case who came with Guillain-Barré syndrome, completely paralyzed. And he was great. We are so clever. We started in IVIG till the labs came back. And we're in the habit of just doing a whole panel, and his calcium was 18. Then the hunt started, and he had parathormone malignancy. So he had these malignant parathormones. So the treatment is not very easy. The calcium takes months to come down sometimes, and the treatment needs to also go on for a very long time. Mostly we use normal saline in 2 to 3 times the amount. Give furosemide to mobilize the fluid out because the kidney is not going to take that much. Prednisolone, some form of steroid, can go on for 1 to 2 weeks. And bisphosphonates to mobilize the calcium out of the system and into the bones. We use bisphosphonates. And then there are other treatments also. But these children require a lot of managing. The CNS emergencies, altered sensorium, stroke, seizures. Breast is the most common one we see, but seizures are very common. And there is leukoencephalopathy. They may be due to drugs. Methotrexate encephalopathy is something that I think many of you have also seen. And these CNS emergencies also bring the child into the PICU. Many of these chemotherapy agents cause alteration in consciousness, and we'll never get corticosteroids. Just take 10 seconds more, because we just use them like water, but they are mood altering, they cause hallucinations, they actually can cause steroid psychosis, which may be transient, but sometimes it is not. So we need to think of all these things. GI emergencies, the only one I'm going to talk about here is veno-occlusive disease, strange disease. The first time I saw it was after bone marrow transplantation. I didn't even know it existed. It's because of the dysfunction of the hepatic sinusoids, the endothelial cells. You see a child who looks like a Bacchiari, but because he's had a bone marrow transplant, you know that this isn't a Bacchiari, it's a veno-occlusive disease. Difficult to treat. There's a wide spectrum from self-resolving to mortality. So there's a wide spectrum, and an expensive drug called defibrotide is used for it. How effective it is, I don't know. Oliguria, we won't go into the details, but just visual disturbances, blindness, all these veno-occlusive diseases, drugs itself can cause central retinal artery occlusion. And don't forget the skin vesicants, because you can lose a limb from all these nasty drugs being pumped into the child. And that's why we use central lines and ports. Sorry, I went a minute over, but these are the conclusions that we need to look for these complications, be sensitized to them, educate ourselves, as well as the parents. Thank you very much, all of you, for giving us this platform to show our BMT department and oncology department, which is one of our most, not only a trust department, I don't like to use that word, but it is also a very, very hardworking department that works as a department. In a country where everyone is so individualistic, this department works as a department. They have a fellowship program also going, which is quite popular. Thank you very much.
Thank you very much, Dr. Sunu, for those kind words for my department. And we all know that childhood cancers are highly curable, but that cure comes with the hard work and at a cost, both financially and work-wise also, as to how the child and the whole family and us, we have to go through those hard days to get those fruits. And without working as a team, it is very, very difficult to achieve these targets. So I'm very, very grateful and thankful that we have a good team at SRCC being supported by all other departments like emergency, nephrology, endocrinology. Everyone is around to give us the helping hand, and that makes us really very comfortable to treat these children at any level of complicated treatment. And thank you for this opportunity to showcase our department and our activities to Mahapedicon and West Zone Pedicon.
Thank you. Thank you, madam. Thank you, Dr. Udani, madam. Thank you, Dr. Sujata, madam. Thank you, Dr. Ruchira, madam, for such an informative talk. I request Dr. Purna Kurkune, madam, to stay on the dais for the next session. And we request all the panelists and speakers to collect their mementos from Dr. Wagale. And I request Dr. Dabadkar, sir, to give them a mementos.
I would like to announce that the academic session will be a continuous flow. There won't be any lunch break. Lunch will be served only till 3:30 p.m. You can find the food court at Nirvana restaurant just after the reception on the left side.
Now we proceed towards our guest lecture session. I would like to request Dr. Sunita Ingle, madam, President Raigad IIP, our own dashing president, to come on the stage to chair this session. I also request Dr. Purna Kurkune, madam, to please come on the stage to share this session. Now we move our first lecture. I would like to call on the stage Dr. Bakul Bhai Parekh for his guest lecture. Sir is a national president IIP in 2020. He is a national honorary secretary general CIP in 2016 and 70. He is a professor of pediatrics at BPCH and multi-specialty centers Ghatkopar. He is a CEO of DIIP and in charge of Digital Center of Excellence. He is also member of Maharashtra COVID Task Force. He is also known internationally, and that is he is a president of IPA, that is International Pediatrics Association Congress 2023. He is a honorary secretary general also at South Asia Pacific Pediatrics Association. I request Dr. Bakul Parekh, sir, to give his thoughts.
Health sector is making rapid progress in digital technology, like image data collection, self-monitoring devices to the latest use of cloud computing and artificial intelligence. To mesmerize through this magical extra energy, we have with us Dr. Bakul Parekh, sir, who is a true magician. He is the legend. who has sensed the trend and introduced DILP. So we hand over the stage to you.
So thanks the organizer for giving me this opportunity. When I heard a topic digital magic, I was just thinking what to talk. During my childhood, we used to say Sim Sim Khulja, Alibaba Chalis Chor, and that was magic. So now the things have changed. And so we'll talk of digital revolution in healthcare. And as we know that it has definitely impacted almost everything like economy, innovation, science, education, health, governance, and lifestyles. It started in 1980 with the advent of internet, mobile devices, and social networking. It has changed the way we communicate, the way we learn, and the way we practice. Sky is the limit. To stay competitive, we have to invest in digital infrastructure. Disadvantages can be privacy, security, digital manipulations, complexity, and definitely social disconnect, which we see. So what is health tech? It's basically EMR, that is electronic medical record, patient information system with patient empowerment, artificial intelligence device to a diagnosis, and resource management and communication system. And what has it has provided to us? Empowering the patients, reducing the health expenditure, remote consultations, mobile wearables, and use of artificial intelligence in our devices. And what is artificial intelligence? There is collection of data, structured and unstructured, that is stored in databases and servers, and then that process the data using CPU, GPUs, or even artificial intelligence algorithms to detect the patterns. So basically it is study of patterns which will give us a predictive signal and we'll get the actionable insight. So we are far away from general intelligence in machine, and artificial intelligence merely finds patterns in large data set, and basically based on that pattern data, we'll get the indications of what to do further. So definitely it is better than human beings in knowledge-based disciplines. So will we need doctors when we have artificial intelligence like this? Yes, of course. Even though it may be able to diagnose better in the near future for a range of situations, the need for doctors will not go away at all, because a human expert is definitely required for the judgment. So it is always man behind the machine, which is very important. And the confidence of an empathetic expert human being is always needed for developing confidence in the child. And do doctors need machines? Yes, again, doctors can and must adopt artificial intelligence in the practice. This will improve the ability to work on large data sets, which if we try to infer mechanically or manually, it's going to be very tedious and impossible. So together with the machines, they will be able to diagnose better and faster, and patient healthcare outcomes will improve. What IAP has done? We have definitely touched upon diagnostics, monitoring, support tools for the doctors, and public health governance. What is diagnostic and monitoring? Of course, we can get diagnostic tests which can be done at point of care. It will be faster and cheaper. For example, a device that uses spectroscopy, so without puncturing, you can know the hemoglobin by flipping a device on the lip. A range of wearable devices for monitoring will be available. And if it is connected to artificial intelligence on the internet, we can listen to the lung sounds or other symptoms and alert us as soon as symptoms appear. So IAP is planning to enable early and affordable access to devices and technologies which are available all over the world, but we should bring it to our own members by joining hands with leading universities in the US and Europe. We already started working with one Israel university, and they are giving us lots of information. Explore at home services, like if you have a skilled mobile manpower equipped with artificial intelligence, then you can definitely make use of them, and you may be away, but you can get the information which you want. A partnership with National Cancer Institute Biobank of IIT Madras has been done, and initially for cancer diagnostics, and subsequently it will be extended across the genetic spectrum of diagnostics and predictive genomics. We are already working on it, and maybe by year end or maybe beginning of the next year, we'll come out with a program called as Smart Clinic 2.0. So computer-aided diagnosis is working on very large information bases, and a combination of standard therapeutic guidelines and machine-inferred therapeutic guidelines will help us in picking up the diagnosis and treating the patient better at point of care. Uh, so the other part which we are working is on dictated diagnosis and prescription. Like when you are using some programs like Docon or Exxon, you have to type. But here you just speak and the things will be on the sheet. So you don't lose the eye-to-eye contact with the patient, and you are faster. And you don't disrupt your routine practice, because many doctors, they see so many patients so fast. So by using this, they will lose time. So this will help in getting it a little faster. And automated local language translation of diagnosis and prescriptions also will be done, because there are 12 common languages which are used in India. So we are concentrating on those 12 languages initially. Then tools for the practice, like integrating Google natural language and dictation technologies in IP. That is your Siri and Google Assist that will help us in doing that. And we have already that program called as IPEN in place, which had gone into limbo 2 years back because of some politics, but now it has been reactivated. Then clinical informatics. Now it will give us improved quality through more timely and more complete and better organized information delivery to the healthcare provider. Higher productivity by structuring patient care with piping of STGs and thereby reducing practice variations. And facilitation of research, that is mainly clinical research, because you'll develop your own data, education, quality improvement and outcomes assessment and strategic planning, and linking the data with administrative, especially insurance. You can come out with some, once we have data, you can come out with some insurance products, like in example in cancer, you spend lakhs for diagnosis and lakhs for treatment. So usually patients don't go for it. But when you have a data, an insurance company comes with a product where you have to just pay 1,000 rupees a year, and if there are 100 million patients which we see in a year, they register, then you understand that in 1,000 rupees they can get diagnosis and treatment done without any problem. But at present it is not there because we have no data. And providing the statistical power to address previously unanswerable questions. Now, public health governance, how we are acting on large scale EMR and prescription data feeding will lead to predictive personalized healthcare patterns that show up the special incidents. And as Indian doctors increasingly start using EMR systems, National EMR Department enables deep and large epidemiology data, which we can use as artificial intelligence engines to find amazingly new applications for Indians. So very important thing is that we should have our own data, and that will be helped by this particular product. Now, IIP is in discussion with NSDL to create a national EMR depository. They are going to come with national health card, and IIP is going to join hands for pediatric patients. And national EMR repository and associated healthcare use creates the scaled up data sets needed for artificial intelligence built for Indian epidemiology. Now, IIP's IPEN system is created to solve these problems, and it is being done on. So mostly by first quarter of next year, we should be ready. Now, what's the future of pediatrics? Now, beyond smartphone and sensor strategies, machines are being used and trained for data, collecting data, and then diagnose some common diseases based on the patterns of symptoms and the signs which are fed to the machine. And training and research, it is definitely general medicine is learned on the web. This is how the classrooms of the future will look. And libraries of future, the content creation by 3D printers and digital doctor. Rise of machines. Initially, artificial intelligence came in, and then your machine learning started, and now we are going into deep training by using various layers of neurons. So I'm looking at waves. The first wave of 2015 to 2025, which we are in, where we use technology for practice automation, point of care diagnostics, and academics like online discussion forums, case presentations, and digital data generation. The second wave, that is 2025 to 2035, treatments will be driven by artificial intelligence. A new generation of therapies will come in, and complete health detail of every child online, and adequate technology-based referrals will be done. And the third wave, that is 2035 onwards, autonomous machines that will perform almost all the human specialties do today. Of course, there will be always a human expert to approve it, and pediatricians will continue to perform the most important role of overseeing. And this will be the reality from 2035 onwards, making the treatment more easily available and affordable. But we have to definitely reinvent ourselves every 10 years to remain in practice. Disruptive technology, now and tomorrow, practice skills on virtual simulation. Now we know simulation labs are already there. And then of course, 3D printers will help us in developing prostheses and so on. And then FDA has given green light to RP Vita Hospital Robo, where Robo will take rounds on your behalf, and you'll get all the information sitting somewhere in your house. And typically in ICU, patient will say, I can't see you, something like that. Then there is patient facial recognition, by which you can definitely pick up some genetic disorders or things like that. So here, for example, face to gene. So a face is sort of scanned, and there are certain spots which are recognized, and then the real photo is put on that, and then it will pick up the diagnosis of various genetic disorders, and that makes things very easy. And so many culprits and noisemakers are being caught by this facial recognition. So identifying facial phenotypes of genetic disorders using deep learning is known as deep gestalt. Then future, artificial intelligence, machine learning in dysmorphology, 3D images, integration into NGS data analysis tools, photographs added to genetic test requests, and recognition of new syndromes by learning the patterns. And it is not going to replace a dysmorphologist, but will be an additional diagnostic resource. Areas where digital technology has made an impact in the healthcare: big data collection. Digital technology allows getting big data in minimal time. Data collection allows healthcare policy to stay on top of cutting edge techniques and trends, and big data creates systems to better identify risk factors and recommend appropriate preventive or interventional therapy. IIP's practice management system with electronic medical records is online and will be available next year, as I told you. Then, of course, we have faced during COVID time telemedicine and teleconsultation, which is very cost effective, convenient, early diagnosis, helps to quickly determine who needs emergency assistance, and helps maintain minimal physical interaction during COVID pandemic, and can be used to provide education and training. And I was talking about this IIP NSDL e-governance initiative, where we'll have audio-visual telemedicine solution, one-to-many familiarity, just better communications, scribes, specialist opinions, self-assessment tools, patient education tools, telemedicine clients as platforms for as measurement and monitoring devices, existing of field products added and available from April 21, which I had written last year. So now it will be available April 2022. And this is a small video, but I'll just skip. And now at present, what specialized services we have on IIP NSDL platform is Smart Clinic 2.0. We have nutrition assessment and advisory program, which enables clinics to conduct nutritional assessment and deliver sustainable nutrition solutions. Behavioral and neurodevelopmental enables clinics to prescribe developmental needs assessment and program to special needs children. And catch pediatric cancer, where we know that 70% of the pediatric cancers are treatable if diagnosed in time. So enables clinics with capabilities of early detection and diagnosis of cancer by looking at red flag signs, and spot inborn errors of immunity, which enables again to pick up those inborn errors of immunity. And specialized devices are like, we are working with Israel University, as I was telling you, Cape Medic Smart Inhaler, Cape Medic Smart Spirometer, and track system with Cape Medic mobile app. And this is where you can get PulmoScan, a smart portable airway assessment device that performs spirometry on tidal breathing of patients. Then we have HD Stat, that is intelligence with PCG and ECG functions, which gives cardiac insight at the point of care. And of course, improved lines of communication we have using this platform, and you can go beyond geographic borders, which is possible by doing teleconferencing. And online education, we know that the IIP platform, what it has done. And we had certificate courses, live classes. Now we have Center of Excellence on ICP, that is Indian College of Pediatrics, where I am in charge. And there we'll be doing all those digital courses and certificate courses and diploma courses if possible, if government allows. Then we had e-pedicons and pediweeks last year, which everybody has seen. And then point of care technologies for every pediatric clinic under IIP Smart Clinic 2.0. Phase 2 is already going on, and phase 3 will start in next month. And by February, March, it will be going nationwide, where every pediatrician will get a software with Android phone and a tab, and they'll be taught to how to pick up those red flag signs and feed into the data. And also they will get, along with that, their OPD management system and other things. So you don't have to buy those Exons and Docons and so on. So to conclude, overall digital technology has transformed healthcare, and this transformation is expected to continue in the years to come. Artificial intelligence, machine learning, deep learning, blockchain, healthcare mobile apps, wearables, and many other such advancements will change the future of healthcare. And as long as healthcare organizations and healthcare professionals keep their minds open and create the required infrastructure and systems, there is no saying how far digital technology can go in healthcare. And take-home message will be, digitizing office practice is an evolution and not a disruption. Because of COVID-19, moving into digital age very quickly was important, and better to adapt them rather than to be left behind. And digitization in office practice is the new normal. And we take pledge to get used to it before it's declared compulsory. And investment in digitization is worth the effort. And we had done some survey year before through IAP, taking into account all the PGs as various medical colleges. Through medical teachers, we asked some questions. So yes, everybody said digitized survey, and postgraduates from different parts of India were involved, and there were innovative ideas, hopes, and dreams. And a step towards healthy children and happy doctors was under. So first question, do you think libraries are necessary with information available at fingertip? Many people said no. Should we have teaching modules for each subject? Yes. Should we digitize classrooms? Yes. Are you aware of developments in artificial intelligence? Yes. Have you heard about deep learning? Again, people were knowing about it. Medical apps useful? Yes. Can technology replace a skillful specialist? No. And are the labs overtaking our clinical skills? Yes. So symbiosis of humans and technology is very important. Encourage mutually beneficial relationship with wherein we help machines learn and they improve human efficiency. Despite general paranoia over various forms of automation, technology was best when it is utilized in conjunction with human labor. The doctor in olden era and doctor now. A doctor's touch can soothe, comfort, and convey caring in a way words never can. Despite the rise of scanners, robots, and other new medical technologies, the physician's hand remains one of the medicine's most valuable diagnostic tools. Life is a game in which you juggle 5 balls in air, while work is a rubber ball, which will bounce back to you, and family, friends, spirit, and health are glass balls. Work efficiently and spend time with family and friends and take proper rest. Have best genetic fit, strong culture and business strategy, understand and adapt with external factors, innovate, adopt best practices and be ahead of industry trends and try to be industry leader, survival of the fittest. Thank you very much.
Thank you, sir. Thank you very much. Friends, our next talk is optimizing media for child development. For that, I would like to call Dr. Samil Darwai on the dais. Dr. Samil Darwai is a well-known developmental and behavioral pediatrician. He is a recipient of Rajiv Gandhi Mano Seva Award, founder of Director of New Horizon Child Developmental Center and Research Foundation, and hold different position in Central Life.
In the 20th century, the word parent was used as a noun. However, at the turn of the century, it became a word. So, parenting became an art and a science. The space once occupied by grandparents, uncles, aunts, and cousins is now filled by Facebook, Instagram, and WhatsApp. Try hard as we may. We can't turn back the clock. To guide us this technologies, we have with us an eminent speaker, Dr. Samir Dave. Over to you, sir.
Lunch will be served. This is before 3:30. Please go and have a lunch. Those who wanted to have the lunch. There is no lunch break,
But there is lunch.
but there is lunch.
Good.
But I am sure lucid talk of Dr. Samir Lalwai, nobody will go for it.
Bukul said, machines cannot replace person. Loaded it did work, so I had to carry a pen drive. Okay, without this also. Okay, thank you so much. And good afternoon, respected President of IAP, Dr. Bakul Barik sir, respected office bearers of the Indian Academy of Pediatrics, organizing chairperson and secretary and office bearers of this wonderful conference, respected Jayant Upadhyay sir ji, who is the West Zone Vice President and the organizing chair of this conference, organize office bearers of IAP, Maha-IAP and IAP Raigad, all the respected faculty and my dear friends here. Thank you so much for this opportunity. We are going to speak about optimizing media for child development. That was a topic given. I've added an IAPN's initiative. What can we as IAPNs do? Because I'm sure we've heard enough about the issues of media, and you have Dr. Dabadkar has been speaking about it. Dr. Ganguly has been speaking. So many of us have heard that. So I'm not going to go into the typical scare mode. I'm just going to explain some of the initiatives that we can do as IAPNs. So just to begin with, some of the cases that we have seen at our center: 14.5-year-old girl brought for behavioral academic concerns. She was an avid blogger, very concerned. So literally, to tell you, the mother was saying every evening, by the time it's been a couple of hours that she's put her latest post, she used to get very anxious कि कितने likes आए हैं. And that used to actually make her do all kinds of silly things. She would get anxious, she would have breathlessness and all those things, and totally demotivated from everything else, worried about academics. And we had to spend about 3 to 4 months trying to counsel her to get out of this addiction. Another 12.5-year-old child brought for behavioral concerns. Again, excessive screen time, social media usage, video gaming, meeting random people. And parents said, ये कोविड की वजह से हमारे फैमिली का बहुत नुकसान हो गया. So what was the नुकसान? That suddenly हमारी लड़की बड़ी हो गई. That was, those were their words. तो क्या मतलब? So this girl got onto Instagram through a cousin who was above 16 or whatever is the minimum age. And she was chatting to another boy. And one day she left the house to meet, that's from Goregaon. She went to Babulnath side. And fortunately, the parents got through the cousin and they found out and they reached there. And they said that boy was a nice guy because she had told him she's also 18 years old. He didn't know. So he was very cooperative and that is how they could stop it. But the parents were so anxious, they also needed counseling. दाभोळकर साहेब तुमच्याबद्दल बोललो हा मी. ठीक आहे आता मी बोलतो. A 12-year-old boy was brought for behavioral academic concerns. Increase again in the last 3 to 4 years. 7 to 8 hours of online time every day, and negotiating with the mother every day. Throughout the day, I want to watch some more and less. And we know all the other side effects of weight loss and all. So again, we had to gradually wean off the screens. Now we had to restrict the online gaming only to weekends. We had to make a schedule for the child, get him to comply to daily tasks. One of the most important things that we've been doing and found very helpful is getting them involved with household chores. I know it doesn't sound very enticing that today's kids might do it, but if they get the right kind of motivation and the parents in themselves take part in those activities, it's a very good way to organize their skills. This is the important part that I wanted to share. 4.5-year-old child brought for speech concerns, poor interaction, poor response to name call, does not indicate needs verbally, used a lot of neologisms, unable to initiate or sustain a conversation, occasional aggression, not following commands, repetitive behaviors, opening and closing of doors. And guess what then the parents did? The only thing they felt the parent was child was manageable was when she was on the screens. And the parents were very impressed because she could operate all the YouTube and everything, and she could repeat all the poetry that was going on there and nursery rhymes. She obviously met the criteria for autism. We started her obviously on a developmental program, but in addition, we started gradually restricting the screen time for the children. Even within 1 to 2 weeks, with children like this, you will notice some improvement. They won't start speaking or become normal, obviously, but you will notice better interaction with the parents, better response to name call. Echolalia has reduced, and that just led to a term called virtual autism, which next time if Mahesh gives me an opportunity, I'll speak on. At New Horizons, what I wanted to share is for the last 12 years, initially with a pen because we didn't have an automated system, and now an automated system, I personally have written on every child's prescription, no TV, stroke, no screens. And I believe very firmly that has been a very important point. So how does IAP move ahead with optimizing media for child development? Because you just can't tell them to stop showing screens. So the first part is we have to present this information in a palatable form to the parents, gradually work for a change in their behavior, and keep focusing on the outcomes. Giving lectures and talks and making guidelines doesn't help anybody. It's making sure that people follow them. What are the difficulties while they are following them? Counseling them, more importantly, coaching them. Counseling is not a very good word because counseling generally is one-sided. Coaching is very important because you have to focus on the outcome. So what are the common concerns? Screen time, how much screen time is too much of screen time? That's the quantity that the parents want to know. They want to know what is healthy media, what is unhealthy media. They want to know whether there's psychological other impacts of media usage and whether the media young children are exposed to, is it going to help them or is it going to really harm them? Because parents do feel whatever you tell them that there's a great value of media. How do we handle these concerns and go ahead as IAPNs? First, we need to understand the difference between media and screen time, where media is any interaction with the screen, including watching television, content, internet, so on and so forth. Whereas screen time is the total amount of time in 24 hours that the child spends in front of the mobile phone. What that should mean to you is this is a time the child is cut off from human interaction. And screen time is inversely proportional to human interaction. And at New Horizons, what we have seen is one of the most important indicators of autism and how it starts is poor human interaction that the child has. And if that is being worsened by even less exposure to humans at home, because as it is, we've got nuclear families, no chacha chachi around, and plus people go to any extent to even take loans to buy a smartphone for their child. We have seen children about 7-8 months who are put in front of tablets just because they eat faster. But here is a research coming out now. So it's no longer an old man's tale that we are talking about. JAMA, this study published in JAMA did show the association between screen time and children's performance at even 18 months of age. Dr. Sunuma, I'm sure you must have seen this. There's a direct relationship between screen time and sleep duration. And every problem associated with screen, when it affects the child, it affects the child's development as well. So multiple reviews, and again, this study which showed very clearly that a significant association exists between mobile media device use and expressive speech delay, which what we were talking about. And the mechanism is via poor interaction. So how do we go ahead as IAPNs? We need to look at what matters to whom. You can't say the same thing to everybody. Same shoe doesn't fit all. So we have come out now with the IAP guidelines. Now there are two ways to work on this. How do we take these guidelines to the community, our patients? How do we take it to academia and agencies? So very clearly, some of us who are more research inclined can absolutely look at it from a research point of view, because you don't need an MRI machine for it. You don't need any other facilities for it. You don't need a great lab for it or blood work for it. So you just need to look at downloading some templates and looking over a period of time, what are your results? Whereas in the community, we need to work with our pediatrician, work with the parents and children, especially the adolescents, and how do we impact the educational field. Now, somebody used a very nice term, it's not mine, for pediatricians, who said mediatricians, those who are digital advocates and those who are able to get across the key messages. And how do we keep getting this messaging across? How does each one of us who see patients, for whatever reason they come, can we keep a track? And like Dr. Bakul Bhai was saying, it's very important to have data. And maybe the IAP system that sir mentioned can help us collect data on screen viewing. And of course, we liaison with the others who work with children as well. Now, here are the IAP guidelines for screen time in children. And below the age of 2 years, very clearly, I'm sure all of you are aware, should not be exposed to screen time at all, except for live video interaction with relatives, especially during times of the pandemic that we saw. Between 2 to 3 years, the screen time should not exceed 1 hour. The lesser, the better, but always supervised. It has to be the parent who's in control. And for older children, it's very important to not let the media displace other activities. You can't stop the media in an older child. So you have to make sure that they get good sleep, regular exercise, family meals, and there is some time where they are off the screen. And at all ages, the message that we need to get across is for the parents to be a media mentor. Actually, don't just fight, don't use a screen, because no child will listen to it. And co-view the media with your children. So this is what we need to know as IAPNs. What are the messages that we need to pass across to the community? Very important that we are all creating awareness, but it's very important what is alternative. And the key answer is, I tell this to all my parents, the only way you can get your child off the media, off the screen, is by replacing the screen with yourself or any other human being. Gone to the extent of telling my parents, गांव से कोई uneducated देहाती आदमी ले आइए, no problem. At least it's a human interaction for your child. that's better than just letting the child. So there is no other alternative. And I don't want to talk about the parental control and the media control because I don't know much about it. And I don't know how much useful it is, because I suspect children are much more smarter than us when it comes to hacking and breaking through all these systems. Simple issues like family skills is establishing zones. So there can be no screen zone, no screen time zone. For example, a particular time of the day, no screens. Lunchtime, meal times, no screen. Screen free areas in the house or zones in the regions in the house, like no screens in the bedroom. There can be days where you are, it's like a digital fasting where you don't use, like upon upas karto, so you don't use screens throughout the day at all. It's very important to link this to nutrition and exercise and play, because every parent will listen to you when you start speaking about nutrition, and that's where you can slip in this message. Peer support is very important because parents will come and say that his colleagues and friends are all using and they are aware about this so and so cartoon. My child is not. So is he going to be left behind? So we came up with this idea where we got a bunch of 6 mothers together. Like society mein, Bombay complex, nobody has relatives or anybody around. And we suggested that each mother bring all the 6 children to her home for one evening or half a day. So she can take her off for half a day. And unke ghar mein, whatever they want to do that day, they can organize some games. Unke ghar ka khana. And Mumbai typically there is one Bengali family, Gujarati family, North Indian family, so on and so forth. So the child gets exposed to all that kind of food one day. Then, and the other mothers are working. The next day, all these kids go to the other mother's house. The first mother goes back to work. This mother is off work. And every mother needs to take off or half a day off only once a week. But look at what the children get. It's not only that they are off screens, they get to learn from 6 mothers. And this is the best kind of intellectual stimulation that they can get rather than watching that same stupid thing on YouTube again and again. So these are the things that we need to do. Of course, rewards and recognition. Then we had a small kind of a Zoom call where we kind of felicitate all those mothers. I didn't have to give them any money or something, but just some virtual pat on the back also helps. And then these are the influencers who write about it or who blog about it or go out and talk to others, and the advocates. Well, about education, we all know that this is what the children say, that well, the school is now inside the phone, not the other way around. So it's going to be important to understand that there will be educational screen time. And it's extremely more important to say that let there not be entertainment screen time separately. Then the entertainment has to be on the playground now that COVID is off. Media again is very important, and I'm not talking about what the channels do. It's what all of us can do as part of the media. All of us need to be very, and I've been Bakul Bhai was to Vivaswan's videos. I've seen so many other pediatricians, younger pediatricians I've seen who are now getting out and putting out a message to their colleagues about what's to be done. So this is what all of us need to do. This is just a small thing that I do. I just write a column for a Marathi newspaper, but the number of people who read it, and I'm sure Hemant Joshi and Archana Joshi ma'am are the 2 people who can tell you the impact that it can have on the society when you do it multifold. Dabadkar has come out with videos, and all of you do so much amazing work. This adds to the pressure on everybody when we do this advocacy on various people, because when they hear the doctors talk about it all the time, it's very impressive, and they do tend to get pay attention to it. Otherwise, they're only hearing a $1 billion industry of the media, which is just advertising itself. With the government as IAPNs all across, we work in Raigad, somebody works in Gadchorli, somebody is Chandrapur. We only convince parents of children with special needs to cut down two things. One, to cut down media usage, and second, to look at sleep and to increase the time that these children sleep, especially, get their cycle right. Not no sleeping during the daytime, but sleeping later in the night. Very often the key message that to give them is what time should the child be woken up. And at our center, we don't tell them to make your child sleep at that time, because you can't make anybody fall asleep unless you are a boring presenter like me. But you can definitely make a person wake up. So the key message to give the parent is wake up your child at a fixed time per day. Don't let him sleep throughout till about 8 p.m., 9 p.m. Automatically the child's circadian rhythm takes over and that works. But if any problem, consult a mental health professional at the earliest. And all of us need to act as a role model for healthy media use. So thank you very much for a very patient hearing. Thanks, Jan Bhai. Thanks all the organizers. Thank you very much. Thanks to the chairperson.
Thank you, Samar Bhai, for such a mesmerizing talk. I wanted to share one experience. When I told a child that you don't see you decrease your screen time, so mother is to complain that he sees lot of mobile. The child says, "I तुझं WhatsApp पहिले कमी कर, मग मला सांगायला." And there is another instance when we used to repeatedly tell on the advice of parents, घरी दुसऱ्या दिवशी आई सांगते, "सर हा सांगतो डॉक्टर बदला." Thank you again.
Thank you so much. Just wanted to mention acknowledgement of all my team members. Many of them was fellows helped to make this presentation as well. Thank you very much. Thank you so much. Thank you. Thank you.
The next topic is empowering community health workers for reducing industry prices. Dr. Neeman Mohanty sir, request you to come on dais. Friends, healthcare workers include doctors, nurses, paramedics, and many more. These sectors are educated and have platforms to voice their misgivings, while the very backbone of our rural health projects are ASHA and Anganwadi workers. They are the bridges that connect the society and medical services. They tend to have more responsibilities and are very little authority. Dr. Neeman Mohanty sir will tell us how we can invest in them to reach better results.
Dr. Neeman Mohanty sir is a professor emeritus of pediatrics at the MGM Institute of Health Science. He is also member of Academic Council and advisor, MGM University of Health Science. He is a former DIG Medical and Chief Consultant of Pediatrics. He is a recipient of Meritorious Services Medal from President of India and many more in his CV. I request sir to start.
Friends, good afternoon. My colleagues and the office bearers of IAP, I am grateful to the organizers to have given me this opportunity to stand before you. So this is a talk I have compiled from our own research work in Raigad district. So this is no hi-fi. On the ground reality, what we saw and what we propose, we're bringing in here. This is the institute where I was trained and my place of work in MGM. This slide we're very much familiar with pediatricians. We started, this country rather started his journey and these are the causes of neonatal mortality, which as controllable, many of them, the sepsis, the birth asphyxia, preterm, these things, diarrhea, this can be controlled. If we work in this direction, the single digit neonatal mortality will not be a distant dream. 2/3 of IMR is contributed by neonatal mortality. It is known that 90% of deliveries of SBAs trained on 41% of the interventions. If you can do that, you can reduce the neonatal mortality by about 18%. This is a slide come in the Lancet recently, we're showing that pointer. Okay. So here you can see the neonatal mortality picture in India in 2000, 2010, 2017, and right side is the under 5 mortality rate. The pictures are similar, or the profile is almost similar. It is contributing, influencing the under 5 mortality also. So issues in rural areas, come down to our rural areas. Our primary health centers, 100% deliveries are being institutionalized now. Deliveries are supposed to happen in hospitals. The only one nurse or a NM is posted some places. They are damn tired throughout the day, working day, and a lot of records they have to maintain. So in an odd hour and deliveries come, practically who attends them? That's a real difficulty. All delivery should be considered at a medical emergency. Immediately, we are supposed to have one trained person for neonatal resuscitation at each delivery. It is only said, but it is not being done. 80% of that Bharat, where it is not happening. But the government says that is not possible to train our staff. We have to withdraw them from our normal duty and train them. It's not possible also. So we will do that. The ASA who is accompanying this mother to the hospital is not supposed to enter the labor room. She is available, but we are not utilizing her. So why can't we train her? No, they say she is not trainable. Her efficiency of education is not that much that she is not trainable. We have proven that she is trainable. Moyes will agree with me. The type of people who are using in our nursing homes or say clinics in the rural areas, they are only all this ANM person or the DICE type people, and they are picking up. They are being trained by a repeated use of this technology in our own efforts. They are getting trained. So why can't the government formally officialize it and train the Anganwadi workers or the ASA workers in that direction? These are the 5+5 targets. If we achieve neonatal mortality in single digit. 5, the blue one is for the mothers and the green ones for the babies. Antenatal steroids, then skin to skin contact, that's the kangaroo mother care, and breastfeeding, then breast crawl. If it's associated with combined with breast crawl, the result will be better. Linear cord clamping. I will come down on this about these 5 things, and 5 for the neonatal for the babies. So the NRP for all the hospital staff. Safe oxygen in a controlled manner should be used. Use breast milk or express breast milk. Kangaroo mother care. Infection control. This will bring down the neonatal mortality to single digit, has what Kerala, even Mizoram has done it. So for this, we thought about this, some programs, some projects in the MGM, and this is a place in Budhani. And then we had developed 5 projects that is based on this our thrust areas. These are the neonatal resuscitation at birth. Can we train our Anganwadi workers and ASHA workers and compare their output with the trained nurses? We saw that. What I'll show you. Then the home care of preterm babies or low birth weight babies. 50% of our low birth weight babies die out after their hospital before they see their first birthday. Can we do something about it? That we have seen that. I'll show you it. Actually, this number of slides are more. I'll hurry up these things. Then breastfeeding, complementary feeding, breastfeeding, how it is working, and when it is combined with the breast crawl, I was surprised to see the difference in the satisfaction in the breastfeeding and the growth and development. We have assessed for 1 year. There's a lot of difference, and only the death was 2%. Where the NASA level is 50% that they say, and the control is about 20%. I will show you. This is the first. We have to train them and retrain them because they forget. So we train them every month. I took a test for the previous training, trained them, and sent like that. We kept on repeating it. The outcome is super. It's the first study training the ANM, GNM, and ASHA on the NRP and care at birth, and saw that these are the things we had structured the training program. and the not only the theoretical but also skills also. So these are the issues on which detailed structured program was developed, and this was validated by applied pilot studies and applied on them. So there were 366 subjects, 243 ASA workers, and for the control we took trained nurses 30 and ANMs about 93. Their education level, basic education is almost same, ASA and ANMs. But you see their knowledge about the neural resuscitation, obviously the ANM had a better knowledge and ASA had no knowledge. But the outcome is, you can see that the blue ones, they are the basic knowledge, and on the improvement of post-test and red, they are almost similar in ANM and ASA. So they are very much trainable. This is the skill we have shown. The first, the blue one is for the ANMs, and then the see the improvement after the training. Similar, when the ASA, they started almost zero, but they reached the ultimate training ability was almost at the ANM level. So they were nowhere less. They are very much trainable. Now the second was the facility-based newborn care. We compared the ANMs with the trained nurses. This was conducted in Alibag, Panvel, Mahad, Mangaon, these areas. I'll rush through the slides. The first day, initially 3 days we trained them. Then after 6 months and 3, then after 1 year, these are repeated. And these are the results, almost they're comparable. You can see the bars. Initially it was lesser, but they were comparable. Both of them are performing in a similar manner. You can see these test scores, neonatal resuscitation scores are similar, and specific neonatal mortality rate in these causes, disease-wise mortality we have calculated. You see infections decreased, others almost similar, but in that particular area, the infant mortality reduced very significantly. So the third one, we took as low birth weight babies. We trained the mothers at the discharge from the hospital how to take care of the babies at home, and followed them every month at their home in their own environment. We trained them and retrained them. And the controls are, because the babies, low birth weight babies born in our hospital, record were taken out, and they were compared with the growth and development compared with the other the prospective group subjects. So what we saw, these are the aspects on which they are trained in details. Priority on managing low birth weight babies. We had about 1781 deliveries in 2015, that is our control. But in prospectively 2016, all deliveries, of them about 34% were preterm, but prospective group, the subjects were 21%. It saw, you can see this, the mean knowledge score increased in the pre-test and the post-test bar one. It was a lot of difference has come. It is between the pre-test and post-test for the mother's knowledge. These are the birth weight. These are the low birth weight babies. That's why the normal WHO growth chart is not applicable here. We had used the CDC chart, which is, you can see all these babies were growing much below the 10th centile of the normal growth chart. So it's a centile growth, not a, you can see this. But it's low birth weight babies slowly picked up after 6 months. When the complementary feed was introduced, they picked up. But they improved, but they did not, the catch-up was not there. It is said that catch-up occurs not before 2 years of life. So we were not expecting that. But still you can see none of them at least we lost because of the failure to thrive or infections. This is about the length, similar thing. They were growing and they are showing steadily growing. This is head circumference. And this is I'm showing the control simultaneously. So on other groups like 1.5 to 2 kilo and 2 to 2.5 kilo. I'm not showing all these data. And their DDST, when we did, they achieved milestones, that is the motor, language, and fine motor, personal, social, in a higher numbers than as compared to the controls. Surprisingly, this was the achievement. This retrospective group, we could not test, but by questionnaire only, we recorded their, from the mothers, we recorded their milestones. So illness in infancy, you can see the white one is the control group, that is a retrospective group, and the green one are the prospective group. So there is a study group. So you can see the difference. The infection rate was very, very high in the previous group, but the intervention group, trained group mothers, so these were very minimum. You can see the hospitalization of the babies. See the difference in hospitalization, different this first quarter, second quarter, third quarter, fourth quarter of 1 year. You can see the difference in the hospitalization. Similarly, the mortality, if this is intense intervention group is this, but the retrospective group, the mortality was high. So there is a difference in mortality also. So here, the imparting knowledge and skill to mothers, low birth weight babies at home environment was key to their growth. Breastfeeding and breast crawl. Surprisingly, the breast crawl group, I don't know why was the difference. Only one breast crawl to start with. And we found a lot of difference between the output. You can see I'm not going to the details. You can see the breastfeeding contributes the maximum to reduce the under 5 mortality. Breast crawl, no need to tell this group how to do a breast crawl. This is photo is wrong. This should be done in different manner. So they have seen the mean score of adequacy in breast milk between the breast crawl plus breastfeeding group and only breastfeeding group. We are not given breast crawl. A lot of difference. See the difference. This is visible. And only one breast crawl. That is not going daily breast crawl, no. But they are making the difference. It has to be explained. And these are the details by day one. What we found that this baby who are not losing weight, but 10% we say it is allowed, 10 to 20% they are losing first 3 days. It was not happening in the breast crawl group, but it was happening with only breast feeding group. So that initially they had an advantage and the growth was very good. You can see this growth. Clearly the advantage of breast crawl group was going ahead of it. This is normal breastfeeding group. These are the boys and these are the girls. You can see the difference all throughout. And successful exclusive breastfeeding till 6 months of, you can see this is a very high with the breast crawl group and only breast alone breastfeeding is a little lower, 50% only. Common infections. So the last one is the delaying the umbilical cord. Our obstetricians are very busy, high-fi obstetricians. We should take them along with us. They do not have any time to delay cord clamping. So cut the cord and go for the next delivery. That's the kind of thing. So to bridge this gap in our hospital, we said we'll milk the cord. Like it is previously in 1950s also being done. But nobody does it now. So we wanted to, so there is care. So it will call hypervolemia, it will show hyperbilirubinemia. These are all myths which are proven. We have a different group with preterm babies also. There is, it's workable. So no problem. I will show you. These are the, you have to, it is not only once it is not done. You have to churn it and release the proximal so that the placenta refills the cord. Again, you tune it, do it 3 times, quick successions. In 30 seconds, you can do that. And rather than waiting for 3 minutes, they are reluctant. So it is in the nursing domain. It is not being practiced. You train them and the nurses can also do it. And it is being done, it was done by nurses only. So this is, I'm not going to details how milking is done, what is the advantage. We all pediatricians, we know it, but we don't do it. We should do it. You can see the Apgar difference. It is actually significant, the difference Apgar score. So these people will lead least neonatal resuscitation if you do the milking. SpO2 There is advantage. You can see this statistical difference. Temperature control. There is a significantly control is there. So baby has a there is no chance of hypothermia in these babies. PCV, they are scared. There will be hypervolemia. There is no scare. You can see this, and this significantly that difference in the PCV. But I will show you weight in neonates is significantly different. Newborn weight for the next up to 3 days. Then you see the PCV in the intervention and control group, there is no dangerous sign. It is going little higher, and there is no dip in the hemoglobin like we expect that the physiological anemia, it is normal, we presume it is normal. It is not happening, the dip is not happening. This is without milking group. This is milking group. And it is continuing till 1 year of life. For about 12 months, there is its advantage is going on. Weight, that is the advantage. Weight gain is better for 1 year. Only one milking, but see the difference it is causing. Length, in the later part there is little advantage, but it's not being attributed to our milking. But see the brain growth, there is significant difference. Weight and head circumference. I would like to invite your attention here. The head circumference is higher than the control group. Why? The myelination is better. Maybe some stem cells is going, I don't know why. The myelin content, they have been estimated in other studies by SPECT-MR, the myelin content higher than this group which have been milking. See these head circumferences, and all these are significant. The difference are significant. Less than 0.001. Myelination, this happens. And when we did DDST in these babies, there is a gross motor language. You see the passing was higher in this milking group, and the failure was not as compared to less as compared to the non-milking group. The person social, all these sectors are there. So friends, the in situ stripping of the umbilical cord can safely replace the delaying of the cord clamping, if for a convenience to say. And this is safe even for preterms. The Apgar is better. There is less intraumbilical hemorrhage, the NEC, anemia, hypothermia, and whatnot. Helps to weight gain better, as you have seen. Then it should be universally practiced, and we should take our obstetrician friends into confidence to practice it. And these are my students who have done PhD under me. So these are the people who have done this work in different parts of Raigad district. In my hospital also, see milking of the umbilical cords was done in our hospital-based study. And these are my colleagues, Dr. Vijay Kamble, Dr. This is Prabha Desila, this is Mary Mathu, these are nursing faculty, and these are the students from nursing side who have done this study. Thank you. This is from away from Dodani. You can see this beautiful place. Thank you very much.
Thank you so much, sir, for this wonderful study. And its simple measures can have such great outcome is actually proved from your studies. So thank you so much, sir.
We want to take it as a Raigad model.
Why not?
Model.
Sure.
So this brings end to this session. Yes, sir. You have some question?
No, that. No, we didn't see that. That's how I have seen. Police at may find normally you do PCV only. So we have not seen that. There is no difference. You can see the advantage there. Full cord. Full cord. Yeah, from placenta to descend quickly. Do it and release the proximal. Like this. Turn is like this. Then you will release this first one. So the gets refilled from the process again. See, another 20 to 30 ml of this then another study only. No problem. And now lot of papers are coming there. They are not doing it. That's why it is recommended, but they're not doing it. And this can substitute permanently, and there are no plea to say no to it. And we will not ask them. Even our nurses or pediatricians to do it. That is a wrong one.
Thank you, Dr. Nitin Mohanty, sir, for such an excellent talk. We would also like to thank both our chairpersons, Dr. Poona Kurkure ma'am and Dr. Sunita Inge ma'am. I would like to announce that there won't be any break. The academic session will be in continuous flow. Lunch will be served only till 3:30 p.m. You can find the food court at Nirvana restaurant just after the reception on the left side. While turning back to Hall A, also do visit the trade exhibition and stalls. We would also like to announce that inauguration ceremony of the conference will be in the evening from 6 p.m. Request all to gather in Hall A for the ceremony.
Friends, our next session is a panel discussion and topic is discussing sexuality with the teens is of great importance to parents as well as a pediatrician. For this, I would like to call panelists on the dais, Dr. Swati Ghate madam, Dr. Sadachar Uzmalkar sir, Miss Samindra Sawant, and Dr. Shubda Kirwadkar will join from USA. I would also like to call moderator Dr. Jayan Pandarikar sir on the dais.
Gone are the days when intimacy on silver screen were depicted by two flowers touching each other or thunder and lightning. With the advent of internet, teens have free access to all information they see. I remember two acts that appear on television. A father tells his son, "Beta, you are now 14. Let's time to talk about the smart plans. Okay, Dad, what do you want to know?" Also, the girl watching TV with her mother, while an intimate scene. The mother bends down to pick up something that hasn't fallen down. Girl tells her mom, "Mom, the scene has changed. Time has changed. Things have changed. It's time for the older generation to scale up their preparedness." Who better than Dr. Jayan Pandikar sir to acquaint us with the ways and means to bridge the gap?
Dr. Jayan Pandarikar sir is a president of Mahastra IAP 2020. He is a director of Sushant Maternity and Children Hospital, Amravati. The panelist for with us is Dr. Swati Ghate madam. She is working in Jaipur, Rajasthan as a pediatrician and child adolescent specialist. Samindra madam is a mental health expert. She is from the Dadar. And Dr. Shubda Kirwadkar, she is joining from US. She is a regional head of AHA. I would like to request Dr. Jayan sir to start his question.
Well, thank you organizers for giving me this opportunity. I was asked to talk some interesting topic on adolescent medicine. Okay, Himan Bhai said, "Kuch to bhi aisa ho jana chahiye." Then I thought, the sex is the only word where everybody is all means interested to know. Rather, sex is a word, it is more Googled at all ages, of course, about 8-10 years of the age, even at the age of 50-60 years. So then I thought, why not take a topic regarding discussing sexuality with teens? Quite often we talk about sex, sex education, sexual identity, we talk of sexual orientation, gender, everything. But very rarely we discuss actually sexuality with the teens. Even in our office practice, when patient comes to the complaints, Dr. Sahib thoda discharge hoto hai, kutun bathroom cha jagavaron ka? Like this. Dr. Sahib, tithe dukta hai, kuthe, tithe dukta hai ka? We never utter a biological terms. Does it pain at a penis? Does it pain at a vagina? Does it pain at a breast? We never talk of biological terms is because we ourselves are not prepared to discuss sexuality with the teens. And that's why I have chosen this topic of discussing sexuality with the teens. Another thing is now sex is a very just small word. It has a different meanings. We all know it is used everywhere, even in Bollywood. ये कमीज बहुत sexy लग रही है like that. So this is such as a word. So sexuality has a multiple dimension. It has a physical, mental, social, economical, biological. You name the word, and it has all sorts of dimensions are there. And so then I thought that we should discuss this topic. That is because quite often we talk of sex education. Quite often we talk about family life education and sex education together, because discussing sex in the schools, rather it's a taboo. Because teachers say, "Hum kaise discuss karna chahiye?" And parents say, no, probably your teens, they will practice it. So please don't avoid using these words. Even when the teens, they ask something about that to the parents, parents say, "Ha, theek hai, baat bhi bataungi tumko main," like that. So every time we avoid discussing this with teens, and that's the reason why they face the sexual abuse, why they land up in the sexual abuse and other problems and teenage pregnancies. And that's why I thought we should take up this topic, discussing sexuality with the teens. And of course, for this, I have expert panelist, Dr. Shubha Madam, who has joined virtually from Nagpur, Dr. Swati Ghate, my friend, my batchmate, who has joined from Jaipur, and we have Dr. Samindra Sawant, who is clinical psychologist, joined from Mumbai, and Dr. Sadachar, who is a secretary of Maharashtra IP. So let us begin with these terms. I asked my panelists, quite often we discuss these terms. So can you please quickly tell me about these terms? My question is to Dr. Shubha Madam. Dr. Shubha, can you please tell me what is sex and what is sexuality?
Yeah, hope I am audible now.
Yeah, please, go ahead.
Yeah, so thank you Mahapedicon and the team. These terms, as Dr. Jayant has already said in his introduction, sex and sexuality have to be properly understood by all of us, because since this subject is taboo, many times we do not understand the various connotations and dimensions of the term. Now, sex actually means the physical, anatomical, physiological differences that people have as male, female, and intersex. So it's a term which is assigned at birth by the doctors to the baby, and it represents the physiological, anatomical, genital, chromosomal differentiation between male and female. But remember, though we take this as a biological binary, there are many babies who may have some differences in their chromosomal markers, and therefore another term which is important is intersex, where there is difference between the physical anatomical genitalia and the actual chromosomal sex. So of course, all of us know this, but sexuality, this is a term which has very wide dimensions. And if I need to introduce this term in terms of circles, I can do it in 5 circles. So first circle is about sensuality. Sexuality includes sensuality. That means knowing, being aware of your body, being comfortable with your body, and also knowing how your body image is to yourself and to others. Sexual intimacy is the ability to experience emotional and physical closeness to another individual. It includes caring, sharing, loving. It also includes risk-taking and vulnerability. Third term is sexual identity, which of course my other panelists will go into detail what is the gender identity and role. Fourth is sexual health, which includes the reproductive care, hygiene, and all the consequences, physiology, anatomy of the reproductive organs. And finally, sexualization. It means how your sexuality is used to manipulate people, to control people. So this includes rape, incest, and all the sexual abuse that we talk of. So sexuality is a wide term, and we are going to discuss all these angles today.
So
thank you.
Thank you, madam. So the sexuality is wide term, which includes everything physical, then the biological, then the social and everything. So this, it's a very, very wide term. And so when we are discussing regarding sexuality, we have to cover all these aspects of the sexuality. Now, my next question goes to Dr. Swati. Swati, what is gender and what is sexual identity?
Thank you so much, the organizers, for this wonderful opportunity. Hope I'm audible.
Yeah.
So gender is the social part of sex. Like just now Shubha madam told that sex is biologically determined, but what it implies to the society. So the social and the legal aspect of our sexuality is called gender, and in it is implemented some specific characteristics, some behavioral patterns, some norms, some thoughts, and some expressions that a person who would carry over and when he belongs to a particular gender. So men would have some different things, females would have some different things expected out of society, and that is what defines their gender. Coming to sexual identity, it is the sense of self as a sexual being. It includes all aspects of sex, like including the gender identity, the gender roles, the sexual orientation, the thoughts that the person carries regarding his own body in context of sex, his desires, his drives, and anything that is pertaining to his particular sexual domain. So it is an all-compassive term, and it is a part of the identity that the adolescents form during their growing up.
Okay. Now my next question, Dr. Samindra, madam. Madam, what is sexual activity and what are sexual drives?
Good afternoon, everybody. So Dr. Shubhada and Dr. Swati have already explained to us entire context about how we look at sex as a physiological or a biological orientation or process, as well as the social aspect and the emotional aspect of it. Sexual activity, as we all know, is about how we express our sexuality. It could range from, of course, the ultimate being the sexual act, the sexual intercourse. But before you reach there, there are many other ways in which people express or manifest their sexuality, which could be ranging from right from watching people of a certain sex or gender that they are attracted to, usually heterosexually the opposite sex, or in case of people with alternate sexual orientations, it could be the same sex, to watching these people, to imagining, fantasizing. These are also parts of sexual activity. And moving on to experimenting with their own bodies, which includes masturbation, which includes watching exciting, titillating pornography, watching other people, and moving on to then experimenting with a sexual partner and engaging in the sexual act. Sexual drives are, of course, driven by the various hormones, the various chemicals in our body. And as medical professionals, you all are much better equipped than I am to really know that there are specific hormones that create the sexual drive, which is the desire to engage in sexual activity. A major part of the drive is, of course, biologically triggered or biologically driven, but there are a lot of emotional as well as social triggers to the sexual drive.
Fine.
So I think that in a
Yeah.
nutshell explains.
Dr. Sadachar, could you just define what is sexual orientation, what is sex education in two sentences?
Yes, actually, this is difficult to define in short. It's a very big topic, but in short, there is a heterosexual, one is heterosexual orientation and other is homosexual. And in heterosexual, of course, there is a...
It can be bisexual also.
Yeah, that can be bisexual also. But a heterosexual is obligatory attracts to the opposite sex, while the homosexual attracts to the similar sex. In that, it can be gay, lesbian also. But in bisexual, there is a both ways. One can attract to the opposite sex as well as the similar sex also. So this is about sexual orientation. about sexual education, sex education. This is definitely much needed topic in our school education, also in educative system also. But for sex education, it is a basically a wide aspect of giving information regarding the various aspects of the sex and its moral values, also the social stigma, and also there are many other facets for the sexual education.
Okay. So friends, sexuality is all about your sex, your body, gender, orientation, drives, activities. So that's why sexuality includes each and everything. So before I proceed with the discussion, let me tell you that we are going to discuss who will discuss the sexuality with the teens, when to discuss, how to discuss, where to discuss, why to discuss. So under this format, we'll discuss this our panel and discussion, and then we'll go with the scenarios. Okay. So I request all panelists, please brief in on your answering, because we have so many cases to discuss. So now, why to discuss? We all know this is a statistics by the CDC, American statistics. 10% of the sixth grade they have had sex. 50% of all the teenagers they have had sex by the time they enter the 10th grade. Look at the figure: 70 to 90% of the teens they have had sex by their 12th grade. Coming to the Indian statistics by HS studies, it mentions that teenage pregnancy is almost 7.9% in our country. That too, I think this must be just tip of iceberg. We don't know, because many times they are not reported to the hospitals also, and of which it is more common in 5%, 5.8% they are seen in rural areas, and 2.1% seen in urban areas. And of course, we all know the risk. They are at a risk of exposure to the 25 sexually transmitted diseases, including fatal AIDS. Once again, why to discuss? Almost 1 in 20 of our youth, they self-identify as other than heterosexual. This too large, big figure. Of course, this is statistics from the CDC, American stats. I'll skip this slide. Now, what are the benefits and silent features of discussing sexuality with the teens? I'll ask one by one. The first benefit, I'll ask Dr. Shubha, madam.
Yeah, so as we have seen that sexuality discussion is very, very imperative with the teens, because all of us, all the growing up teenagers have relationships with so many people, and these relationships need to be healthy. So if we discuss the various angles of sexuality, the definition of a healthy relationship is well understood by the teens. So any relationship needs nurturing, giving space to other, agreeing to disagree. There are emotional boundaries, there are physical boundaries. So all these things can be very well understood if we talk about sex, sexual relationships, and the interaction that is therein, the compatibility, mutual respect, trust. These are all angles which build a healthy relationship, and therefore sexuality discussion is imperative to build healthy relationships.
It's a healthy relationship in the family and outside the family as well.
Yeah, both, with everyone.
Dr. Swati, can you please tell me second one? What is benefit? Quick. You're not audible, Dr. Swati.
Yes, this sexuality education can be a good way to teach and carry forward our own cultural values and the values of the family and the society. Because we see there is a lot of turbulence in the society as of now, and also the teen to teen harassment on the sexual grounds is also increasing very greatly. So this is a good way to teach them how to protect themselves and others as well.
Okay, fine. Third one, Dr. Samindra, madam. Please take a mic.
It helps build better communication and more open and transparent communication between parents as well as the children, or any of the adults. It could be parents, teachers, or pediatricians for that matter. It promotes discussion of something out in the open, which gives the children or the teens the impression that this is not something terrible, horrible to be hidden about, but it's a normal part of life and normal part of growing up. So it promotes a healthy communication and healthy interaction between the adults and the teenagers about something which is very much a part of our life.
Last one, Dr. Sadachar.
Definitely, recently the teenage or at any age, the sexual abuse is rising, and when one is empowered regarding the sex and its education, and also about the various aspects of that, definitely they will be more what we call as protected from that angle. And even many times in sex abuse, close ones are related, close ones are involved. So they will be able to know. Many times they shy and there is a guilt in their minds. So that can be prevented with this.
So the main aim is to avoid sexual abuse in our teens. That's why we must discuss the sexuality with them. Now, what are the concepts of sexuality in developing stages? We all know there are three main stages: early adolescence, mid adolescence, and late adolescence, and of course, young adults now we call. So what are the concepts of sexuality in early adolescence? The question is to Dr. Swati.
Yes.
Yeah.
So regarding early adolescence to start with, the early adolescence is a phase of curiosity. The hormones have started surging up, and these hormones are making a lot of changes in the adolescent, also in his sexual thoughts, in his sexual reproductive organs, and also in his emotionality. So he is very much confused about all these things, and he always finds himself, he wants to confirm whether he is one among the all or he is odd one out. So there is a lot of anxiety in him, and he wants to discuss all this sexuality with his peers. They are mostly of the same sex, and he always wants that they should be holding hands with him when he is passing through this turbulent phase, number one. And there is limited capacity for him to interact into a meaningful or relationship with same or opposite sex. So he will go through a lot of pawns and all and confirm that whatever he is doing is going through is normal.
So the important message is that at this age, the early adolescent is more in the phase of exploring the sexual anatomy, and he's more curious to know about the sexual anatomy. Now about mid-adolescence, Dr. Shubha, madam.
So in mid-adolescence, carrying over the curiosity, it goes into exploration, and now attraction towards opposite sex becomes a major part of his thoughts. There is attempt to initiate relationships with opposite sex. There could be some exploration of sexual activity, and there is intense peer pressure in these to conform to their group. That they need to have either a girlfriend or a boyfriend, as it is the tone on tenor right now. So these opposite sex attractions, or actually being able to understand what is my sexual orientation, the process starts in the mid-adolescence.
Yeah, and even they try to experiment it also. Okay.
Yeah, experimentation.
And now my question to Dr. Sadachar. What are the concepts of sexuality in late adolescence?
Basically, in late adolescence, there is a bit of a cognitive maturity. And with cognitive maturity, definitely the hormonal, meaning the surge of emotions are receding. So they are in a what you call it, in a position to come for a committed relationship from groups. That is the main thing, and that can go, that they can say that will last long. So that in late adolescence, these changes will definitely make them more empowered for committed relationship.
So here, basically, he wants to go with a stable relationship. Okay. And lastly, Dr. Samindra, can you please comment about young adults in a word?
It's about experience and consolidating all that experience into forming a more serious, a deeper sexual relationship with a partner with whom they start looking at slightly long-term perspective.
Okay. So this is a very common diagram we every time when we talk about adolescent medicine, then we always see this particular diagram, which tells you that the development of prefrontal cortex, it is late as compared to the development of the limbic system and amygdala. And we all know the functions of amygdala are emotions, aggressions, impulsive behavior, sensitive to rewards, etc. And in the functions of the prefrontal cortex is reasoning ability, impulse control, emotional management, goal and priority setting. That's the very reason why they land into the prefrontal cortex it matures very late as compared to this, and that's why they land into some problems. Okay. Coming to this neurophysiology of sexuality behavior, The same thing is the okay. The same thing I just have mentioned. Now the next question is who should discuss, who should provide a sex education? Okay, we all know who can do this. As a pediatricians, we should do it. As a family physicians, they should do it. And of course, if they are going to counselors, there are nowadays counselors in the schools, they should do it. Then most important is parents. Can parents do that? My question to you.
Yes, of course.
Yeah, but
Empowered
the
parents.
empowered parent is most important. If parent himself is not empowered, he doesn't know the things, then how can he do that? So the empowered parents, at the same time, empowered teachers, and of course, empowered caretakers, they all must do get involved in the sexual discussion. Now, my question, Dr. Samindra, can friends do that?
I don't know about whether they can, but they definitely do that. So major information to friends about sex and sexuality comes from friends. But since we are talking about empowerment here, I think empowered friends and peer education can be an amazing source of information for our teens.
Yeah, because quite often we say that it's the peers who give this wrong information, unscientific information to the children, and that's why they land into these problems. So empowered friends, definitely they can do that, and of course, empower peer friends, they should do that. Now, when to talk about sex with the teens? Can anyone comment? When should we talk about them? Okay. Okay. Is it a one-time moment, Dr. Sumindra? Okay. It's a continuous process. So the whole slide tells you that you should grab that opportunity whenever, wherever, however we get. You should grab that opportunity to discuss the sexuality with the teens. If the child comes to you with these complaints for some physical elements, but you feel that it's somewhere sexuality is involved, you must comment about the sexual history of the sexuality and try to grab those teachable moments and teach them. Okay. The most important thing is that children, they are most receptive about their values at around 8 to 10 years of the age. Beyond 12, 13 years, probably they start their own thinking and they may not listen to you as far as values are concerned. So this is the right age. Between 8 to 10 years, you must try to teach them about your values, your family, culture, and everything. Okay. Now, how to talk about sex? I'll just brief this slide. Once again, try to grab teachable moments. At what age? It is at 10 years, at 12 years, at 16 years. How specific it should be? Then what are the do's and don'ts of this communication? Then what you should all focus on? Focus on anatomy and physiology of the male and female reproductive system. Talk about intimacy and relationship, their sexual intercourse. Just talk about unsafe sex, pregnancy, and STDs. We never talk of that. Talk about sexual abuse, then rape. And of course, we all know date, rape, drugs, that we all know. And most important thing is that we must talk about the medical legal aspects and POXO Act, and we must update ourselves as far as POXO Act is concerned. Okay, this is slide what Dr. Shubda had already covered, that what parents should talk about. They should talk about under these headings: sensuality, intimacy, sexual identity, sexual health, reproduction, and sexualization. So my next question to Dr. Sarachar, can you talk about do's and don'ts of communication as far as sexuality is concerned?
Actually, we need to grab very sensitive moments, that is teachable moments, that is about communication. When the child is or the teenager is receptive for that, that is very important. Other thing is that we need to keep the whatever conversation is very simple and understandable. Don't talk in very scientific or very much complicated words that may confuse them. Other thing is that what are the facts of the life that we need to share with them in friendly manner. And the teenager should be in a relaxed mood in that sense. That shouldn't be a offensive one. In the conversation should be in a friendly way, and it should be taken. The teen should be taken into the complete reassurance and what we call it as in faith, meaning complete faithful manner that we need to communication.
Okay. The most important message is that you should always keep your all communication lines open for a child 24/7. Suppose he gets up at night, I had night dreams. So at that time also, if he asks about sex, please wake up and tell him what is that. So that you should keep these communication lines open all the time for your child. That's the most important message from this slide. Now, what are the myths about sex education? Quite often we say that if you teach sex education in the school, probably they may practice and they may experiment this and all those things. That's why the sex education is always a taboo as far as the school education is concerned in the schools. So what are the myths? There is a no 100% method to prevent sexually transmitted infections. What are the facts, Dr. Swati?
Yes, the fact is that yes, there is a method which is abstinence, which can be 100% foolproof method not to get any STIs. And we can always, in a matter of fact way and in a very convincing way, tell our adolescents what is the importance of adhering to the abstinence.
Right. So the myth is it may increase curiosity and practicing rate. Dr. Shubha madam, what is your comment? Dr. Shubha madam.
Curiosity is many times, yeah. So curiosity is there in teenagers. Of course, it's there, and us or talking about sex helps them to reduce this curiosity, give them authentic information, and answers most of their questions. So in all the studies all over the world, it has been proved that this sexuality education actually reduces their risk-taking behaviors and the problems therein.
So it has reduced by 75%. And even the stats, they mention that the people say that parents may not support, but the various studies, they have proved that almost 94% of the parents across the globe, they have supported to this program. Okay. These are some facts about parenting communication. I'll skip those slides because I want to discuss now case scenario. So now let us discuss this case scenario. The first case is to Dr. Samindra, madam. Can you please read this case? The 10-year-old boy from middle-class family, he was caught by mother watching porn movie. She had noticed it previously 2-3 times, but neglected, but now concerned and worried about his such act. My question is how to approach, how to tackle this situation, and how to communicate her with this.
So let me focus first on how to approach. The first thing I would say as professionals, what we need to educate our parents is that by the time the child is 10, we should expect these situations. And ideally, if a discussion has already happened about it between the parent and the child, it makes things easier. But have you not had this discussion and you happen to see this? The first few times that you notice something wrong or you notice that the child may be watching something inappropriate, as we have already discussed, we need to grab those teachable moments. So if we can use those opportunities to get a discussion started, it makes things easier. From time to time, instead of cornering the child, scolding the child and saying, oh, you're doing this very bad thing, get the child to open up. So instead of talking or downloading what you think about it, if you get the child to ask, okay, what interested you? What is it that you were watching? How does it help you? It encourages the child to open up and start talking, and based on what the child says, the parent can then take the discussion ahead. So to begin with, in that moment, that's how to approach. Then rope in other professionals who can help to teach the child about do's and don'ts about watching this kind of media.
Okay. So this is what parents should do. They should not neglect. They should not comment. They should not comment like that. They must immediately talk to and discuss with the child and tell him all the biological terms and tackle the situation. Now, this is case scenario 2. 14-year-old Kunal, he was found to be in romantic relationship with his classmate Rashmi. Class teacher noticed his relationship. So my question to Dr. Sadachar is how to approach this case. Should he report to the parents, principal, and what are the teachable moments and how to handle this case?
Actually, at 14 years is definitely early adolescence. Yes. And at this age, attraction.
That's not early adolescence, it's a mid adolescence.
It's mid adolescence.
Yeah.
But at this age, the attraction, infatuation is very common and it is acceptable. Regarding how to approach, the teacher should take the Kunal into meaning call it as confidence and counsel him regarding, meaning try to take from him the information regarding what is his stage of relationship. whether it is just an infatuation and just an attraction mentally, or whether they have crossed any limits, that he needs to confirm. Other thing is that at this age, these type of relations can be in both ways. It can be a constructive also, it can be a destructive also. So there is a more responsibility on teacher in this case rather than Kunal and the other partner, because that teacher has got the responsibility to find out that what is the stage Kunal is. If that relationship is going to be on the upper line, that is in constructive manner, then that there is no need to be punitive about it. Rather than we should empathize him, and the only thing that we should be vigilant also regarding this relationship.
Okay. So this is quite common situation we come across in the schools, and as we are discussing regarding teachers, when we go to schools, we must tell them that they should how to handle these cases. Not every time if they are in relationship, that means it's not it's something destructive. It can be a constructive relationship also, and they must empathize and they must talk to them. They must discuss with them, and at the same time they should discuss with the parents if something wrong they find in this relationship. So we move on to the now next case scenario, and I would like to answer this. I would like to ask this question to Dr. Swati. Dr. Swati, 16-year-old Brunal brought to pediatrician by her mother with the complaints of foul-smelling discharge and itching at private parts. So how to approach this case? How to investigate this case? What is diagnosis? How to treat, and what are teachable moments? Let me tell you, Dr. Swati, here we want regarding sexuality discussion point of view, not the other medical treatment point of view. So please discuss that way.
Okay, thank you so much. So regarding any physical illness, as we go about, so we have to take the in detail history, and I think that I need not go into the details, but we should use this opportunity that the adolescent has walked into your office. So let us use this opportunity to take the entire detailed HEDSS history. If you are, I hope everybody is aware of this psychosocial history taking in the adolescents, which is regarding the home, eating and education. D is for depression and drugs. Then A is for activities, S is for sexuality, safety, spirituality, and added to it is this the media nowadays. So this is history which is taken in every adolescent that is walking into our office, and taking into the talking in privacy is very important for adolescents, and our client is now the adolescent and not the mother or the parent. So when we take this history, we have to talk in separately and in privacy. So privacy and confidentiality has to be told to the adolescents in no uncertain terms. Like, I am Dr. So-and-so, I deal with teenagers, and whatever you are talking with me and whatever we are discussing here will be within the boundaries of these four walls. If it is harmful to your or anyone else's life, or if it has any legal entanglement, then only I will share it with your parents with your permission. So that is a disclaimer that we have to give for every adolescent that we are talking about. So then regarding when we talk about sexuality, it is assumed that by talking about some simple things like home and education, we have taken a lot of confidence, and we have moved ahead, and now we can discuss little intricate issues like sexuality.
Dr. Swati, let me interrupt you here. What are the 5 P's of sexuality history taking? Can you please discuss those 5 P's?
Yes. So we have to first tell the adolescent, this is very important, that whatever I am doing to you is a normative thing. Yeah, like I ask all these questions to all the adolescents that are coming to me, and this is very important for your own health and the prescription and the treatment that I'm going to give to you. So there are 5 P's that are given by the CDC for us taking the sexuality history. The first P is regarding the partners. So when we tell the adolescent, when we want to ask regarding whether he has an intimate partner, we should always begin with the same a statement of normality. Like many adolescents of your age, they are in close and intimate relationship with someone. Do you have someone like that with whom you are very close? then he is likely to open rather than asking a point blank question. Are you in any relationship? Are you into any intimacy with someone? So that is how we should go ahead. Then we should also ask, do you, how many partners do you have? Whether they are males or whether they are females, then how do you, like how frequently you are in like intimacy with them, then how, whether you know the HIV status of your partners, this all has to be asked regarding the partners. Then regarding practices, whether most of the adolescents do not know that anal or oral are also the sexual acts. So they only think that vaginal intercourse is the sexual act. So we have to ask what practices you are following, and whether in these practices you are coerced or you are pushed or you are doing it with your own will and wish. So this is regarding practices. Then coming to the past history, whether you are taking, whether you were diagnosed anytime having something like a sexually transmitted disease, whether it was investigated, whether it was treated, and all the details. And then coming to the protection, whether you are using protection, whether you are using condom, what are your ideas about using all these things, and what do you do to protect yourself? So this is all we ask, and this last question is regarding pregnancy. Last fee is regarding that. So we should always get an ask history of a missed period and all the things.
So as a pediatrician, we must ask this 5P approach regarding partners, practices, past history, protection, and pregnancy. Always, whenever you're talking about the sexuality with the teens or in our office practice. Now it's the last case scenario to Dr. Shubha madam. 17-year-old Sania, he came all alone to family pediatrician with history of amenorrhea, 2 months. She's tense, worried, afraid, and nervous. How to approach? What are the medical legal responsibilities of doctor? How to deal with the parents, and what are the points of counseling and follow-up? I request you, please restrict to your discussion about what are the points of counseling and follow-up, because we are running short of time. That's why.
Right. So Swati has already described how we have to take the preliminary history, physical examination, head assess, and all that. So I'll not go into that. Here it is important, the medico-legal aspect, because this is a 17-year-old girl, and so POXO will come in, and therefore the pediatrician has to be aware of the various aspects of POSCO. What are the responsibilities of reporting, documentation, whatever he or she has learned from the teenager, in all the manner in the previous speaker had described, that you have to be empathetic, sensitive, you have to be aware of the parents' concerns, talk to them. Many times the parents are very, very panicked, or they have a lot of anger. Some of them become violent. You have to take care of that. You have to understand who amongst them is more sensible, talk to him, so that our client, that is the teenager, is taken properly care of. So reporting is very, very important, and many times this is very difficult, because these could be people who are very much known to the person, or there could be an issue of abuse, but all this has to be considered in terms of POXO. And of course, maintaining confidentiality of the victim is very, very essential.
And of course, more important, as a pediatrician, we must refer this patient to gynecologist. We must take her opinion as far as medical management is concerned.
And yearly follow-up counseling has to go on for a long time with this person, both in terms of sexuality education as well as the diseases like HIV or sexually transmitted diseases.
Thank you, Dr. Shubha. Now, quite often teenagers comes to our OPD and they straight away ask this, their comments are like that. But we are in love, it feels so right. Why should we refrain? So, Dr. Shubha, what is your comment in the line?
So we can fall in love with the person.
One line comment.
Yeah. So tell the teenager that you first validate his feelings. It's not that love, you cannot love a person, or you are too small for all these things. This should not be your words. You should validate, of course, these feelings are normal and natural, but also tell them that true love requires time. You have to think deeply, you have to mature, and all these things take time. So go slow, go steady, and there are many other dimensions to your life that you have to take care of.
Next common comment from teenagers: my friend is doing, why should I be the one who should not So how will it answer this comment, Dr. Swati?
So I will tell the adolescent, I appreciate that you are seeking support on this, and I congratulate that you are not yet gone into the sexual debut. So there are two spirals. If you indulge, then there is the spiral of guilt, risk of STIs, pregnancy, mental and physical trauma, uncertainty of the relationship, and having a strained relationship with the caretakers. And in the other spiral, if you say no, and then you increase your self-esteem, feel good about yourself, good mental, physical health, and good relationship with your parents and caretakers. So it's your choice, and go ahead with whatever the way you want. But if you are indulging, then protect yourself.
Fine,
And
Dr.
every
Swati.
choice has a price.
Yeah. And I went one line answer from Dr. Sadachar. Quite often teens say, I feel pressured. How to say no to my best friend? Just one line answer.
Actually, one needs to empathize him first, and they should she should tell that there are many reasons, that family values are there, parental education, parental values are there, and many times, and she should avoid the lonely places also, so that then.
So they must be taught about these skills. This is one of the life skill, that how to say no. Okay, fine. The last question, Dr. Samindra, madam. They say that all my friends have partners, but I feel I left out. What to do?
So first of all, I'll acknowledge and validate the need to fit in, because FOMO is a very, very real thing for teenagers today. At the same time, have a discussion about the importance of waiting for the right partner to come along, and take the discussion from there.
Fine, fine. So the foundation of strong relationship is friendship should be at the bottom, then should come love, then should come marriage, and of course, sex should be last. This is what message we should give. How much time is there? It's over. Should I take 2 minutes more? Please. And of course, this is a wrong pyramid, and which can collapse at any time and can spoil a teenager's life. I'll skip this slide. The take-home messages are: the human body and development should be taught throughout childhood. Values, right, culture must be discussed always. Understanding sex, gender, sexuality, and sexual activity is most important. Relationship issues must be discussed. And of course, the active communication, good communication is very important mainstay of this discussion. The life skills for health and well-being must be imparted at school, at home also. And of course, nowadays there are digitally also so many lot of scientific information is available, and we should make this information available to our teens. Now, in one line, please, because already we are exceeding time, I want messages for teens. What message will give Dr. Samindra, madam? One line messages.
We are all sexual human beings and have a sexuality, and there is a time and place to express and manifest it.
For teachers, Dr. Sadachar?
Teachers should grab the teachable moments. That is most important. And also the group sessions in schools, that is also that he can do. And
okay, fine. And for pediatricians, Dr. Shubha, madam? One line message.
सर, एक छोटंसं हे सांगू का? 2 मिनिटात. संवादाची संधी साधा, शिकून घ्या लिंग गाथा, मुलांनो बोला बिंदास, दिल की बात, आईएपी हमेशा है आपके साथ.
Okay, fine. And for parents, Dr. Swati, as an adolescent, this is a poem Dr. Swati has written, and as an adolescent, क्या बोलते हैं वो? Teenager हम बन गए, प्रश्न लिए हजार, शरीर मन और बुद्धि ने लिए नए अवतार. कौन हूं मैं, कैसी है चाहत, सोचूं बारंबार, क्या क्यों धड़कता है ये दिल और क्यों उमड़ता प्यार. काया मेरी चाहे कुछ तो, क्यों मैं न दूं नकार, नजदीकियों पर मेरे क्यों समाज का अधिकार. कोई मेरी उलझन का तो जवाब दे दो यार, मम्मी पापा डॉक्टर टीचर, नया लगाओ पार, मेरी नैया लगाओ पार. So this was the teens, what teens says. Now, Dr. Swati, as a parent, you please answer the thing in a poem.
This is also a dilemma that the parent is going through. पर बेटे को आई मूछे, बिटिया को पीरियड्स आए, क्या बताऊं कैसे बताऊं कुछ समझ ना आए. रोज रोज की बुरी खबर और स्क्रीन पर नंगे नाच, गर्लफ्रेंड बॉयफ्रेंड के चक्कर में आए ना इन पर आंच. सेक्स ज्ञान के बिना विचारे कर देना कोई नादानी, तन मन की इन नवलहरों को दिशा हमें है देनी. हया शर्म अब दूर फेंक कर बैठूंगी उनके साथ। धन्यवाद आईआईपी तुम्हारा खूब सिखाया पाठ।
बहुत खूब Dr. Swati, बहुत खूब. And
Thank you
last
so
slide. So as a sexual rights, we must tell the rights of the child, explain them the rights to stop any sexual contact with the partner at any time whenever he feel. Say no to any unwanted touch at any time. They must make their own sexual decision. They should not get pressured into being physical or sexual. Do not express your sexual orientation if you don't want to. And of course, most important three are, they are recognize, react, report any sexual misconduct with you. So they are the three, they are the most important rights of every teenager. We must talk to them. With this, once again, I thank organizers, my panelists, and of course, the audience. Thank you very much.
Thank you so much.
Thank you so much.
1 second. I am a gynecologist, but I want to say that the session is going very good. I am a mother of 2 daughters, and I always tell my daughters that ensure your safety by maintaining your dignity.
Yeah, that's good. Very good. Very good suggestion. Any other question? Okay.
Really solve the dilemma of pediatrician also to how to interact with our kids. Thank you.
Thank you.
I thank Raigad IIP also for giving us the opportunity and giving this good organization. Thank you, sir.
Thank you very much.
Ladies and gentlemen, our next topic is a guest lecture. And for this, I request Bakul Bhai to please come on the stage for the lecture.
Sir, talk about a condition which has itchy inflammation of the skin, usually develops in early childhood and is more common in people who have a family history of the condition. Yes, you guessed it right. Atopic dermatitis. Is it allergic or a self-limiting condition? So let's ask Dr. Bakul Parekh sir what is it?
Perspective. We see this condition very often in our practice, but sometimes we mismanage. So let's go through the slides and see what we can do. So what is atopic dermatitis? Ultimately, most important part is itching. There is chronic pruritic inflammatory skin, which is characterized by dry skin, and it relapses very frequently, mainly affecting face and flexors. It is often associated with increased IgE and with presence of personal or family history of atopic conditions in the family. So diagnosis will be based on 1, itchy skin plus any 3 of the following. That is history of flexural involvement, visible flexural dermatitis, but in a child who is below 18 months, maybe tics and extensors, personal history of asthma or hay fever in the family, history of general skin, dry skin in last 2 years, and onset under the age of 2 years. It affects most 20% of the children, and out of this 20%, 10 to 30% can go on having the same condition during adulthood. There is a complex interplay between genetic predisposition, immunological dysfunction, skin barrier defect, and environmental insult, and this leads to your atopic dermatitis. I will concentrate more on environmental insults. A dry environment may increase the transepidermal water loss through defective skin barrier. And this skin barrier defect facilitates entry of chemicals, irritants, and allergens, leading to IgE sensitization and then leading to various food allergies. Skin barrier defect increases chances of skin infection also. So this is a common presentation. Usually it is seen between 8 to 12 weeks. Dry, scaly, red lesions with excoriations, predominantly on the cheeks. Many of our newborn babies we see in the age of 3 months or they will have this red skin cheek. Napkin area is paired. That is very classical of this. Itchy and discoid eczema may be seen in some of the atopic eczemas. And if you go on the older age group, that is toddler and preschool, they are more mobile. So more of wrist, elbows, ankles, and knees will be involved. Gradual change to flexural environment and scratching leading to excoriation. Most of them they will keep scratching, and then there will be excoriation and superinfection. And in school children, mainly flexors, eyelids, earlobes, neck. And then there, because of frequent itching and excoriation, there will be lichenification, thickening of the skin, and that may get pigmented also. So may need to rule out contact dermatitis in some locations like perioral or posterior thigh. Especially in adolescents and adults, you'll see more of perioral dermatitis. Now, how will you assess before you manage? So it is based on body surface area and frequency and intensity of flash and quality of life. So if your quality of life is bad, you are getting affected again and again. Intensity is so much that you have to continuously itch, and larger areas, then it's an condition where you have to treat immediately with potent steroids and so many other things. And there are scoring systems like EASY, SCORAD, SASAD. We may not go into those details. So how will you manage this? First, of course, you have to educate and counsel, telling the parent that this is a condition which is inflammatory, which may last longer, which may relapse, there may be self-remissions, and there is no cure but control, like what we do in asthma. Then we have to explain about specific measures. Now, specific measures should be directed at barrier defect, immunological dysfunctions, and detrimental environmental exposures. Genetic defects, of course, the things are being researched. So at first consultation, definitely you have to counsel them well, educate them well about the chronicity, the recurrence, the relapses, and it may take a longer time to treat, and better to stick to the plan which we decide rather than go to one doctor to another doctor and go on giving more and more steroids. So what are the therapies? Most of the time it is topical therapies. We use moisturizers more commonly, then topical steroids, then topical calcineurin inhibitors, and wet wrapping. Rarely we at our level go for phototherapy or systemic therapy. When that is required, you may have to refer them to dermatologists. So what do moisturizers do? See, let us accept that most of the time we don't think much. When a child comes with eczema, we give that mix steroid, antifungal, antibiotic, and leave them. But that is not the right way. Most of the time, many of the skin conditions in newborns and young children is moisturizer is enough. And you should know which moisturizer to use and how it acts. So it fills the crevices and so smoothens the skin and increases the flexibility and thereby prevents the excoriation. Something like petrolatum, dimethicone, mineral oil. People use teal oil, singdan oil, but never use custard oil or mustard oil or oils like that. They are very irritant. Then attract and hold the water. They will absorb the water. At the same time, they will gain water from dermis to epidermis and make them moist. And it thereby reduces the itching. And some moisturizers containing ceramides, cholesterol, and free fatty acid level in molar ratio of 3:1:1. And it claims to lead to barrier repair also, but evidence is still equivocal. So we know that there are ointments, creams, lotions, and oils. So when to use what? So in one line, ointments should be used for thickened skin lesions. But they are cosmetically not really acceptable. Creams are the one which we use very commonly. It should be moderately thickened skin, and usually it gives very good result. And lotion should be used for larger area or hairy area because your ointment and cream may not touch the skin. So you have to use lotions. So these three things you should remember. And oils, of course, as I told you, that mustard oil and olive oil should not. We use olive oil very commonly for newborns. But if they have atopic dermatitis, please avoid. So mustard oil and olive oil should be avoided. Coconut oil is very good. Now, what features should be an ideal moisturizer have? It should reduce and prevent the transepidermal water loss. It should restore the lipid barrier. It should be hypoallergenic, fragrance free. Again here, though it is ideal to have fragrance free, but without fragrance, people will not accept. So some sort of organic fragrance we may allow. And non-comedogenic. Non-comedogenic means they should not block the sebaceous ducts outlets and thereby cause those eruptions. Minimum preservatives absorb quickly to hydrate the skin and cosmetically acceptable and affordable, which is not so most of the time. All the skin ointments and creams are very costly. So how to use a moisturizer? Frequent application is a very important part. 2 to 3 times in a day, liberal use. If using a jar, don't use your finger, but use spatula to avoid contamination. And downward application from above down to avoid the damage to hair root and hair growth. And apply immediately after bath so as to trap more moisture. So immediately after bath, more frequent, up or down in one direction to avoid the, and use when you're using a jar, use spatula, not the finger, which otherwise is done. Can preserving skin barrier prevent atopic dermatitis and atopic march? Many times we know that asthma is maybe associated with history of atopy or dermatitis in previous or in the childhood. So does this can be prevented? There were various studies, but at the end, it is still shown. Cochrane says no, there is no change. But many people use it from birth onwards to prevent this atopic. When there is strong family history of atopy or dermatitis asthma, there is worth trying repeat moisture use in childhood. Then about topical corticosteroids, a very commonly used drug or ointment or cream, whatever you use for atopic dermatitis, used intermittently for sore. So this should not be used like moisturizer. So not be applied 2 to 3 times and very frequently. It should be once in a day. And once it is controlled, within some time you should stop and go to moisturizers. And it should be a reactive approach. So most of the time use when there is acute flares rather than starting from the beginning. Proactive approach I will like to avoid. In case of repeated flares, after using for short periods, use once. So this is okay. If you want to prevent, after it is controlled, use once or twice weekly on affected area for few weeks to few months to suppress the inflammation effectively. And this has definitely shown increased period of disease remission. Then these are the steroids. Out of this, I think hydrocortisone and disonide, these are the two ones which we should use rather than using the stronger steroids. So once daily application suffices. Repeated application of same steroid over a longer period may reduce its efficacy because of tachyphylaxis. And TCS application helps reduce staphylococcal load on the skin surface. And sometimes it causes skin atrophy if you use very frequently and potent steroids. So parents should be adequately counseled regarding steroid use. Both steroid overuse and steroid phobia should be addressed, because many times even your steroid ointment or inhalers also people say steroid. No, see, oral steroids and large dose steroids are useless, but all these things when used properly is very effective. How to choose a topical steroid? So it depends on type of lesion. Thick lesions, again, potent steroid, and thick lesion, ointment, right? And potency will depend upon the type of skin. So if thinner the skin, you will use cream or less potent steroid, and delivery vehicle can be anything depending upon the large area. Suppose it is hairy or very large area, then you use lotion. So how to choose a topical steroid? Depends on site of application. Sensitive areas like oculate fold, axilla, groin, areas with thin skin like face and genitalia, we need lower potency steroids. Because we have used, I should not use brand name, but Candiderma, Derma, they are used for those intertrigo, and then it leads to skin atrophy and your depigmentation very commonly. So that should be avoided. Duration of treatment used for a short duration only, can be used for maintenance intermittently once acute flare is settled. Don't apply daily then. Once it is controlled, maybe once in a week you can do. Proper patient profiling. So in neonates and infants, lower potency steroid, and families with low understanding should preferably be prescribed lower potency because they will misuse it again and again. Then what is the unit you use? The fingertip unit. So amount that can be squeezed from the fingertip to the first crease of finger with a 5 millimeter diameter nozzle considers 1 FTU, and this equals to 0.5 gram of medication. So generally 200 to 250 milligram is the need per day. So you can understand how much you should use. It can cover area equal to 2 palms of the person measuring this FTU, and usage should be explained in FTU to avoid both overuse and underuse. And these are the adverse effects. Most commonly your tachyphylaxis, hypopigmentation or hyperpigmentation, and atrophy of skin. These 4 things you can remember. Then when your moisturizer fails, your TCS fails, that is topical corticosteroid fails, then the role of tacrolimus. Now 0.3, 0.03 and 0.1%. So 0.03 and pimecrolimus has effect equivalent to low potency steroids. So they are used as steroid sparing ointments. When you want to use steroids very frequently, or there is lots of recurrence, initially you control with steroid, change over to tacrolimus. And TCR steroid sparing, and usually can be used during flare of AD or as maintenance after using TCS initially during the flare. And for maintenance, this can be used 1 or 2 times in a week, and use has been shown to reverse the skin atrophy. Very costly ointment, but if used properly, it's very advantageous. Then systemic therapy, of course, oral histaminics, we always say don't use sedative antihistamines, but here It is the other way around. Use sedative antihistamine because you want child to be comfortable, and should be used during acute flush to break the itch scratch cycle. And oral steroids should preferably avoided, and when it is needed, better refer them to dermatologist. Systemic therapy, of course, it is to be used when there is severe resistant disease, widespread disease, steroid-dependent atopic dermatitis. It is affecting school or personal relationships, and sometimes there is lots of psychological afflictions, especially in adolescence. So there you may have to use it. So how will you manipulate the environment? Keep surrounding environment of child cool as heat induces itching. Keep nails short to prevent excoriations. Prefer cotton clothes. Avoid woolen and synthetic garments. Cut inside labels for neck area of shirts or t-shirts to avoid irritation. And pets may be removed if benefit outweighs the psychological trauma it can cause to the child. Environment prompt treatment of secondary infections is very important. Suspect contact reactions if resistant lesions. Suspect food allergy in resistant atopic dermatitis. Assess family dynamics if compliance is poor. Assess sleep pattern of the child, and assess any school absenteeism, as this may foretell psychological issues. And bathing is very important. Now in a newborn, when a child comes to you, how much time do you should bath? So it is practically only 5 to 10 minutes with a warm water. Should not be cold, should not be hot. Warm water. Preferred that bathing is preferred over your sponging and wiping, what we otherwise advise when child is sick. And scrubbing should be avoided. And 5 to 10 minutes bath is ideal, as prolonged bath causes pH changes and reduces the threshold for friction. And bath at least once daily. Cleansing practice. So here I will like to say only that you don't use soap, but use cleansing detergents. They are synthetic detergents, syndots they say. That should be used during newborn period so that they are not damaging your skin, and it maintains the pH of 5.5 rather than alkalizing pH of soap, and that will help you. But the cost and availability may be limiting factor for the use of this cleanser. So ideal cleanser should be mild, liquid, have a synthetic detergents, fragrance and color free, minimum preservatives, acidic or neutral pH, and affordable. And wipes again should be alcohol free, should have proper cleanser, appropriately preserved. Maybe emollient can be used, and acidic pH should be maintained. Role of probiotics and prebiotics. Lots of talks are going on about prebiotics and probiotics in terms of allergy at skin, asthma, and various places. But Cochrane at present says it is not effective. Role of food allergy. Whenever there is moderate to severe atopic dermatitis, you think about food allergy, and most of the time, 90% of the time, it is either to nuts, milk, soya, egg, or fish, and sometimes wheat. So can you prevent atopic dermatitis by using early moisturizing in a at-risk neonate or early introduction of allergens? Professor Barnett said the first 2 years you don't give nuts to avoid allergy developing later on, but now the theory has changed. You give those foods in the initial period so that they develop hypoallergy. And exclusive breastfeeding first 4 to 6 months of age, and administration of probiotic bacteria in pregnant women 2 to 4 weeks before delivery, and in infants for 6 months after birth. These are all studies going on. No proper results are available. Look at the case scenario, how you apply this knowledge. 1 month old girl was brought to you by mother. Her elder sibling had atopic dermatitis. What is your advice? Whether this child will develop? So you have to, yes, you have to tell them about bathing. You tell them about soothing of itching, removing the crusting, and lukewarm water should be used. Reduce use of soaps and use cleansers. Emollients are the best applied after birth immediately so that the moisture is preserved, and they should be applied to normal and abnormal skin both. And this should be applied at least twice a day, more frequently in severe cases, especially winter months. So identify potential triggers. So what are the triggers? Overheating, lukewarm baths, 100% cotton clothes should be there or kept bedding to the minimum to avoid overheating. Direct skin contact with rough fibers, particularly wool, and also you should limit and eliminate the use of detergents. Dusty conditions should be avoided. Low humidity should be preferred. Cosmetics, makeup, perfumes, all can irritate. Soaps, or use soap substitute rather than soap. So basically, warm water bath, cleansers, emollients, frequent moisturizers, and avoid all your irritants like rough clothes or woolen clothes or whatever. Use gloves to handle the chemicals and detergents. Triggers can be infection, bacterial or viral or fungal, stress and anxiety, lack of sleep, and certain food chemicals or colorings like eggs, peanuts, milk, fish, and wheat. Aeroallergens like dust, mite, pollen, animal danders, like whatever we advise even in your allergic bronchitis. And environmental factors, hard water and tobacco. Case 2, this is the child. 3-month-old boy with patch of dry skin on cheeks, trunk, and right leg. Small areas of redness, infrequent itching was shown to you. Your comment. So this is mild atopic dermatitis. Daily application of moisturizer twice, thrice daily, immediately after bath. Mild corticosteroid application for 7 to 10 days to control and avoid irritants. Case 3, 8-month-old child with patchy areas of dryness, occasional areas of erythema, frequent itching, areas of excoriation is seen on your table. Your approach. Again, this is a moderate atopic dermatitis. Here you will avoid flares, frequent application of moisturizers, topical application of mild potent corticosteroids twice daily, TCI, that is your tacrolimus, antihistamines, and wet wraps. Wet wrap is like you wet the cloth, wear it, and above that you wear dry cloth before after applying your moisturizer or steroid, so that it penetrates the skin and preserves the moisture. Then case 4, 1-year-old child with widespread areas of dry skin, more number of erythemas, patches, intense itching, areas of excoriation, bleeding, oozing, lichenification, and parents beg for your immediate attention. So this is severe atopic dermatitis where you will use emollients, moderate to high potent steroids, antihistamines, wet wraps, topical calcineurin inhibitors, and phototherapy. Steroid-induced atrophy will be seen like this, especially on those flexors. Then your striae can be seen. Steroid sparing is very important with using tacrolimus. Then relief of pruritus, you will require sedative antihistamines like hydroxyzine, diphenhydramine, and cyproheptadine at times, and wet wraps. In refractory cases, of course, you will need systemic steroids, cyclosporin, anti-metabolites. Most commonly used drug is methotrexate by the dermatologist. A 5-year-old Arpit with atopic dermatitis, parents are sports enthusiasts. They want him to be a football player. How do you counsel? Can be engaged in sport activity, definitely, but avoid heavy clothing, heavy sweating. Swimming may be better tolerated, bath immediately, and avoid contact sports. 6-year young Archana, skin prick test positive for house dust mite, serum Ig levels are very high. Adequate ventilation of housing, avoid carpets, wet sponging, vacuum cleaning, avoid soft toys, wash bed sheets at a temperature of more than 55 degrees, encasing of pillows and beds. Just 2 minutes. 7-year-old Sachin with atopic dermatitis with history of frequent flares wants to go to school excursion in summer to Kashmir. Parents are worried. Counseling encourage summer holidays in altitude and beach resorts. Proactive application of moisturizer and anti-inflammatory agents and control of flares. 8-year-old Satyabhama is pestering her parents for a pet. What to do? Avoid furred pet. 9-year-old Anushka gets flares of eczema whenever she wears brand new pairs of clothes. What is happening? Her mother wonders. Wash new clothes and launder before wearing, because formaldehyde and other chemicals are the culprits. Remove the labels. Use liquid rather than powder detergent and second cycle. Salman is a 9-year-old boy who was brought in by his father, who is concerned about white spots on the face. He has past history of mild asthma, no history of hospitalization. Albuterol was needed, allergies are none. Family history, mother had a history of childhood atopic dermatitis, lives at home with his mother and father, and otherwise negative. So what will you do? This pityriasis alba. So poorly defined hypopigmented scaly patches on the face, very common condition. And here again, your treatment will be moisturizers, nothing else. And 12-year-old Virat has eczema of hands, used to get relief with 1% hydrocortisone. This time same molecule but different brand. The problem is fed up. Why? Because they have different preservatives. And last case, Hema Malini, 25 years old, has come to you for counseling. Her first child is having severe atopic dermatitis. How to prevent this for the next child? So again, probiotics may be used. Breastfeeding should be strictly followed. Better avoid implicated food allergens by mother. Emollient therapy to the whole body. Avoid triggering factors. Vitamin D might have a role. So ultimately, recurrent exacerbations, severe refractory cases, switch over to systemic immunosuppressive therapy will require dermatological reference, and eyelid dermatitis, chronic blepharitis, keratoconjunctivitis, cataracts will require ophthalmic preference, and take-home points will be, it's a chronic pruritic inflammatory skin disease with a wide range of severity, one of the most common skin disorders in developed countries, affecting more than 20% of children and 1 to 3% of adults. Distribution and morphology of skin lesions varies by age. A large percent of children with atopic dermatitis will develop asthma or allergic rhinitis. The pathogenesis is multifactorial, and treatment includes long-term use of emollients, gentle skin care as a short-term treatment for acute flares. Thank you very much.
Thank you, sir. Thank you. Thank you very much. Now we call.
This should be the pyramid.
Thank you very much, sir.
Thank you.
Now we call upon Dr. Samir Dalwai, sir, for this next talk, which is on art of effective presentation.
Creating effective on various subjects and delivering it to the writing of the essential skill required to the professionals. Simple tips like use of particular fonts on slides, background colors, and body language can affect the presentation. The ideas are presentation.
Thank you.
So,
Thank you very much, respected seniors, respected past president, Dr. Ajusha sir, Dr. Bukul Bhai sir, president, Dr. Jayant sir, the office bearers of Maharashtra IP, Dr. Jayant Pandrikar, all the other office bearers of Raigad branch, all the other office bearers of Central IP, respected friends. I shall begin with my presentation now, how to make an effective presentation. It's a very interesting topic, and when I suggested it and we spoke, Bukul Bhai given the idea, and Hemant, they were very happy to have this. And I don't think any of us needs to hear about this talk. We just need to listen to the presentations of this great man. And just being around him and learning from him initially in the few months at JJ Hospital, where I had the great opportunity to work with him, is the most effective thing that you can learn. Few things to learn from him is no question about talking about his knowledge, but more important is his simplicity. You will never find anything colored on the slides. That's why today I've also kept this presentation very blank, because sir has 5 or 6 words on every line, 4 or 5 lines, simple presentation, no colors, no cartoon, no pop-up, no disappear, nothing. Matter is over. But that is the greatness of the man and his effort. The other person I've learned from is a very contrasting style, and it's all about style and knowledge. And Dr. Merchant I've heard from and learned from is few things that always, Samir, speak about your work. Whatever you have done is also very relevant, as long as it's relevant to the topic, because people want to know what has actually been done rather than what you've just read from the books. So again, thanks to him. And finally, the master whom I think really the person who taught me, ठोक के सीधा क्या बोलता है वैसा. I can't tell you how many times he has criticized me, he has shouted at me, and I really miss that. Every time I would meet him, the moment my talk would get over, I would look at him. Either he would be like this, happy, or do like this. तेरे को बोला था मैं. That was his usual style. तेरे को बोला ऐसा मत कर. But that is where I've learned from, and I'm going to try and share a few things with all of you. So what do you do? It all begins, art of making a presentation, when you get the invitation. What do you do when you get the invitation? You are excited. Wonderful. What else? Try to exploit. अच्छा मेरे को परसों क्यों नहीं बोला मैं क्या होता है ये before coming here. So the first thing is read the invitation carefully. What exactly is the topic they've given you? Very often I've heard people come to the presentation and it was what and where can make a very big difference. So it's very important to know specifically what you're talking about. Note the time allotted. People come prepared with a presentation for half an hour when the topic was allotted only for 12 minutes. So it's quite a mismatch. And then they have to say, okay, I'm going to rush through my slides. Nobody came to see your slides, that you have to rush through them or not rush to them. So it's unfair to the audience. Note the theme of the conference. I may be speaking about something, whether it is what I want to present with, it's relevant to the entire theme of the conference. Because most of the people hopefully will be speaking about the theme, and you come up here and you speak, everything is black, and you come here and you talk about white. So it's not, doesn't fit into the whole thing, and your presentation falls. The most important thing is who is speaking before you or after you, or parallelly to you in the other sessions. I'll give you a surprising insight. We always used to choose the talk before Amdekar sir. Why? Because sir ko sunne ke liye jagah nahi rehta, so people come early to book the seat. So they come earlier in the previous talk to book the seat so that they can hear Dr. Amdekar. So if you have the talk before Amdekar sir, anyway the seats get filled, so you get a better ego massage. Whom you speaking after, that is something that all of you can choose on your own. Book on time. I mean, sometimes you've been given the invitation 3 months back and you try to book the ticket 3 days, you prepare and everything 3 days before, and you don't get Tatkal also. So you can't reach on time. And begin to prepare. This is what, again, I've learned from Anand. Anand would say that I would start preparing the PPT on the day, Nani, the day I get the invitation. The day I accept, I start preparing the invitation. So the people who are sitting next to me are laughing because they're saying what a hypocrite this man is, because he just started making the presentation 10 minutes back here. So you don't have to all copy or follow me. You can follow better people like Anand, who used to prepare a month before. Now, when you prepare, what are the things you remember? What are you setting out to do? तुम्हारा मकसद क्या है? तुम बताना क्या चाह रहे हो? और तुम किसको present कर रहे हो? The same topic, if it is being presented to pediatricians, has to be different when you are presenting it to the parents in a school. It cannot be the same. If you talk about malaria the same way you're talking to pediatricians, to parents, they will get very, very afraid and they will think you're trying to create fear mongering just so that you get more patients, and it doesn't work that way. The same thing if you're talking about a topic, say I'm speaking about autism. If I'm speaking to a crowd of general practicing pediatricians in a rural area like Jalna, I have to speak in a way that they are able to implement. It's not about anybody's intelligence. Everybody is super intelligent. It's about the resources that they have in a particular place. I have to address it that he can go home and take it with him or her and practice it every day. But I'm speaking in a developmental pediatric conference. I have to talk to the developmental pediatricians. It has to be perhaps either totally my experience or it has to be cutting edge. So this is very important that we understand. What does my audience already know? If I'm not aware of what they already know, like I just mentioned, I'll be wasting their time. I need to know what they already know and then gradually build up. And again, Anand used to always tell me, and I'll be very frank, तू क्या करता है तेरे सेंटर में, किसको पढ़ा नहीं है? हम लोग उससे सीख के हमारे क्लिनिक में क्या कर सकते हैं वो बता. So don't tell us your great funders about autism, what you do. वो तू तेरा development pediatric conference में बोल. So it's very important to understand how can I help the person in front of me, how he can go and do this. So even what I'm doing right now, it's like a meta cognition. All of us will prepare our talks. All of us look at talks prepared by others. I think these are the issues we must all keep in mind. So those who were laughing that I just prepared the presentation, I like to serve food hot. मुझे ठंडा खाना परोसना अच्छा नहीं लगता है. Because I believe, and it's your individual style. That's why you have to choose what suits you. I believe that I work best as I build up just before the actual event or the actual presentation. My mind works best, and I hate copying or copy pasting from anywhere. So if you are doing it the last moment, there's no time anyway to research or copy paste. So you end up putting what's there in your mind. And I believe that works best with people because they really connect to the you. If they have to read something, if you have to copy paste, they can also read somewhere from wherever you have said it. So I believe you do it not totally last minute like maybe I do always, but somewhere towards the end, so your core knowledge comes out. Very important message to remember is if you have a talk for about 15 minutes, plan that I want to give 3 key messages. That these are the 3. That's unfair. Last time I spoke 7 minutes lesser. So abhi adjust kar do isme. So if you are speaking for 15 minutes, don't have 25 ideas that you want to share with the audience. Kuch fayda nahi hoga. Okay, I'll make it 25 slides and I'll squeeze those slides to 20. That's a mistake. Nothing with the slides. The idea is audience can grab one key point in 4 to 5 minutes. So if you have 20 minutes, stick to around 4 messages that you have to give. Run through the ideas with those you like your presentation and those you don't like also. निंदकाचे घर असावे शेजारी आणि जर शेजारी निंदक नसतील तर घरात बायकोला विचारा तरी चालतं. The next philosophy is KISS. KISS is not what all of us think it is and what was discussed in the previous topic by Jayant Pandrikar sir in detail. It is about keep it simple, stupid. Don't make it complicated. Keep it as simple as possible. It's not your chance to show off what you know. What you know, there's Indian Pediatrics Journal. Usme dalo. They want to, take whatever you know which others don't know. Our general audience is not for that. And it's a good idea to rehearse. But again, like I said, I'm not really the best example for that. Simple things like font sizes, whether you can see it from 2 meters away, enlarge the keywords, keep it bold. Too many colors looks too colorful like a peacock. Nobody likes. They're all confused. They're looking at the color, kya ho raha hai, and they think it's a Karan Johar film and they're not focusing on your content. So not too many fonts and styles, 6 lines per slide, not more than 7 words per line. Don't present data like this. Instead, you can make it into a graph or try and make it colorful and things like that. Not too many animations. Something pops up from here, something pops up from there. People are always trying to say, Abhi kya hone wala, as if it's a Amitabh Bachchan action film. So don't do all this thing. Nobody likes it. Keep it clear. Don't keep all caps lock. Prefer simple fonts. Italics are difficult to read. Underlines also difficult. So wherever there are key messages, use a brighter color. And a bold font is very fine. Again, the contrast is very important because every center or every auditorium has a different setting. Here it's bright. Sometimes it's very dark. So you should always be prepared for that because it's not in your control. Abhi, I've just arrived for the talk. So just 2 minutes. When you arrive in time, check that you're at the right place at the right time. I know why you all are laughing because I came late today. So check you're at the right place at the right time. Especially in Pedicon, there are 11 halls. And sometimes in places like Delhi, one hall is like 10 kilometers away from the other. So you won't make it in time. Check if your technology, the iPad that you have or whatever is compatible. Check the videos, whether they are running, and run through the whole presentation. There are times you check the first 3-4 slides. They run very well. In the 5th slide, अरे यही check नहीं किया था तो उधर बंद हो जाता है. Check the audios, check the video whether it's running. Check the microphone. It's a very important tip. When we are speaking to an audience, we are looking at the last person. अरे तो माझा आवाज पोहोचतोय का? I forget कि सामने mic है ना. Because visually we are focusing on the person, we don't realize there's a microphone. So it's very important to come and check the volume, because if you speak loudly, it appears that you are very stressed and you do get stressed. So keep this thing in mind when you check for it. Freshen up, of course. When you begin, there are too many introductions at times. So I remember one great person was being introduced and another equally great person, but his junior was introducing that person. And he went on, this sir is like this, sir is like that, sir did this, sir that. Finally, when sir got up to speak, there were only 3 minutes left to speak. And he said, the way my student described me, I thought I am dead and this is my condolence meeting. Itna bolne kya jarurat thi? Mere ko hi time de de bolne ke liye. When you begin, it's always about us. Begin in a way, it's not, okay, I'm going to tell you a few things that you don't know. Khatam. I am going to tell you. That's the worst thing possible to do. It's all about us. It's all about what we know. Generally begin with a bang, and I call it the humor, stunner, or the bummer. So of course you can't put some stunning pictures like what I know you're thinking, but humor, a joke, a lighter animation or a cartoon usually makes people smile and laugh. And when people smile and laugh, the rest of the presentation generally goes easy. Begin with a question like Bakul Bhai was doing. If you keep asking questions, that's the best way you can interact with the audience. And very important to remember that you have to keep your tone down, like I'm trying to do now. Keep your tone down, because then it appears very peaceful to the listener. If you keep on speaking at this tone, after some time people want to just throw 3-4 stones at you. So keep your tone down, because a loud tone gets very irritating for the audience who's been sitting from the side. And this is how you get the audience on your side. And keep smiling unless you're presenting mortality data for that month. If you're smiling while presenting mortality data, you had it. So keep that. It's not about a topic. It's about what you think about it. It's not about autism. It's what I believe about autism, what I think about autism. Because that's why you've called me, right? You want to hear what I believe about it. If I had to tell you what the CDC thinks about autism, then you can just go down to the CDC website and download it. Begin by saying that I'm going to address these things, these issues. If there are any disclaimers, especially if you have stolen the material from somewhere, say it in the beginning. State where your work comes from, that I worked at Sion Hospital, my data comes from there. And there will be always somebody or the other who will pass some stupid comments in the audience. Chalta, you also laugh, people also laugh, everybody laughs, good for you. How do you progress? Share your own work, relevance to your presentation, keep the flow going. One message per 5 minutes. Watch the audience, not your presentation. Okay, now on this slide, no, I am this slide. Audience doesn't want to look at the slides. Audience has to look at you. You are the presentation, not the slides. Don't humanize. My presentation says this. Nobody called you for your presentation. People call you to hear what you're saying. So never ever refer to the presentation. My slides show this. Nobody cares about your slides. Keep the photographs on. Keep the interaction going on. Many speakers who stand keep looking up at the roof. If you're talking about God, it's a spiritual talk, keep looking up. So everybody else will also look up. If you're talking about a topic, look at the audience and be comfortable with it. And keep a watch on the time, as I'm keeping, trust me. When you conclude, build up the crescendo if there is one. So now as you go ahead, cut the humor slowly, and you need to get a little more serious, because that's where the emotional connect comes across. That this speaker really, really cares about the topic. Take home messages and key messages are important. Acknowledge well all of those who have helped you, and thank others. Answer questions peacefully. So for example, I'll just close in 2 minutes. Did you know that more than 400 million users of PowerPoint in the world exist? More than 4 million PowerPoint presentations are made daily, which means 1 million presentations per hour. So it's important that it's not the presentation. It's about you. People come to watch you, not the presentation. Last couple of comments. Clothes maketh the man, and when a man dresses shabbily, people remember the clothes, and when he dresses well, people remember the man. I've learned from Dr. Amdekar the simple thing. He wears a simple shirt and a trouser. or he wears a jacket and he comes, the man is equally elegant and stands out in a crowd of thousands. It's his style. What is the difference between fashion and style? When all of us do one thing together, all of us wear jackets, we are in fashion. When we do what we like, that's our style. Each of us is born with our style. You can improve it. You can imbibe things. I have picked up a lot from Anand. I've picked up a lot from Merchant Sir, from Dr. Amdekar. But eventually you have to be you. That is style. What is unique? And people will remember you for that. So finally, your audience needs to be captivated like this, not captive like this, because next time nobody will call you. And finally, you are the presentation. You are not Yash Chopra that you are going to show them a film. Ye dekho kabhi kabhi. You are the presentation. People have to watch you. So you need to understand that the entire attention should be on you, not my slides. This is a very busy slide. Are kya bewkoof aadmi? Busy slide kai ko laya li? Nahi lane ka na busy slide. Why are you making the slide human? This is a slide is busy. You are personifying the slide. Why? You are in the spotlight. You should be on whom the spotlight is. Don't deviate it to the presentation. Finally, acknowledgements. All my teachers, I have mentioned some of them and many more. Acknowledgements, all of you, because the feedback that we get from everybody after the talk is most important. And a colleague of mine who helped me make this presentation, Dr. Misbah. So thank you very much. And I'm very sorry for the extra time. Thank you very much. Thank you.
Thank you, Dr. Samir. I know time is overshoot. We are already running late. But for next scenario, the next case scenario, I would like to call Dr. Nani Udekar on the stage. Also chairperson, Dr. Shilpa Dudgaonkar madam, Dr. Archana Joshi madam. Please come on the dais. Dr. Archana Joshi madam is very senior pediatrician from Virar, and she has a lot of work in the preventive pediatrics. And Dr. Shilpa Dudgaonkar madam, she is a EB member. She is from Pune IIP. And yeah. Madam is from the Jangir Hospital. Dr. Narendra Naniwadikar, he is from Kolhapur, and he is one of the person who is national convener for IIP ALS, and I did my ALS under him in Panvel. So thank you, sir.
My sincere request not to start the timer before I say a couple of words, because this I have to add after Samir's speech. Samir, if you would have given this speech, say a month earlier, probably I would have prepared it better. And at the same time, I could see Anand in last couple of slides. That is for sure. So I think it was one of the excellent presentations. So I will start with my talk.
Sir, yeah. I'll just review the introduction.
Yeah, sorry.
The topic of our first case is the clinical setting of a child found unconscious in the garden. When a child loses unconsciousness, we need to take the situation very seriously. Although unconsciousness have many reasons, from head injury, hypoglycemia, drug toxicity, and many more. Believe me, they all are challenging to manage. So a systemic team approach is required, as it's a very time-sensitive condition. Sir, over to you.
Thank you. Thank you, first of all, for the organizers of Mahapedicon and Team Raigad IIP for having invited me for this talk. The talk is Unconscious Child in Garden, an approach to case. Now, all of us know any child who has lost his or her consciousness needs an urgent attention, because an early identification is required. But this early identification is to be done by a systematic approach. An immediate intervention will help this child recover with an intact neurological outcome. The cause of unconsciousness could be as trivial as syncopal attack, or this child could be as serious, having status epilepticus or any other intracranial bleed, or maybe the child has arrested. And most important part of this talk is that it is an out of hospital scenario where I'm not with my armamentarium. So I have limitations of identification and interventions both. So what is important is I take a systematic approach. I take using advanced life support algorithm and a checklist, which will differentiate between a not so serious condition to a serious condition. We will talk about systemic ALS approach to define the physiological status of this child. We will try to identify the severity of the problem at each step using the IAP ALS algorithm or checklist. Keep the child stable by using the airway breathing circulation approach and treat the specific cause. And prompt and safe transfer to the emergency room depending on the physiological derangement is there in the child. And of course, if you find that this child has arrested, start with high quality CPR if there is a life-threatening situation. Now we'll just quickly talk about the limitations of out of hospital scenario. First of all, I have limited equipments of assessment available with me. I'm not carrying my entire bag. Then whoever is helping me, I've got inadequate and inexperienced help from the bystander. And in case I'm supposed to transfer this child, I've got a suboptimal way of transport in case transfer to the healthcare facility is needed, because the time is important. And it's a race against time. There is a need to act fast, and that too correctly. And add to it, in our scenario, we have got chappal, kanda, are usko pani maro, advised by the lay people. So you have to overcome all of these. So the first step is identify yourself as a healthcare personnel who is going to help this child. Second, check the scene safety. We are in the fields. There could be open electrical wires, there could be toxic gas leakages, there could be a reptile on the loose, or there may be a swarm of bees. And ask for the help and identify anyone who can help you and get a medical help from the nearby health center. And of course, you can always use mobile to contact the emergency service center. Now, I'm not going to go into the ALS lecture, but this is a quick recap. It's an ALS algorithm where we take an initial impression of consciousness, work of breathing, circulation, primary assessment of airway, breathing, circulation, disability, exposure, secondary assessment in case I'm not able to reach a diagnosis by doing a sample history and a focused examination. Diagnostics tests are not applicable in the fields, and an intervention which includes safe transport. And of course, after every step which is taken, if a physiological status is unstable, proceed with, in case the physiology is stable, you proceed with the further evaluation. But if you ensure that this child has got a life-threatening situation, you immediately have interventions, whatever are possible. When you talk about unconscious child and the list of the causes, there are multiple. In fact, it will involve at least 10 slides. But true to what will happen in a outside or in the fields is trauma, post-ictal poisoning, envenomation, electrocution, anaphylaxis, cardiac event, vascular episode, or maybe a complete airway obstruction. These are the important causes when you see a child who is found unconscious in a garden. So let us go one by one scenario. And the reason why this child has become unconscious, either if it is respiratory cause, then it's the hypoxia which has led to the child being unconscious. If it is circulatory, then it is shock, or it could be both, combination of both. And lastly, it could be a primary CNS insult. So let us go case by case. We have got a 1.5-year-old child who was found unconscious in the garden. This caption is going to remain same for all this. The initial impression, now we'll talk about the ALS language. Unresponsive, work of breathing is decreased. This child is pale, so needs urgent intervention. So I do a primary assessment. The airway is clear. The respiratory rate is 25 per minute. Whatever I can see, there is conducted sound which are heard. The pulse is 140 per minute, which I can do in the garden. They are weak volume. The CRT is more than 3 seconds. The disability, the child is unresponsive on AVPU scale, and the pupils are equally reacting because I have got a mobile with me to look at the child's pupil. The exposure showed me that this child has got a large swelling over femur and an occiput. And so this is probably circulatory insufficiency which has led to this condition. So I progress. So there is a history of trauma in this child, and there's a probably hypotensive shock secondary to volume loss. So what I do in the fields, what I do in the garden, I open the airway with the jaw thrust maneuver because this child has fallen, protecting the neck. I arrange for the transfer, taking care of the neck and splinting of the femur. I cannot do anything in the garden. And I shift this child to the emergency department with the airway protected. So this is hypotensive shock secondary to trauma. Now I've got another child who is 1 year old, found unconscious. Initial impression, unresponsive, work of breathing decreased, and this child is pale. Again, needs urgent interventions. The primary assessment showed that the airway had frothy secretions. The respiratory rate was 15 per minute. There were conducted sounds which I could see that this child has got some noisy breathing. The pulse was 130, but it was good volume. The capillary refill time is normal, skin is normal. And the disability again is unresponsive on AVPU scale, and exposure showed no abnormality. So probably there is some respiratory failure. I do not know the cause at this stage. And then I go for the secondary history, sample history, which is taken. This child was active 10 minutes back, and the caretaker told me that she threw a generalized tonic-clonic seizure for 5 to 6 minutes. Allergy medication past history, it's known epileptic on AED and had missed her dose on that particular day. Otherwise, nothing was contributory. So events, the child had thrown seizure, and after that, this child was in this particular status. Now I know what I'm dealing with. So this is post-ictal respiratory failure. So what do I do? Again, in the fields, I keep the airway clear, preferably keep the child in lateral position to avoid aspiration. If at all I have got midazolam spray, or the caretaker has got his or her midazolam spray with it, I use it and keep this child in recovery position. If the seizure stops, continue to monitor till the help arrives or this child is transported. And whenever is transported, again shift with the neck protected, shift to the ER with airway protected. So this is a seizure disorder leading to unconsciousness. Then I've got a 4-year-old child who was collapsed in a garden. Unresponsive, work of breathing is normal, ping. So probably I've got some breathing time with me. Assessment told me that his airway is clear, the normal respiratory rate, no accessory muscles working, breath sounds looked both sides normal, no adventitious sounds were heard. The pulse was 70 per minute, regular, low volume, CRT was normal and skin was cool. And then the history came that this child had seen something ghastly. The disability was responsive to painful stimulus on AVPU scales and the pupils were reacting. The exposure showed no injury, rash or petechiae. So this child was kept in supine position. Because of that history, whatever we got, we just opened the airway, we allowed the child's legs to be raised, allowed fresh air, and after some time this child responded in a couple of minutes. So now was awake, responding to stimuli and commands. So it was a plain simple syncopal attack. Now this child, again, another 2.5-year-old child, found unconscious, initial impression, unresponsive, work of breathing increased, and this child is pale. The assessment showed that the airway was clear. The respiratory rate is 20, gurgling sounds, and chest expansion is reduced. The pulse was 74, regular low volume, CRT was more than 3 seconds, and cool skin. And again, disability showed unresponsive on AVPU scales, so pupils were equally reacting to light. No exposure, no rash or petechiae. We stabilize this child by opening the airway. This child definitely needs to be transferred as early as possible. So there is both element of respiratory failure as well as shock. And what history came up was this child was active and playful 30 minutes back and was given by mistake medicine by the caretaker, now found to be nitrazepam. There were a couple of tablets which were given to this child. So otherwise there was allergies, medication past history was not contributory. So this child started becoming drowsy after 30 minutes of consumption of the drug. Again, the plan was to ABC stabilize this child by opening the airway and plan for the transfer. But we know that this is likely to lead to respiratory depression and needs further assistance. So needs to be shifted to the ER. Then we got a 15-month-old child found unconscious, was running fever and had not eaten anything. The initial impression was unconscious, work of breathing slightly increased, and this child was pale. Primary assessment showed clear airway, respiratory rate of 40, no adventitious sounds. Pulse was 130, well felt, and sweating was there. And disability was P. He was responsive to painful stimulus on AVPU scale. The pupils were equally reacting. No petechiae, no rash. No, this child was hemodynamically stable. Again, I knew that I've got some time on my hand before we shift or before coming to some conclusion. But we went into the secondary assessment. The sample history, this child was running fever and was refusing to eat. Allergy medication, past history not contributory. And the last meal was 8 hours back. And events were, as described, gradually became lethargic. So this history tells me that probably this child is having hypoglycemia. I wish I could do a point of care sugar test on this child. So this child was shifted to hospital, was found to have a sugar of 35. Hypoglycemia was corrected, did well. So this was a metabolic condition leading to unconsciousness. Then this is a unwitnessed collapse for a 9-year-old male child. Initial impression is unresponsive, work of breathing is absent and cyanosed. Now the question is, do I continue with my further assessment? The answer is no. The pulse is immediately checked. The pulse is absent. So this is a life-threatening event and we need to call for help. Suppose I am the alone person, I will call for help immediately, open the airway and start with the high quality CPR. And I need to follow the BLS algorithm. So call for help and call for the AED if available. Open the airway, start with CPR, chest compressions with all the standard routines of CPR, push hard, push fast, 100 to 120 till the time the help arrives. So this child was CPR was continued, the help arrived in form of AED. The rhythm was identified as ventricular fibrillation. The shock was delivered, CPR continued, and the sinus rhythm restored after a while, and it was shifted to the PICU for the further post-resuscitative care. And the history revealed that this child had a cardiomyopathy and was prone for arrhythmias. So was picked up right at time. So it was ventricular fibrillation, and what helped this child was timely availability of the AED. The other, so let us take a quick look at the what do we do in the cardiac arrest. We open the airway, we start with the chest compressions depending on the size of the child. It's an infant, then we use 2 fingers or 2 thumbs techniques depending on whether you have 1 rescuer or a 2 rescuer, and a prompt use of AED which is required. Then we have got a 2-year-old female child who has witnessed collapse. The initial impression again is unresponsive, work of breathing is absent and cyanosed. Again pulse check, no pulse. Life-threatening event, call for help. So we have to again follow the BLS algorithm. So open the airway, started with high CPR. Rescue breath did not produce enough chest expansion. So on opening the mouth, we realized that this child has a candy which this child was consuming. So this had caused the complete obstruction. So despite giving resuscitation, if the child is not improving, you have to think of first thing, especially in a collapse which has happened in front of you, because it's an acute sudden condition. So fortunately for this child, the candy could be removed from the mouth under direct vision and the CPR was continued. After a while, this child started having respiratory efforts, was put in a recovery position, but was shifted to ER for observation because the child has just undergone almost an arrest. We had arrested. So we have to think from that angle. So this was the foreign body. So quick recap for the foreign body. If the child shows universal sign of choking, then you can give Heimlich if the child is slightly elderly. And if it is an infant, then you can use the chest thrust or the back slaps to the point that the child removes the foreign body or the child becomes unconscious, where the CPR is continued. Then we have got a 4-year-old child who was found unconscious. Again, initial impression, unresponsive, work of breathing reduced, pale. The primary assessment showed the airway was open, respiratory rate of 12 per minute, gurgling sounds, pulse of 80 regular, and the CRT was more than 3 seconds. Actually not good volume, the child had a low volume pulse, and this child is unresponsive on AVPU scale. There were no petechiae or rash seen. So what is the cause for this respiratory failure? So this child was playing in the fields, was fetching a ball from the bushes and hour back and continued to play. After a while, this child started gradually becoming lethargic and then was found in this situation. There were no caretakers around, and after some time he was found to be lying there. The alleged medication past history was not contributory. Events were as described, and focused examination now revealed 2 tiny marks on the hand. So probably we were dealing with a snake bite. This child needs assisted ventilation. All I can do in the fields is open his airway. If I have got a bag mask, which is not a likely situation in a garden, so I have to see to it. In case this child is gasping, maybe we'll have to start with giving a rescue breath, mouth to mouth, keep aside the COVID protocol. Okay, and rush this child to the emergency room. And of course, this child was transferred to the ER in supine position, treated for snake bite, and has recovered. Then we have got a 6-year-old child found unconscious, unresponsive, and work of breathing was reduced and pale. An accompanying person informed me that he was bitten by honeybees. Open beehives was seen nearby. And primary assessment, there was frothing at mouth, respiratory rate of 10 per minute, efforts were reduced, adventitious sounds were heard, and the pulse was 80 per minute, weakly failed, CRT prolonged, extremities cool. The child was again unresponsive on AVPU scale, pupils equally reacting, and there was exposure showed the bees of marks of bee stings were seen. So respiratory failure, circulatory insufficiency, most probably anaphylactic shock. So First of all, again, I need to take care of the scene safety. Like unlike earlier condition where probably the snake had bitten and the field was clear, over here, there is a swarm of bees which are seen. So I have to take this child to a safe place. Open the airway, ideally needs back valve ventilation simply because the child's breathing is already suffered, and ideally would require injection adrenaline at the site. So shift with the airway protected. Timely epinephrine at the site actually would be ideal. So this child again had anaphylactic shock, was shifted to ER. So anaphylactic, I mean epinephrine, Effieject, if available, should be or could be used. Then we have got 7-year-old child lying in the garden after touching the electric pole. Again, check the scene of safety, used the wood to dislodge. Initial impression, unresponsive, work of breathing was absent. Life-threatening event, call for help, used algorithm. Again, AED was used, shock was delivered. This was a case of electrocution. Again, AED would have helped this. And this has happened just 3 days back in Raipur. Now, I'll just go quickly through this. I'll not use the, what is important is whatever initial impression, primary assessment, secondary assessment we talked about is all available as a checklist. If the child is alert, you proceed with evaluation. If this child is unresponsive, you call for help. I'll talk only about the green and the red ones. If the child's work of breathing is normal, I proceed with evaluation. If the child is gasping, not breathing, start chest compressions. If the child color is pink, proceed as appropriate. If the child is bleeding or the child is cyanosed, then I'll have to rush with my actions. Same with airway. If the airway is clear, I support the breathing, and if it is unmaintainable, I think of immediate transfer. Same happens with your respiratory rate. All these are there in the ALS checklist group. So the red ones are the ones which are important as we see in the fields. Okay. So assessment of the circulation is also same. So we'll not go into the details of this. I'll just focus on this GCS score. We cannot go on doing the Glasgow Coma Scale or a modified Glasgow Coma Scale in the fields. What I need is I have to see quick assessment, because I know that a GCS score of more than 12 is an alert child. GCS between 9 to 12 is responding to voice. Monitor this child closely, and if it is less than 8, then it is either painful stimulus or unresponsive. Arrange for immediate transfer for such a child, because we are probably going into the danger zone. And this is a rough correlate of GCS between this. Just give me a couple of minutes. And of course, if the child on exposure is found to be cold, again, we'll have to think of transferring this child as early as possible. So this is a rough correlate. And again, when we talk about disability, one of the important aspect is a point of care test, which is a part of disability and which is not difficult. We will see what I'm trying to say. So the plan of action is, if the child is stable, call for help, be with the child, watch for the deterioration, preferably keep this child in a recovery position. If it is respiratory distress or a failure suspected, give position of maximum comfort, arrange for transport, accompany the child till it reaches the healthcare facility. This is most important. And for respiratory failure, open the airway, give assisted breathing if equipments are available, and transfer this child as early as possible. And while transporting, ensure cervical spine protection. In shock, again, open the airway, arrange for the quick transfer. And when we talk about shock, if there is a bleeding site which is there, always, of course, we have to compress and stop the bleeding to prevent further loss. And for a cardiac arrest, of course, call for help and start with the high quality CPR. So this gave me a thought as to what I can do for a child who is there lying in the garden. So all of us are moving in a vehicle, either if it is two-wheeler or a car. What are the equipments we can carry which can definitely help? Because the situation can arise anywhere. So a face shield, a bag mask, ambu bag, maybe LMA depending on your level of your skills. Pulse oximetry, glucometer, which is not a very difficult thing to carry. A portable BP apparatus plus minus, stetho, digital thermometer, and preloaded epinephrine, midazolam nasal spray. These are the things which can be used and which can be kept in your kit, which will not occupy too much of your space in your vehicle. So these are the things which I'll definitely think. And at the community level, access to emergency services, the AEDs, which are gradually becoming available in public places, and more people trained in BLS, because unless I've got people who are helping me in the BLS, I'll not be able to help this child, maybe alone. And of course, a well-equipped ambulance whenever this child needs to be transported. So all one need is two hands and a willingness to help, be it the garden, be it any open space. And I thank all the organizers for allowing me this talk. Thank you.
Thank you, Dr. Naniwadikar, for taking us through the excellent talk, right, from all the emergencies that you can manage on field, the systemic emergencies, right, from bites to stings to accidental consumption of drugs to trauma, and how you would go about it on the field. Thank you so much. And especially the last two slides were very important take-home messages for all of us, that we need to know the emergency services that are available in our area, the AED ambulance services that are there that can help us in the time of need. And I think most of it, all of us know, but thank you for taking us through that excellent journey. Thank you, sir.
For our next talk, I would like to call Dr. Ramakant Patil, sir. He is alumni of BJMZ 1981 batch. He is a founder of Nelson Hospital, past IIP Nasik branch president, and he is a EB member, Central IIP 2020.
Sometimes it becomes difficult to differentiate those types of rashes, and COVID and post-COVID my parents somewhat confusing. So now let's listen to what speaker how such cases.
Thank you for those kind words. And we are approaching to the end. Thank you, chairpersons. This question has come in NEET PG, that 3 years child with fever and rash on day 4. What is your diagnosis? So one who is finished internship, he should know the diagnosis. And that too in some 30 seconds or 60 seconds. He has to finish those questions into 180 minutes. So I think we should know all this. What is important is that any child who is coming with fever and rash, before approaching, as Nani has told us, that whether the child is stable or not. Because a child with fever and rash on day 4 may be having some serious problem. So we will first find out whether the child is stable, vitals are stable or not, and then we'll start evaluating the child. Otherwise, we'll start supporting the child, support the vitals, and then simultaneously take the history. As our living legend has said that you have to have the diagnosis on history. If your diagnosis is not there on history, then either your history is incomplete or you are incomplete as a physician. So we should have diagnosis on our history, clinical examination, and our investigation should be confirming our diagnosis. They should be more of a confirming, or in some cases we have got differential diagnosis 2 or 3, and to come to one diagnosis that should help us in investigations. Most of the time we go for that misapproach. We manage first, then investigate, then we see for the signs, and then we ask the symptoms. So that should not happen about this miss. Unfortunately, this miss disease is very common among us. So that we have to strive hard to go for the history and proper clinical examination, and that will definitely give us a diagnosis. So as sir has told us many times in our history books, fever, there are 2 complaints here. There is a fever and rash. When there are 2 complaints, we have to take onset, duration, progress of each complaint, and which is the major complaint. So in fever, whether the fever is having high grade fever with onset, or whether it was moderate or low grade fever, how was the interfebrile period, a response to paracetamol, whether patient the fever is rhythmic or erratic, what is the condition on day 3, day 4, whether progress, how the patient is stabilizing or it is same or it is localizing. As to start with, I have said to rule out serious illness and look for the localizing signs. So we may have the diagnosis to start with very early in the history. Similarly with the rash, in rash what we particularly see, whether there is a prodrome, and that will definitely tell us whether it is infective, what sort of infective, how is the evolution of a rash, whether it is a cephalocaudal or centrifugal or centripetal. Associated symptoms definitely help in localizing the cause of the rash or determining the cause, and also to have the history of exposure to person having similar rash, infection, or insects, particularly ticks or particular area, animals, dogs or cattle,
and time of the year. Leptospira in our Mumbai in monsoon season, monsoon maladies, travel, drug exposure, because many times it may not be the infective cause, or it may be the inflammatory or allergic cause for the rash. So in rash, on clinical examination, what is important is the morphology, distribution, how it is distributed, how it is associated with the fever, whether it is coming on the day 1, day 5, or how the fever, blanching, non-blanching, mucosal involvement or not there. So this is the morphology. It is very basic. What is papule, what is vesicle, what is pustule. We all know this, but to complete this presentation, I have given here one more only important is that SR, which many times we do not look for the SR, and SR is usually seen in the folds, skin folds, and in study they have seen nearly in 66% patients, nearly 35% were around the nappy or in the below inguinal region or perianal region, and nearly 27 to 28% either in the skin fold, neck fold, or the axilla. So these are the area where we have to look for the SR. SR very rarely is evident on the exposed part. So SR is to be seen. And what other things we definitely know what is difference between petechiae and purpura. So how does morphology help us in differentiating the fever and rash? If it is a maculopapular rash, we know all exanthematous fevers like measles, rubella, erythema, infectiosum, exanthema subitum, then infectious mononucleosis, chikungunya fever. These are all giving rise to maculopapular rash. But non-infectious diseases like SLE, systemic onset, and Kawasaki can have any type of rash, many types except vesiculobullous. So these are the different, if the maculopapular rash is there, this is the etiology. Diffuse erythematous is seen in scarlet fever. It is red diffuse erythematous. It is not a maculopapular. And with discommation, then it is seen in the diffuse erythematous with discommation. Either it is a scarlet fever, excessive discommation if it is present, then it is a streptococcal or staphylococcal scarlet skin syndrome or toxic epidermonecrolysis. And in cases of Kawasaki disease, we can see it in hand and feet. Diffuse erythema can be seen on day 6 of fever or day 5 of the fever. Then vesicular rash is seen only in like chickenpox and hand, foot, mouth disease. Chickenpox is again a central, and hand, foot, mouth disease is again a periphery, which is again not rather than hand, foot, it is a elbow, knee, because we are seeing all the vesicles on the elbows and the knees rather than on hand and feet. And very rarely, very few lesions are seen actually in mouth, only on tongue it is seen. Then petechial purpureal rash, we don't know that. Fortunately, meningococcemia, I have seen last case in when I was at that time. Now JR3 is not called as JR3, but we were called CR at that time. So that is the last case I have seen as a meningococcemia. But petechial purpura is seen in dengue fever, and dengue fever do have different types of morphology, 3 different types of rash. Urticarial rash can be seen in some infective cases also, like infectious mononucleosis and Coxsackie, and other uncommon infections which are we already only read in the textbooks like Yersinia, Borrelia, and Coxella burnetii. Nodular rash, like a rash which is tender, which is seen, that is also called as erythema nodosum, which is a tender rash, which is seen in many infective cases, particularly tuberculosis and some drugs. So this way helps in the morphology, how the morphology of the rash will help in coming to the diagnosis. Distribution, again, I have told that which is central, vesicular if it is chickenpox, peripheral vesicular, then it is hand, foot, mouth disease. Then if it is maculopapular rash, central, spreading from cephalocaudal, then it is more likely to be measles. Whether it is a blanching or non-blanching, if it is blanching rash, it is more likely to be the petechiae purpura, which is we are seeing. And if it is a this thing, all exanthematous lesions are most of the time blanching, and the petechiae purpura are non-blanching lesions. Mucosal involvement is important because exanthems are most of the time enanthems also. The mucosal involvement is called as enanthem. And if few exception will differentiate, like erythema multiforme major will have mucosal involvement. But if there is no mucosal involvement, we call it as a erythema multiforme minor, and depending on surface area. Similarly, in staphylococcal scarlet skin syndrome, mucosal involvement will not be there, which will differentiate it from your toxic epidermonecrolysis. So this way, it will definitely help us whether it is a whether mucosal involvement is there or not. And this is the mnemonic. We always laugh at the mnemonic, but it helps in this determining, particularly for exam cases. So relation of rash to the fever. And this mnemonic is that very sick person must take a double treatment. That first day, if there is a fever, that will be V for varicella. Second day, it will be scarlet fever. Fortunately, smallpox we are not seeing. Measles, day 4 it is seen. Typhus, that is rickettsia, usually we are seeing on day 5. Dengue, it can come on day 1 also. It can come on day 4, 5 when it patient is critical, and day 6, 7 when patient is improving. But for the mnemonic sake, we have taken it as a day 6. And typhoid, if the rash is there, it will be on day 5. So these are the some pictures of measles which are saying the maculopapular rash starting behind the ear from the face. What is important, I am going to tell you about measles. But only thing, many times patient come to us and they say he had a measles and twice he had measles. So the measles progression will be at least for 8 to 10 days. It will not that measles rash has appeared on day 1 and it was better on day 3. It progresses like behind the ear from the forehead to the face and chest, and it resolves in the same manner and with the fine granular disformation, and it takes at least 7 to 10 days. It will not be over in 2 days. And coplic spots, it is always given a significance, but it is seen only in 20% cases. But if it is seen near the second molar, it is a pathognomonic of measles, and because we don't have to do any investigations for that. Rubella, the measles is rubeola, and rubella is again many times it is a evanescent. It is over in 2 to 3 days. So whatever many times patient tell us that there was measles, it was probably a German measles, not the measles. Only thing is that we get a posterior auricular lymph nodes, preauricular lymph nodes in cases of German measles. Varicella, we say what is important is that if there is a, it is a pleomorphic. What is pleomorphic? You will say on same day you will see a papule, you will see a vesicle, you will see a scab also, and sometimes pustule also. And it is a erythematous base. The base is red, so it appears as a rose, and there is a fluid-filled vesicle, so it appears a dew on the rose petal. This is the varicella, which is seen more on the trunk, and it will be pleomorphic and erythematous base. You are sure that it is a varicella. And fever usually subsides in 2 to 4 days. Erythema infectiosum, these are all were called as first to 6 diseases, like measles first disease, scarlet fever second, German measles third disease, then erythema infectiosum is a 5th disease, and exanthem subitum is a 6th disease. Fortunately, erythema infectiosum is not very common in immunocompetent children. Even if it does happen in immunocompetent, it is a disease of more of a immunocompromised children, and it is a reticular lacy. I will like to express all these pictures from our IAP action plan for fever and rash. Some pictures are of mine, but many of the pictures are from that IAP action plan of fever and rash, and I owe thanks to them, to express my thanks to them. It is caused by parvovirus B19 immunocompromised, and this lacy rash, if it is seen, it is a erythema infectiosum. And this is a roseola infantum or exanthem subitum, also called as 6th disease. It is caused by HHV6 virus, and the fever is there for 3 days, and fever lysis or disappears, and the rash appears, and it appears like a slapped cheek. This is again a many times benign, but it can cause aseptic meningitis, encephalitis. Most of the time, this may be the cause of febrile seizure also in patients who are having fever with rash and convulsion, and when the fever disappears. This is scarlet fever. Fortunately, we are seeing very less number of cases. In scarlet fever, it is particularly one of the cause of strawberry tongue in addition to Kawasaki disease. There are signs like that reticular erythematous lines are seen on the elbow, which are called as fascia lines. The rash, the edema may be there on the face, but the rash is not there on the face. Face is spared in case of scarlet fever, and it is erythematous and granular rash is there. That's why it is called as a sandpaper-like rash. It is again caused by streptococci. Epstein-Barr virus, which is also infection, is also called as infectious mononucleosis or glandular fever or Pfeiffer disease. Maculopapular rash, in 50% cases, it gets exacerbated by ampicillin or amoxicillin. I find the pseudomembranous tonsillitis, the whitish tonsil, if the membrane is there, because we are not seeing diphtheria cases, but in cases the pseudomembranous tonsillitis is there, most of the time, at least 50% cases, it will be infectious mononucleosis. Second important point in infectious mononucleosis, my personal observation, and is that recent onset snoring, the child who was not snoring, who has got fever, some rash, and if he develops snoring, then it is, and if more likely to be infectious mononucleosis. And we are not doing monospot test or all these things, doing the viral capsid antigen, EBV, VCA, IgG and IgM, and that will definitely clinch the diagnosis. And it doesn't need a treatment, fever on reassurance, only in cases of immunocompromised patient. There is definite papers are there. It gets helped by using IV acyclovir or valacyclovir. This is very typical rash we are seeing day in and day out. What is the impression of the palm? It is called as a dermographism. And this is seen on the day 1 or 2 of the dengue fever rash. This is the rash which is typically seen in the dengue fever. And these are the different rashes which is seen in dengue fever. This is the rash which is called as a white islands in the red ocean. This is the rash which is appearing on day 6, which predates that this patient is likely to improve now, and platelet count and overall clinical improvement will be there. So 3 types of rash. Prodromal phase has got a diffuse erythema with dermographism and hyperemia. The transient macular rash might be there. In critical, it will be a marbly formed maculopapular rash sparing palm and sole. And in differvescence, that what I told, normal skin island, white skin island in ocean of red, it is suggestive of good improvement with rise in platelet count and overall clinical improvement. Chikungunya, we were not seeing any rashes, but in this season, last 4 or 5 months, we have seen very different types of rash in chikungunya. We have seen that it is a maculopapular rash also, but we have seen bullous also. This picture is of mine, my patients, who have got a chikungunya with bullous, and how to confirm that? Because many times we are sending IgM, but IgM becomes positive on day 10 to day 14. And if you are doing IgM of chikungunya on day 2 or day 3, then it will be that it will come negative also. It will come negative. So the diagnosis in first 6 days will be chikungunya RT-PCR, which clinches the diagnosis, but it is costly, nearly costing 4,500. But our search stops. What is the cause of this bullous lesion? What is the cause of fever? What is the cause of erythema and rash on the pinna, which is a very diffuse erythema is seen in many cases of chikungunya. Fortunately, a pediatric patient have got only arthralgia there in chikungunya, not arthritis, but few unfortunate can have even arthritis, and the pain can last for even 6 to 12 weeks also. But if you have got diagnosis in hand, you will stop the search and just reassure the patient and give analgesic as and when required. This is one of the underdiagnosed, and we have seen Dr. Atul Kulkarni presenting different types of rashes in rickettsial fever. Most important is that if it is a scrub typhus, SR has to be seen. It is seen in nearly 60% of the cases. If it is a Indian tick typhus, it will be a morbilliform or maculopapular rash. And unfortunate patient, we may have the gangrenes of hand and feet and even pinna, and which is called as a Kankapya disease in southern Maharashtra and border of the Karnataka. So what is important, we have to find the evidence of tick, history of area going to the tick. In US, dogs are the commonest cause of vectors for the ticks. In our country, it is cattle, and it is also called in local areas the Gochid Tap. So you have to find out the tick, and many times the live tick might be there on the body. We have to search for that. Many times fever disappears along with the doxycycline. Doxycycline has been recommended in textbook, now Nelson textbook also, for from 2 years. So our fear of not using it below 8 years should be taken away. If it is indicated, we can use it after 2 years. Gangrene and this thing is uncommon, fortunately, in initial phases. Hand, foot, mouth disease, we all know that it is caused by 2 enterovirus and Coxsackie virus. Coxsackie virus A16 has got a milder course. Enteroviral 17 has got a severe course. More often neurological signs are seen. Herpes simplex, these are the different herpes simplex, which is primary. Then this virus go into the sensory nerve roots, and whenever because of fever or there is immunosuppression, transient is there, it comes and it causes a recurrent. The recurrent herpes usually at the mucocutaneous junction, not on the mucosa, but primary can be on the mucosa, which gives rise to herpetic gingivostomatitis, genital herpes, and Whitlow also. Whitlow has to be differentiated from your painful this thing. Staphylococcal or bacterial infection of the nail bed, and this herpes Whitlow, because the treatment is altogether different. So we have to differentiate it from. And herpangina is not caused by the herpes virus. It is caused by Coxsackie virus and doesn't need any anti acyclovir. Staphylococcal scarlet skin syndrome, this is again a fever with rash, positive Nikolsky sign, and the mucosal involvement is not there, and culture will be negative because this is a toxin mediated. I don't want to go into details of this. Fortunately, meningococcemia is also not common. Again, Kawasaki disease, as I told you, will have different types of rashes. It will have diffuse erythema on the fingers and the palm. It will have morbilliform rash, and it can have the discommation. Discommation does occur nail bed after 12 days. So we have to find out which are the rash which are localized. And in addition to fever for 3 days, and other 4 signs, at least 3 signs should be present. Otherwise, if we are diagnosing after 10 days, then we have lost important time to give IV immunoglobulin in Kawasaki disease. These are the different pictures of Kawasaki disease. These are the picture of Steven-Johnson syndrome, erythema multiforme major, and toxic epidermal necrolysis. This is a spectrum. Only thing they are saying that erythema multiforme is because of viral infections, and Steven-Johnson syndrome is mostly because of the drugs. When the area is less than 10%, it is called as Steven-Johnson or erythema multiforme. When mucosal involvement is not there, it is erythema multiforme minor. When it is 10 to 30% area, it is an overlap between Steven-Johnson and toxic epidermolysis necrosis. And if it is the area is more than 30%, then it is called as 10 or toxic epidermonecrolysis. These are again the same different pictures. Drug rash can be manifested in different ways, like immunological reaction, type 1, type 2, type 3, type 4, dose related, non-immunological. Only important thing is that it will be most of the time history of drug will be there, ingestion, itching many times present, and we have to rule out other causes. And most important is the withdrawal of the drug is important. If it is IgA mediated, there will be itching. If it is not IgA mediated, then itching will not be there. Dress, for want of time, I will not go into this, but this is one of the important. If you have got a multi-system involvement, like you have got a hepatitis also, pre-coma, coma, patient has got facial edema and the rash. If this is there, and on peripheral smear, if there is a eosinophilia is there, because mortality is very high in drug rash with eosinophilia and systemic symptoms. So dress is one of the important differential diagnosis, and one has to keep in mind. Erythema marginatum, fortunately, because of antibiotic or what, I don't know, but we are not seen the cases of rheumatic fever. I have not seen a case of rheumatic fever in last 5 years. In again, the serum sickness like reaction. Other non-infective causes of rash are like collagen vascular disorders, like this is rash, malar rashes, which is seen in case of systemic lupus erythematosus. Heliotrope, violosis rash, all calcinosis or Gottron papules, which are seen in cases of dermatomyositis. And last but the least, in this not yet to old normal COVID cases, the COVID different types of rashes are there, but no rash is pathognomonic of the COVID. So only COVID test, whether it is because of again vasculitis or what, we have to find out the cause, and if it needed, we will require the anti-inflammatory treatment and even steroids also for that. Erythema nodosum, this is a painful tender rash is or nodular rash is erythema nodosum. Again, it is caused by many beta hemolytic streptococci, mycobacteria.
Sir,
Fortunately, we are not seen any cases. I am summarizing in last 5 seconds. So fever with rash has exhaustive list of cause. Identifying seriousness, shock, third spacing is important, and then evaluate. Proper history, stepwise approach, and temporal correlation with rash and fever is most important. And as living legend Dr. Amdekar sir always say that your diagnosis should be there on the history. If it is not there on history, either your history is incomplete or you are incomplete as a clinician. Thank you for your patient listening.
Thank you, Dr. Ramakant Patil. You have extensively described all the cases of fever with rash, and we have revised everything. Paying tribute to our teacher, Dr. Amdekar, we should all examine all our patients thoroughly, look for rashes, not be in a hurry to just finish off our OPD, examine every patient in details, and vaccination can prevent some of these rashes. We can give measles vaccination, and we can give varicella vaccine, meningococcal vaccine, and use all the drugs and antibiotics very judiciously so that we don't land up with Steven-Johnson syndrome. Thank you, Dr. Ramakant.
Thank you, sir. I would like to request sir to collect his memorandum from the Dr. Wagre sir from that side. Thank you, chairpersons. You can collect your memorandum from there. Now we have very short 5-minute session of Dr. Arun Katkar sir. He is a SMO WHO. I requested to finish within 5 minutes only. Thank you, sir.
Thank you, sir. Good afternoon to all of you. I'm Dr. Katkar, working as Surveillance Medical Officer in WHO, Thane unit. As you all know that Government of India has launched various public health surveillance activities in our country. So I will just speak on vaccine prevented disease surveillance and how we can strengthen this VPD surveillance in our country. I will discuss about the 6 VPDs. Basically, I will discuss on case definition as well as what is the current status of surveillance in our Maharashtra state and how we can support the program. Now, first is measles and rubella. I think thanks to Dr. Patil sir, he has already given all the details about measles and rubella. So he has made my work very easier. See, India is committed to elimination of measles and rubella by year 2023, which is very ambitious target. We have already lost about 2 years with COVID pandemic. So, and you all know that if you want to eliminate or eradicate any disease, we have to have a very good surveillance system in place. So here you can see the revised suspected measles case definition, which we are supposed to report. Initial definition was fever and macular rash with any one of 3 C's, cough or coryza conjunctivitis. But now all 3 C's are taken out. And now the revised definition is any person with fever and macular rash, that case has to be reported as a suspected case of measles. Or any person in whom clinician or health worker suspects measles or rubella infection, that case also can be reported. So all cases of fever and rash, irrespective of diagnosis, I think Dr. Patil sir already showed all the differential diagnosis. So we are supposed to report all cases of fever and rash, irrespective of diagnosis, irrespective of age, and can be reported within 3 months after onset of rash. Here you can see the current status of surveillance in Maharashtra. The most important cardinal indicator is non-measles, non-rubella discard rate. And here it is 1.7 in 2021. Ideally, it should be 2 or more than 2 per 1 lakh population in each and every district and in corporation. So here it is less than 2. So my humble request to all of you to report all cases of fever and rash, irrespective of diagnosis, so that we can reach 2 marks. Then let us come to polio. As you know, polio this year in 2021, we have only 2 cases in the globe, one in Pakistan and one in Afghanistan. We have already eradicated P2 and P3 wild polio virus, as you all know. And as for our country is concerned, the last case was detected in 2011. So already 10 years have passed, we do not have any confirmed case of polio. Now, how we find out a case of polio? By doing AFP surveillance, as you all know. The definition is sudden onset of weakness or floppiness in any part of the body in a child less than 15 years of age, or a person of any age in whom polio is suspected. So that case can be reported as a AFP case. Okay. What we do is we collect the 2 stool samples and we send it to the lab for isolation of wild polio virus. Now, if you see the status, surveillance status in Maharashtra, the AFP cases are slowly going down over the period of last 3 years because of pandemic. So my request to report all cases of AFP so that we can improve our AFP surveillance in our Maharashtra as well as in our country. Now the diphtheria, a suspected case is defined as an illness of upper respiratory tract characterized by the following: laryngitis or pharyngitis or nasopharyngitis or tonsillitis and adherent membrane of tonsils or pharynx. So what we do is we collect 2 throat swabs and we send to the lab. Similarly for pertussis, here you can see the definition. A suspected case is a person of any age with a cough lasting for 2 or more than 2 weeks with at least one of the symptoms like fits of coughing or inspirative whooping or post-acid vomiting, or clinician suspicion of pertussis. That case can be reported as a suspected case of pertussis. So all cases of diphtheria pertussis can be reported irrespective of diagnosis, irrespective of age, and can be reported up to 3 months after onset of And neonatal tetanus, the case definition is any neonate who could suck and cry normally during first 2 days of life, and who between 3 to 28 days of age cannot suck normally and becomes stiff or has convulsions, spasms, or both. Or any neonate who died of unknown cause during first month of life. So if you see the surveillance status, the suspected case of diphtheria and pertussis are going down in our country, in our Maharashtra. But still we have lab confirmed 14 lab confirmed diphtheria cases out of 64 cases which are reported in our Maharashtra. So we are getting positive cases. And this is all about VPD surveillance. And lastly, the AFS surveillance, adverse event following immunization. It is defined as any untoward medical occurrence which follows immunization and which does not necessarily have a causal relationship with the use of the vaccine. So that case can be reported as a AEFI. And this is a letter from state IIP issued for the notification of all these VPDs, what we have discussed just now. And we have given the names and the contact numbers of all the surveillance medical officers of WHO and the districts allotted to them. So if you come across any case of VPD, please report the case either to the RCH officer of the particular district or to the surveillance medical officer of WHO. So without your support, I think it is impossible to have a very good quality or bold surveillance system in place. And because of you only, actually, we have almost eradicated polio and we want to eliminate measles and rubella. That's all from my side. Thank you. Thank you very much.
Now for our last session. Today, as the name says, mood board and panel discussion. It's a panel discussion. And the panelists are Dr. Mahesh Kalra sir, Dr. Satish Agarwal sir, Dr. Sameer sir, Dr. Ravish Hook sir. While the court will be handled by Dr. Satish Tiwari sir.
Dr. Satish Tiwari sir is a professor of pediatrics. He is well known in a medico-legal issues and he is the editor of textbooks on medico-legal issues. Also, Dr. Satish Agrawal, he is from the Amravati. Dr. Sameer Sadavarte, he is from the Fortis Hospital in Mulund, and he is an intensivist. Call them on the stage. Dr. Rajesh Bob is a Vice President Maharashtra IIP and he is the immediate past National Treasurer of Medico-Legal Group of IIP. Dr. Mahesh Baldwar, I would like to call him on the stage. I will hand over for further proceeding. I would have like mic to Dr. Satish Tiwari sir. Dr. Mahesh Baldwar sir will be joined digitally. A unique concept.
Friends, we are about to witness a new exciting session. All quiet. Don't cry, but stay put on your seats. Do not raise any objection or you will be overruled. My lord, we are all in attention. Over to you, sir.
इसको थोड़ा सा तिरछा कर देते तो ये इधर में सबको फेस करेगा एडवोकेट को। तो ये इधर सामने से कर दे।
नहीं तो मैं ऐसे कर रहा था।
हाँ
सर बोले ऐसा सीधा
नहीं इसको थोड़ा सा ऐसा करते हैं। हाँ वो ज्यादा अच्छा लगेगा सामने उसको फेस करेगा तो। हाँ इसको ऐसा। अब तो हम लोग आएंगे ना ऊपर। हाँ आपको अभी थोड़ी आना है ना, अभी तुमको नीचे बैठना है, अभी सर करेंगे अनाउंस और जब आवाज आएगा जब आना, तो सर करेंगे ना पहले, अभी दोनों एडवोकेट नरेट करेंगे उसके बाद में, तुम्हारा अभी नहीं आना। आपलं क्लियर आहे ना पूर्ण? पेपर इथे सर बसणार, तिवारी सर हे जज आहेत, गंगोले सर इथे मी बसणार, ते पण मी बसणार. अभी लगेंगे नहीं ना, रहेंगे, रहने दो रहने दो। तो गमले से ऐसा तो यहीं से भी आवाज लगा देंगे हम। हाँ वही लगा। हाँ बस चलेंगे। चालू होते भाई।
Thank you, organizing committee, for giving us this opportunity to have a panel discussion in front of this August gathering of Mahapedicon at Alibag, Raigad. Now, usually panel discussion involves question answer from the audience, and if the audience does not have any questions, then of course we have a pre-prepared questions. This time we tried to slightly modify, and rather than having a panel discussion, we are going to have a moot court, which will cover how a case is defended in the court of law. So basically we'll be having a type of short drama of the courtroom proceedings. And after that, if there is a time, or if the delegates and other faculties are interested, we can have some important question answers from those who are present in the program. So we'll start with the courtroom proceeding, and I request to start the courtroom proceeding. And if you have any questions, we'll take it at the end.
I would like to invite Judge on the table, on the dais. Case number 8, Mr. Ranjit Gulait versus Rajesh Boop. Mujrim Hajir ho. Mujrim Hajir ho. Case number 8, Ranjit Gulait versus Dr. Rajesh Boop. Muslim Hajir ho.
Order, order. So let us start with the case. Mr. Ranjit Golai versus Dr. Rajesh Boop.
My lord, myself, Advocate Gangulia, would like to narrate a case. My client, Mrs. Ranjita. She is a fourth grader with a no life issue and was registered under the its gynecologist Dr. Samir Sabharwati during her pregnancy for his expert care. Her pregnancy was precious as she had 2 abortions and 1 premature baby at the age of 15 days. She was regularly following up with the Dr. Samir Sabharwati. On completion of 38 weeks, we went to Dr. Samir Sabharwati and who told us out of the grid to get admitted to for the planned LCS. But we said, let nature take care of that and let pain start naturally. One midnight, she passed few plots per vagina, for which she was consulted Dr. Samir, who asked her to get admitted immediately. After hospitalization, she went in labor, blood pressure was going down, and the baby's heart was started falling. Owing to the critical condition of both mother and fetus, she was shifted to OP, and cesarean section was performed without any difficulty. Mother was given blood transfusion during surgery, and she had lost significantly quantity of blood. By the way, you have not taken Dr. Mahesh Baldava virtually. Dr. Mahesh Baldava virtually DIP. Look. Yeah, please take care of that. Take Dr. Mahesh Baldava virtually. The baby did not cry and had already passed meconium. The anesthetist then attended the baby, who was left the attendant. After about 5 minutes, the child specialist, Dr. Rajesh Bhu, arrived and asked the baby to shift to his nursing home. The baby was discharged on 15th day. On follow-up at 6 months, it was noticed that the baby had delayed consciousness. Being educated parents of what maybe they could find that the birth asphyxia is a cause of cerebral palsy and mental retardation. They got shocked and it was a huge blow to them. What they came to know that this cerebral palsy is incurable and also about the future physical, mental, social, and economic consequences of the cerebral palsy. Your Honor, the society assumes doctors almost next to the God, and after that we find the doctors and hospitals are no more service providers. Instead, they have become money-making machines. They don't attend their patients with due care and education and leave them at their mercy of the juniors or the stars who are most of the times unqualified and untrained for the substandard quality. My submission, the honorable court is that this is a clear case of negligence on the part of Dr. Rajesh Bhu, as he was not present at the time of operation and the precious time the baby the precious time was passed. Documents were demanded but were not given, and the client was charged exorbitantly for the care of the baby. That's all.
What do you want to say on this?
Your Honor, myself, Advocate Satish Agrawal, being assisted by Advocate Sudhita Ingre, representing my client, Dr. Rajesh Bhu. I compliment my learned friend Advocate Ganguly ji for his excellent narrative, but unfortunately it is far from truth. तथ्यों को तोड़-मरोड़ कर पेश करना कोई इनसे सीखे। इन्होंने हाथी का एक पैर पकड़ लिया, उसको पूरा हाथी बता दिया।
एडवोकेट अग्रवाल, यदि आपके पास पूरा हाथी है तो आप थोड़ा हाथी के बारे में बताएंगे?
Sure, Your Honor. Your Honor, the incident goes like this. Mrs. Ranjita, wife of Mr. Suresh Golait, was a high-risk pregnancy because she was a precious pregnancy and she was under treatment of the renowned gynecologist of the city, Dr. Samir Sadawarte. She was under regular follow-up of Dr. Samir Sadawarte, who advised her planned LSCS after completion of 30 weeks of gestation. But the mother and the relatives refused. They said that when the pain will start, we'll come for the Caesar. And when the emergency ensued, she was taken up for emergency Caesar. So the negligence lies on the part of the mother and the relatives. After Caesar was performed, baby was kept in the intensive care unit of Dr. Rajesh Boog, renowned pediatrician of the city, for 15 days as a case of meconium-aspiration syndrome. Before admission, the relatives, they were taken to conference, they were involved, and they were told about the condition of the baby, the future consequences and the complications, and written consent was obtained, which is on the record of the Honorable Court. They were told the baby might have most probably sustained birth asphyxia, and were also informed about the likely complications. Taking the relatives into conference and with transparent communication, senior pediatricians Dr. Jayant Pandrikar and Damankar were called for expert opinion, who opined the same, agree with the treatment going on. Appropriate investigations were performed, and the results of the test were informed to the relatives, and they are noted down on the case paper. The notes of the experts, they mention the same timing, the sequence of the events, hence discrepancies ruled out. As far as the charges of exhibit charges are concerned, the relatives were informed beforehand about the hospital expenditure, likely duration of the hospital stay, and likely outcome of the management, which they have consented. They were asked to deposit money from time to time, which they duly complied. Hence, the charges stand void.
Lawyer, it is so important. Would you like to examine some witnesses?
I would like to call Dr. Samir Sadawarte in the witness box. Thank you. So, you are Dr. Samir Sadawarte, the treating gynecologist of Mrs. Ranjita Golet, wife of Surejji.
Ji.
Dr. Samirji, I suppose you are practicing since last 25 years and have a good reputation. My request to you is please answer in brief and to the point to save the time of the Honorable Court.
Ji.
Is it true that Mrs. Ranjita Goleta was under your care right from conception and was following you whenever you asked her to follow?
Yes, बिल्कुल सही है.
I want your answer in yes or no.
Yes.
She got admitted whenever you asked for. Is it true that she was to undergo cesarean operation the next morning, but has to be taken out at midnight due to emergency?
I remember she was admitted for the
Dr. Samir ji, आपको answer yes or no में कहना है. Yes or no?
Yes.
Is it true that the pediatrician, Dr. Rajesh Boog, when called for the operation, reached at hospital 5 minutes after the birth of the baby?
No, he was trying to.
Yes or no, please, sir. Doctors?
I object a lot. How can any question come later? Every answer has to be circumstantial. It can't be answered in yes or no.
Objection overruled. You may proceed.
So, Dr. Samir, yes or no, is it true that pediatrician came after 5 minutes after the birth of the baby?
Yes.
Thank you, Honor.
Advocate Agrawal.
And no, sir. I have few more questions. If you
Okay,
give
please
me permission.
proceed.
You had a trained anesthetist with you, but he refused to receive the baby, and the baby was handed over to the attendant. With yes or no?
Yes, he was there. He was attending.
Again, I will request Dr. Saib, please answer question yes or no. Whether you handed over to the attendant, yes or no?
Yes.
So, again, I will repeat. Please answer in the form yes. Was the baby handed over to the attendant? Yes or no?
Yes.
That's all, Your Honor. It clearly shows the carelessness of the part of the Dr. Rajesh Boog and is a clear case of negligence. As per the definition of the negligence, it is a clearly deficiency of duty resulting in the directly in the damage out to my client. Thank you.
Advocate Agrawal.
My lord, with your kind permission, I would like to ask a question to Advocate Hemant Gangolia.
Okay, permission granted.
एडवोकेट गंगोली जी, हर सवाल का जवाब हाँ या नहीं में नहीं होता। अगर मैं आपसे पूछूं कि आपने सिगरेट पीना छोड़ दिया, आप बताइए, बड़ी मुश्किल हो जाएगी इसका आंसर करने में। Your Honor, may I seek your permission to ask some questions to Dr. Samir Sadawate?
Yes, permit.
Dr. Samir ji, you had advised the patient planned LSCS, then why did you take her for emergency cesarean operation?
जी बात ऐसी है, she was told to have a planned cesarean section at 38 weeks completed and she was a known high risk patient. She has previous abortions also, she has previously baby loss. So we have asked the parents to have a cesarean section to be done as a plan. But we already know that they refused for this. Despite of telling multiple times, talking to them previously also, but they did
What
not.
was the message that you took up for emergency cesarean?
So she comes for the routine admission, and we thought finally that to go for cesarean section for these parents agree. But that night, it was on the next day it was planned, but in the night she started with a sudden onset labor pain. She has uneasiness, she has bleeding, her blood pressure was going very high, and we also noticed that heart sounds of the baby are getting down. So it was a serious condition. We spoken with the parents once again, and then also called for the pediatrician, and we attempted for emergency cesarean section. That was to save the life of the mother as well as baby, or both also.
Anticipating that it is a emergency condition, what precautionary measures did you take?
So we called for the trained pediatrician. We used to call Dr. Rajesh Boop every time, and he was on the way to come. At the same time, we continued using all the measures like oxygen, cylinders, and instruments, keeping the warmer on and all the equipments ready in the position. And we are in constantly touch with Dr. Rajesh Boop.
Dr. Samirji, it is an allegation that the anesthetist, which you are saying is a qualified trained anesthetist, he refused to resuscitate the baby. Any reason for that?
No, this is not correct. He was looking after the mother. Mother was very sick. Mother was taking the blood transfusion. Her condition was very bad. Baby born doesn't cry immediately, but was looked immediately at that time. There were attendants and also by an anesthetist. And baby started crying after some time. In between, the child was looking very well. So after 5 minutes of thing, Dr. Rajesh Boop arrived. Till the time it was continued checking by the anesthetist and intermittently, of course, not continuously. But baby was doing slightly better. After initial time, that was some shock, and then the child was in asphyxia. But baby was doing well afterwards.
What is your experience with Dr. Rajesh Boop?
Rajesh Boop is a very good doctor. He is with me from last 20 years, and such type of incidents never occur. Whenever we call him, he comes immediately. So he was there in 5 minutes time, and he was talking on phone continuously till the time he arrived in the hospital.
That's all, Your Honor. I would just like to submit that the qualified gynecologist called the qualified trained pediatrician, and they both did their duty diligently. Hence, no question of negligence arises. Thank you.
Okay. Advocate Hemant, would you like to examine someone else?
Yes, my lord. I would like to call the pediatrician, Dr. Rajesh Boop, and ask some questions to him. Dr. Rajesh Boop, Hajir ho. Dr. Boop,
Your Honor. Good afternoon.
Dr. Boop, my request is you to be specific and to the point. So when the call was made to you, you reached 5 minutes after the baby was delivered. Yes or no?
Yes, I was driving
with my car. It was about 20 minutes.
Doctor, sir, just answer whether you reached 5 minutes late, yes or no.
Yes.
So you reached the hospital 5 minutes late after the baby was born. When you reached, the attendant was handling the baby. Yes or no?
Yes, yes, yes.
Do you feel that the attendant will replace your services of a qualified neonatologist?
No, we cannot replace.
Don't you agree that the presence of a qualified person at the time of the birth has the positive outcome on the delivery?
Yes, I agree. I agree.
Please let us know if the parents had asked you to provide the reports and the case papers.
Yes, you did.
My lord, as per the orders of the Honorable Supreme Court Bombay, White R.R. Raheja versus MMC and ethics as per the National Medical Council, it is mandatory on the part of the treating doctor to provide all the relevant details, including the case papers, within 72 hours. So my humble submission to you is that due to negligence in duty, he should be awarded the strictest punishment. That's all.
Your Honor, may I seek your permission to ask some questions to Dr. Rajesh Book?
Permission granted.
Dr. Book,
yes.
How many times do you reach late in maternity home after receiving the call?
In 20 years of my medical career, I was always on the time after receiving call, except for this particular incident.
So what was the reason that you reached for this call?
I was driving my car. It got broken down. It was COVID situation at that time. I tried for auto rickshaw. I couldn't get it. And this Sadavarte hospital is far away from city. To arrange another vehicle after calling my compounder, it took some time. But meanwhile, I had informed Dr. Sadavarte that I am getting late. If we can arrange, he said there is no nearby pediatrician nearby. And I was in constant touch with Mr. Ganpat. I had asked him to keep everything for resuscitation ready and continue giving oxygen. This was instruction given to Mr. Ganpat.
Let us know who is Mr. Ganpat.
Yeah. Mr. Ganpat is a very old attendant working with Dr. Sadavarte. Probably is doing his job since last 10 years.
So do you feel that Mr. Ganpat can replace your expert services?
Definitely not. I didn't say that attendant can replace a pediatrician, but he is working sincerely there since many years. And whenever I attend delivery calls, he always assists me. And while assisting, I make a point that I teach him basic steps of resuscitation that includes recognition of red flags in newborn after birth, and that includes baby didn't cry, and he was doing his work sincerely and satisfactorily. This kind of training helps me whenever I attend delivery calls.
So are you satisfied that in your absence, what he was doing better?
When I reached and checked the heart rate, it was around 120. This is a good heart rate, satisfactory heart rate. Baby was receiving oxygen, baby was pink, and he had adequate respiration. So I was satisfied.
So are such practices by such people are accepted by the competent authorities?
See, we have got our parent organization, that is IAP. IAP conducts neonatal research programs. We call it NRP. In NRP, we teach such health worker basic steps of resuscitation. They are trained to face various problems which arises after birth, and these practices help to save many newborns in their problems. And same training was given to Ganpat. Same training was given to Ganpat, and he has done his job wonderfully.
There is an allegation that when the case paper asked, you didn't provide the case papers. Any reason for that?
Relatives came to me for case paper, and I told them that it will take about 72 hours for me to make case sheet. They didn't turn up after that. And the number what I was having, their mobile number, that was probably wrong. I tried many a times to call them. They didn't turn up. They turn up with baby after 6 months. During 6 months, the baby and his mother had went to her mother at their village. In 6 months, they didn't go to any single pediatrician, leave apart doing ROP screening or doing BERA test. They came to me and I was shocked to see that patient having significant delayed milestones. I counsel them that apart from birth asphyxia, there are various causes which can cause mental retardation. I explained them the need of help of developmental pediatrician for better outcome of that baby. I referred him to a very good development pediatrician of area, Dr. Samir Dalwai, and I guided them properly.
Dr. Boop, would you like to say something in your defense?
Yes, Your Honor, I think I must say. Your Honor, हम लोगों की जो पढ़ाई होती है ना, वो लॉ की नहीं होती है. हम लोगों को पढ़ाई होती है मेडिकल फील्ड की. हमको ये सिखाया जाता है कि वो बच्चे के जान कैसे बचाया जाए, उसकी मॉर्टेलिटी, मॉर्बिडिटी हम लोग कितना मिनिमम कर सके. योर ऑनर, आपको शायद कल्पना नहीं होगी कि ये मेडिकल साइंस सीखने में हमारी पूरी जवानी चली जाती है. 18 साल से मोटा मोटी 28 साल तक की हमारी जवानी के पूरे साल मेडिकल साइंस पढ़ने में जाती है. वो जो बच्चा एडमिट होता है ना, वो पेरेंट का बच्चा नहीं होता है, वो हमारा बच्चा समझ के हम लोग उसका इलाज करते हैं और उस सिलसिले में हम हमारे बच्चे को भूल जाते हैं, या यूं समझो कि हमें भूलना पड़ता है. सर, कितने बर्थडेज को, प्रोग्राम्स को, पेरेंट्स मीट को बच्चा हम पे फोन करते रहता है, हम बोलते हैं आ रहा हूँ आ रहा हूँ आ रहा हूँ, बच्चा मायूस होके सो जाता है. सर एक और चीज बताई गई कि हमारे को बीमारी के बारे में नहीं बताया गया. हम डॉक्टर सभी एग्री करेंगे कि हम लोग पूरा डिटेल में उनको समझे, ऐसे भाषा में हर चीज समझाते हैं 10-15 मिनट तक के, मगर आखिर में सवाल क्या होता है, डॉक्टर साहब वैसे तो सब ठीक है ना, और कहते हैं बाकी वैसा तो कुछ नहीं है. अब कौन से लैंग्वेज में हम उनको समझाया जाए. हमको ये भी आरोप है कि एग्जॉर्बेंट कॉस्ट ली गई थी. जज साहब, हॉस्पिटल चलाना अभी कोई आसान काम रहा नहीं. जमीन खरीदना, उसको मेडिकल इक्विपमेंट लगाना, कंस्ट्रक्शन कॉस्ट. गंगोलिया सर जैसे बता रहे थे कि आपके अनट्रेंड स्टाफ थे, ट्रेंड स्टाफ की सैलरी सबको पता है. ठीक है, पोल्यूशन कंट्रोल है, बायोमेडिकल वेस्ट है, इलेक्ट्रिक ऑडिट है, फायर ऑडिट है, वेलफेयर, इसका कर्मचारियों का वेलफेयर, और ना जाने कितनी चीजें हमारे पीछे लगे. उसका खर्चा हम कहाँ से निकालेंगे. ये पेशेंट्स मैनेज करते करते हमको इतना फिजिकल, इतना मेंटल, इतना इमोशनल स्ट्रेस होता है कि हम डॉक्टर लोग कई बीमारियों के वजह से हम लोग जल्दी मौत हम लोग उसमें जाते हैं. कोई इसका हर्जाना देने का कोई सिस्टम है हमारे पास. जज साहब, वो जो नवजात बच्चा होता है ना, एक बीज के तरह होता है. उसको बराबर पालेंगे पोसेंगे, बड़ा होके फलदार वृक्ष बनेगा, समाज को अच्छा छांव देगा, फ्रूट देगा. उसी तरह से वो बच्चे को अगर हम लोग पेडियाट्रिशियन लोग हम लोग उसका केयर करते हैं, तो जाके आप जैसा जज, गंगोली जैसा वकील, हमारे जैसे डॉक्टर बनते हैं. ये चीज का कोई कॉस्टिंग का कोई सिस्टम है आपके पास में? नहीं है सर. सबको मालूम है कि किसी के अगेंस्ट में एक केस दाखिल हो गया, न्यूज़पेपर में सेम डे आ जाता है, फेसबुक पे आ जाता है, व्हाट्सएप पे आ जाता है. आपका हियरिंग तो बाद में शुरू होता है. वो सोशल मीडिया पे, प्रिंट मीडिया पे हम लोगों को तो वैसे ही पूरा केस हो जाता है, हम लोगों को दोषी भी डिक्लेयर कर देते हैं और अपने अपने हिसाब से वो सजा भी दे के छूट जाते हैं, हमको सजा दे देते हैं. ऐसी हमारी हालत है। जज साहब, मुझे ऐसा लगता है कि मैंने मेरा काम पूरा ईमानदारी से किया, बच्चे के अच्छे के लिए किया। उस खराब स्थिति में जब एनेस्थेटिस्ट माँ को बचाने में लगे थे, सर्जन जो है वो ऑपरेशन कर रहे थे, मैं अटके हुआ था, तो बेस्ट पॉसिबल उस समय ऑप्शन जो था वो गणपत के हाथ से उसको रिसर्जन कराने का था, जो मुझे ठीक लगा और हमने वो किया। ठीक है, अगर इस तरह से छोटी छोटी हर बीमारी के लिए अगर डॉक्टर्स पे केस होते रहे और रिजल्ट उनके अगेंस्ट में जाते रहे, तो मुझे डर है कि कोई स्टूडेंट मेडिकल फील्ड लेने का सोचेगा नहीं, और लेगा भी तो वो ये ब्रांचेस नहीं लेगा, पेडियाट्रिशियन नहीं बनेगा, सर्जन नहीं बनेगा, ऑब्स्टेट्रिशियन नहीं बनेगा, वो बोलेंगे मेरे को कोल्ड ब्रांचेस दो, ऑप्शनल दो, ईएनटी दो, पैथोलॉजी दो, रेडियोलॉजी दो, स्किन दो, मैं अपने घर पे जाके आराम से सोऊंगा। आप सोचिए हम कैसा समाज देने चाहते हैं। कौन मैनेज करेगा सीरियस पेशेंट, कौन बच्चों को डिलीवरी कंडक्ट करेगा? आखिर में हम क्या वो आदम जमाने में जाने का सोच रहे हैं, जहाँ हर चीज नेचुरली हो जाए, नेचुरली जो होगा वो होगा। डॉक्टर्स बोलेंगे हमको रिस्क लेना नहीं है। दैट्स ऑल योर ऑनर, दैट्स ऑल।
Your Honor, my submission to you that medical science is uncertain and unpredictable. 2 plus 2 may not always be equal to 4. Sometimes it may be 3, sometimes it may be 5. Events at birth, they are unpredictable and sometimes indigestible to us and the parents, which is a known fact in medical literature. The information of birth asphyxia of this baby was given to the relatives, which they had accepted very well. Written consent was obtained, and which is on the record of the Honorable Court. As far as the charges of negligence are concerned, there was no bad or criminal intention on the part of Dr. Rajesh Bhu. Harm the patient. Such a senior, caring and honest pediatrician or medico is punished, I'm afraid the society will be deprived of good medical services. We are proud of producing quality medical professionals in our country. Yes, our country is opted as the best medical tourism option in the world. So my humble request to you is to dismiss the case and free my client Dr. Rajesh Bhu of all the charges. That's all.
Yes, please go ahead.
What doctor has said, basic whatever the emotions, whatever doctor said was good to hear about it, but basic question remains. As per DNR protocols and everything, 5 minutes are very important while resuscitating a newborn. And again, the question comes, those 5 minutes, the attendant was handling the baby, not anesthetist, and the pediatrician arrived 5 minutes late. So still I feel these are the 2 or 3 points which has to be considered while delivering your judgment. I think, sir, my lord, you will think over it and consider these 3 points. 5 minutes, reaching late, attendant resuscitating the baby, as well as the emotions not to come in the way of the judgment. Thank you. That's all.
My lord, I would just like to counter what Advocate Ganguly said. 5 minutes is certainly a precious time, but if Dr. Rajesh would have been present since birth, how can he be assured that such event may not have occurred? One thing. Second thing, as has been mentioned in the code of law, only not crying is not the cause of cerebral palsy. There may be other causes also, which can be intranatal, postnatal, or other causes. Hence, Dr. Rajesh Bhu to be proved guilty may not be true at all. That's all.
After going through the documents produced by the doctors and their advocates, After going through the details of the evidence and the examination of the list persons, there are two or three things. We all know that life and death is not in the hands of the doctor. We are all there to help the patient, but the outcome is not in the hand of the doctor. We can guarantee for the care and not for the cure. Going through the papers, it has been found that Dr. Rajesh Boop was definitely late, as Advocate Gangulia has said. There seems to be genuine reason for him getting late. It was not intentional, as Advocate Agrawal has said. So the guilty mind was not there, is a genuine reason. But at the same time, the damage has occurred to the patient. We cannot disagree with that. There has been definite damage. And keeping in all the situations or the circumstances in mind, it seems that Dr. Rajesh Boop has not done anything deliberately. And as pointed out by Advocate Agrawal, there can be many other causes of birth asphyxia and the ultimate outcome of the child or the baby. So keeping this in mind, we dismiss the case against the Dr. Rajesh Boop, but at the same time, if he has not given documents at time, though there is a MCI guideline, so giving document on time, that is, as per MCI guideline, it should be 72 hours. So we fine 25,000 for not giving the document, and would order Dr. Rajesh Boop, if he has charged exuberantly, to reduce his charge and refund back the amount in this particular case. That too, because on the humanitarian ground, and we feel that sometimes if the patient is unable to pay, and if there is a genuine case, the doctor should try to give the concessions to the patient. And I think with this, the whole moot court is over. There are some legal points which we request Dr. Mahesh.
Sir, 1 minute. With that, the role play is done. आपल्याला असं वाटतं की कोर्टात गेल्यानंतर खरं मी बघितलंय, कोर्टात गेल्यानंतर डॉक्टर सुद्धा खूप घाम येतं आणि थरथर करतात ते. तर दिस वॉज जस्ट टू शो हाऊ दे रोल प्ले द इन कोर्ट गोस. आपल्या फिल्ममध्ये पिक्चरमध्ये दाखवतात असे जातात आणि असे येतात, असं काही होत नाही. जजची सीट असते, त्याच्या समोर चेअर असतात, तिथे ॲडव्होकेट बसलेले असतात. ॲडव्होकेट असं धावून तिथून पळतात, तिथून जातात, तसे आपण पिक्चर तसं होत नाही. बऱ्याच भागांनी बघितलं असेल, नसेल बघितलेलं, पण तसं होत नाही विचार. पण आणि हे सर्व कन्सिडर करताना जे काय एव्हिडन्सेस पुट फॉरवर्ड होतात, त्या एव्हिडन्सवरतीच जज डिसाईड करतो काय होतं. बऱ्याच वेळा आपला असं गृहीत धरतो की जजला सर्व माहिती आहे, सर्व लॉ माहिती आहे. जसं मेडिसिन इज वास्ट, law is also vast. So we cannot think that judge knows everything, as we don't know each and everything of our science also. So whatever has been placed at the table of the this judge, with the on the evidences, the judgment is given. With that, sir has given the judgment. We have Dr. Mahesh Baldava, one of the greatest expert from Mumbai, and I will request Dr. Mahesh Baldava, sir, please give your expert opinion on this, whatever the this role play was done as a, which is known as moot court. This moot court, when we do LLB, it is the second semester, fourth semester, this practical has to be done. So with that, I will request Dr. Mahesh Baldava, sir, please give your valuable inputs. Yes, sir.
Thank you very much, Honorable Judge Dr. Satish Tiwari, sir, both the learned advocate, Dr. Gangolia, sir, Dr. Satish Tiwari, sir, and Dr. Rajesh Boop and Dr. Sadavarte. Of course, as you have mentioned, in 60 minutes, no case can be over, not even in the movie, which is devoted for this. So it was one of the wonderful dramatization of the court case in 60 minutes which goes on and on for years together, where there is no light in the tunnel, and at the end of the tunnel, both litigants feel what will happen. It was a real court proceedings. In the above matter, we see that the proper counseling is done by Dr. Boop, proper consent is taken, proper prognosis of timely done LSCS was told, which was refused by the patient because the previously high-risk patient was there. I personally believe that by the reasons given by Dr. Boop, I think the billing is going higher and higher. And of course, as is mentioned by Judge Dr. Satish Tiwari sir, if we can reduce, it will be better. Though of course, he has done everything diligently, prudently, with due care and caution. Pediatrician coming late 5 minutes will not change the asphyxia outcome. Complications of the asphyxia, counseling and guidance for further treatment given, since all necessary treatment was given, including oxygen, which was going on from actually the lack of oxygen which gives rise to this, which was going from the moment, say, the birth of the baby. Cerebral palsy may have several causes. May have one of them, of course, we know is the lack of oxygen after delivery, meconium aspiration, gene mutation that result in abnormal development, hidden subclinical viral infections in intranatal or antenatal period. So here everything was done diligently, prudently by gynec, pediatrician, supported by medical literature and the subject experts in this. So according to me, the judgment given is absolutely considered judgment in favor of Dr. Boop, that he is not negligent. And I personally feel that such moot courts will give some insight about what actually goes on in the court of law. Those who are facing cases, most of the time, they wait for the whole day and they get the next date. As you have seen in several movies, Tariq per Tariq, Tariq per Tariq, and this is what goes on. But of course, our moot court is very good. The decision has come. Thank you very much, all the panelists.
Yeah, one minute, sir. It was nice play. I will take the question, one or two questions. Sir, just बैठिए. हाँ. तर आपला हे रोल प्ले करण्याचा उद्देश काय, आपलं जो टेन्शन कमी करायला पाहिजे. नोटीस जेव्हा येते बरेच एलिगेशन असतात, अनवॉन्टेड एलिगेशन असतात, वाचायचं एलिगेशन डोक्यात शांत ठेवायचं, रिप्लाय प्रॉपर रिप्लाय शुड बी गिवन. दॅट इज अ की फॉर दॅट. फक्त एकाच गोष्टीमध्ये घाबरणं असतं, एफआयआर जर झाली तर आपल्याला डॉक्युमेंट शुड बी व्हेरी क्लिस्टर क्लिअर. Otherwise, the other forums which are there, Maharashtra Medical Council, the consumer forum, civil courts, criminal courts, all this requires we get 1 month to reply. कुछ टेंशन नहीं लेने का, 1 month आराम से बराबर से इनपुट्स लेने का, रिप्लाई बराबर से करने का. But most important point, when you reply, it should be absolutely clear. Reply to each and every allegation, whatever is stated. That is to be kept in the mind.
So, carry home message from Dr. Baldava, from Dr. Hemant is, do not get frightened and do not disrespect the court or the advocate's notice. Please reply.
Dr. Satish sir, what he said, that be afraid of FIR. Under section 41A of CRPC, there is the section 304 where even death occurs. It is a bailable section. The police officer can give the bail, but so many times they apply some other sections, and one has to at least remain for 24 hours in custody of the, and that is very bad. Of course, now new guidelines of the National Medical Council have come, which are very clear that unless the case goes to the medical board, they cannot arrest a doctor, which is a very good thing. One thing which I missed out in my comment is that whosoever loses or wins the case, both the parties can go for appeal. So this drama of the lower court may go to the, say, from district to state commission to national commission to the Supreme Court. And a young pediatrician like Dr. Boop, Rajesh Boop, when he's already retired, that time the final judgment from Supreme Court might come.
Okay, so yes, Dr. Jayant. Court cannot reduce, but they can ask So it will not be a order, or it can be just a appeal to the doctor that on humanitarian ground you should uh, refund that order can be there, but otherwise court cannot fix your charges.
That is
Yes.
very clear. I think there was a recent judgment which is in Supreme Court filed by someone that court cannot fix the charges of the professional charges of the doctors.
Dr. Upendra, yes.
Dr. Samir, before the Mahesh Baldava sir, what he stated.
Samir, sorry.
No, just one minute. The what Mahesh Baldava sir stated, we should be very, very well known what is 304 and 304A. What sir stated, 304A is bailable offense. So we get the bail outright. Yes, Dr. Samir.
So take the help of medical legal consultant, and we are there. All of us are there to help you at any time. Yes, Dr. Samir.
So good evening. I wanted to appreciate the wonderful way that you presented. So you're right, it takes away the fright when you actually see it. I had a basic question. If the gynecologist has a obstetrician has a nursing home and the child is to be delivered there by cesarean or natural birth, and you call for a pediatrician to come, the pediatrician has not been contracted by the parents to be the neonatologist at the birth. So for example, I get a call that the patient is dilated, come. I may come in 5 minutes, I may come in 10 minutes. If I say I'm going to come in 3 minutes and I come in 30 minutes, then that 27 minutes is my fault. But if I take 20 minutes to reach there and I say I'll come in 20 minutes, my contract should begin or my responsibility begin after I reach there. So whether I reach 20 minutes, it can be called 20 minutes late. My contract started when I reach there. So can this be a defense?
No, this cannot be a defense because parent may not ask. Parent have given the responsibility in this case of the mother, and whenever she delivers, it is the responsibility of the obstetrician to call the pediatrician if somebody is attached. Now, if the parents say that don't call this particular pediatrician, call this pediatrician, then it will be the responsibility of the parent. So I think this point also we should understand what is contributory negligence. If there is some negligence on the part of the patient, it amounts to contributory negligence, and that will definitely help the doctors involved.
I agree with what you're saying.
And
My question was,
and the responsibility increases when it is a precious pregnancy. It is bound obstetrician to call the pediatrician well in advance.
yes, that's my point. It's the obstetrician's fault, not the pediatrician's fault for coming at whatever time he does. The contract is with the gynecologist or the obstetrician.
Dr. Samir, sorry to interrupt. The basic question, I think Dr. Baldava will agree to this. If there is a case against a pediatrician, then if it is a case of obstetrics, even anesthetist was there, my personal suggestion is please do not point finger to one another.
Thank you.
You have to fight the case unitedly. All the three should give the same message to the court.
Okay, thank you.
If you start
I
fighting
totally
amongst yourself, you will pinpoint each other's
Well taken. Thank you,
Yes.
sir.
I totally agree. I totally agree with Dr. Satish.
One more case, in one of the case, same thing happened. It said that anesthetist can resuscitate a baby, but he is not the right person. So that is again the cross speciality. So anesthetist resuscitating is a cross specialty case. So that is not allowed.
Sir, I have one question. Tiwari sir.
You have to train anesthetist, obstetrician, and as in this case, Mr. Ganpat was trained. So you have to have the training, especially the nursing staff can also be trained.
I have attended LACS, right? I have seen on the paper written, I have given call to Dr. Jay Bhandarkar at 3:20 p.m., right? And actually they called me at 3:40 p.m. Okay, so I have that record and they're mentioned on the paper.
Yes.
But what I should do then, right?
If please complete.
This is the only question.
Okay.
They called me at 3:40 p.m.
Yes, yes.
Right? On the paper I have seen they are called Dr. Jay Bhandarkar at 3:20
Yes.
p.m.
So if you are trying to manipulate the document, then some of you will get caught in that, and it will be again अपने खुद के पैर पे कुल्हाड़ी मारना जैसा हो जाएगा.
So I am.
So do not manipulate the document. Again, what Samir has raised the question: if obstetrician is trying to entangle pediatrician, or pediatrician is trying to entangle the obstetrician that they were at fault, you will be pointing finger to each other, and your case will weaken.
Right.
Jay,
I think-
I have started.
No, no, Jay, when you've written the notes, then that time why you didn't point it? So it should not be 320.
Right.
So
नहीं,
when you have written the notes, you
नहीं,
agree to the time what was mentioned. The
नहीं, नहीं, हेमंत,
documented.
Then I write on the paper from the
उनका
3:45
बोलना
I
है कि
enter
उनको
the
गलत
OT.
लिखा है. He might have come to know later on, ना उस
नहीं
समय
नहीं
पता
सर
नहीं.
सर मैंने पेपर देखा उसमें 320 लिखा था.
हाँ.
लेकिन मुझे मालूम है कि मुझे कॉल 340 को आया है.
आपके
मैं
पास
350
रिकॉर्डिंग
को
भी है.
पहुंचा हूं मैं.
हाँ.
और दूसरा और एक मैं सबको बताता हूँ, when you call neonatal call, don't only talk with the gynecologist, please talk with the relative. बाहर आके रिलेटिव से बात कीजिए, उनको अच्छी तरह से बताइए, and write everything what premature के aspects तो asphyxia लिखी है, right? And ask them to just straight away conceal the relatives. This patient need to shift it to ICU for the further care, right?
Yes.
Then your responsibility maybe stop there. You are in the baby is in the custody of gynecologist. What it does, that is his responsibility, is not shifted immediately to the hospital. It's not responsibility of the neonatologist. What I am saying. So I stop taking delivery calls and Caesar calls straight away.
Dr. Jay, I agree with you morally, but according to me, as Dr. Tiwari has said very correctly, that pediatrician, the obstetrician gynecologist, the anesthesiologist, the supporting staff, nurses, Ganpat, everything, if they are not together, very likely in legal scenario, you are going to lose the case. So all join together, review your notes rather than finding faults for each other.
Yeah. Dr. Upendra, before you start, organizing committee, you decide whatever time is there.
So I will ask MOC whether we
Up
have
to
time
what?
to take 3 questions by Dr. Upendra sir, Dr.
म्हणजे तुला स्वतःलाच प्रश्न विचारायला लागेल.
Yes, MOC, how much time do we have?
Okay.
नहीं, time कितना हुआ? आपने time कितना हुआ?
10 minutes बोला उसने.
हाँ?
नहीं,
कितना हुआ? Time कितना? 6?
मेरा क्वेश्चन ये है, आपका अगला प्रोग्राम कब है? तब तक हम लोग कंटिन्यू कर सकते हैं.
Sir, we are having inauguration 6:30, so only 4 minutes.
Okay.
That's all.
Yeah.
4 minutes.
First of all, on behalf of all the delegates, a big round of applause to a great role play done by all of you. Really. My question is the only serious part which I think which was mentioned by Dr. Gangolia. I want your opinion on that. Which are the situations where FIR, which look to be a little scary, is applicable to us and we should be careful about? What is this FIR business about?
See, allegation or FIR, patient or parents can go anytime to the police. It is their right. Nobody can say that you cannot go to the police or you cannot have any allegation. Nowadays, what we are telling to our delegates or our colleagues, that you treat every patient as a potent litigant. So every patient is a potent litigant. Anybody can have any allegation against you. So you cannot say that he cannot go to the court or to the police. So if you feel something wrong has happened to you, it is his right to go to the proper authorities.
Nowadays you can even file
Sir,
FIR
is
online.
First information.
Hemant
First
sir,
information.
Dr. Baldava is saying something.
Sorry, sir. Sorry, sir.
Under section 154 of Criminal Procedure Code, if anyone feels that he wants to complain against someone, he can do physically in the police station, he can go online and file an FIR. And the police has to give an acknowledgement. FIR filed on online, immediately get the acknowledgement. FIR under 154, it can only be quashed by the judges in the various courts. It cannot be quashed by the police itself.
So what sir said, FIR, first information report, sir ne online bataya, but online is from the police station, not from home. So that online is from police station. And FIR is first, anybody can go to the police station, but then sufficient substance to be given where the police can raise the charges. Yes, Dr. Satis.
Dr. Hemant Sade from Solapur. Regarding the initial series, should we have a harmony amongst ourselves that before the neonatologist comes, the surgery should not start? Because this time problem is for everybody.
That will depend on actual
The
situation. If there is a fetal distress,
Right.
you cannot ask the obstetrician to wait till the pediatrician comes.
Right. Secondly, we say that such situation can happen with anybody. So we are always training few people from our side, obstetrician and pediatrician. So how it is that just because the doctor came late for legitimate reasons, the doctor is held responsible in spite of our own trained people doing resuscitation job for the same. Thirdly, so all the deliveries are not attended by the doctors. For say for a normal delivery, many times is done by the obstetrician. Why obstetrician? By the nurses attending. Now, suppose a stillbirth occurs. It is whose responsibility to sign the document of stillbirth? That is third question of mine. And fourth is regarding the punishment was given because the doctor agreed to give the documents not right now, but after within 72 hours, the patient's relative did not turn up. How can the court to find the doctor for 25,000 rupees? Why single
No,
rupee
the
for that
question
matter?
is whether he relative did not come or whether you are trying to manipulate. That was not obvious.
No, the
The
relative
doctor
agreed.
is saying that you did not come, but patient is saying I had come. So you have to have something there. And not giving document. That's why 2 or 3 important points which I would like to highlight here. Documentation is the most important thing, as Dr. Samir has also said. No, not Samir. I think that timing is very important. So there should not be manipulation in documentation. Then if patient asks for the document, please remember you have to give within 72 hours, and these are MCI guidelines. Now, if you are not giving, either you have to document on the paper also that the patient has asked for the document and then he did not come. So whether he has documented that on the paper, whether the patient really did not come or the patient has come and he has still not given and now he is saying that the patient did not come. So if everything is documented, then the decision will not go against the doctor. So whatever was given here is the court had believed that the document was not provided. That's why the punishment of 25,000. If there is a definite proof that the documents were given, the court might have given the different judgment.
Of course, the stillbirth, as you said, stillbirth
Signing the
certificate, stillbirth certificate
Dr.
needs to be given
Baldova,
by
yes.
gynecologist, obstetrician and gynecologist. Stillbirth is not a responsibility of pediatrician.
This is what I have also, this is what I was knowing for long, but we had in Solapur one case wherein they tried to sue our pediatrician and I was fighting for him because our role comes only after the birth of the baby for that matter. And when such a delivery,
Dr. Sate, again, my suggestion is on such a trivial issue, we should not fight that. I will not give the stillbirth documentation, or I will not write stillbirth. Obstetrician should write stillbirth. Why you are there? If you have seen the baby stillbirth, you can put in your note that the baby is stillbirth.
I know. The
And
delivery
any
occurred
of
at
you,
night.
any of the two obstetrician or pediatrician, they can sign there. Now, what is the harm in that?
There is no problem. The delivery occurred at night. There was a stillbirth. The staff did not call the pediatrician. As per routine, the obstetrician signed the stillbirth. And next day, pediatrician was told, "He collect stillbirth, okay, हम sign करके दे दिए."
So that you document on the paper that I was not called at that
informed.
time.
Yes.
Yes.
Then the responsibility goes to the obstetrician.
See, when you call and gone, you have to document that stillbirth. Anyway, Sawad between obstetrician and
One
pediatrician
last
is
question.
the most important.
One last. Sir, Samir has asked the contract will start when the pediatrician will arrive. It was not clear. When then the phone call is given to pediatrician, the contract starts from that time, or whether when the pediatrician reaches to the baby. Because the whatever logistic problems are there, it is difficult to prove
When the pediatrician reaches to the place, that is the time the contract starts. Call you may give anytime.
That is known as vicarious responsibility. Contract doesn't come there.
Yeah,
This is
why the-
vicarious responsibility because obstetrician's duty was to call the pediatrician. And whether that is
She has
that logic
called.
is not the issue.
She
That
has
cannot
called,
be.
and if she is writing that she has called, that means she has called. As doctor, I think.
No, but it seems that there is ambiguity. Dr. Baldwa sir is saying that when the pediatrician reaches, vicarious liability is a
Yes,
different story.
see, vicarious
Baldwa sir is
liability.
saying that when pediatrician reaches at the venue or the hospital,
Yeah,
then
yeah.
his
Actually,
liability
when
starts. Then the contract
yes.
starts. Because so many things are there. Logistic issue is there.
Contract with the patient may start at that time, but obstetrician and pediatrician contracts had started once he has told on the phone that he is coming.
Yeah, but in this case, it assumption what you say that court has believed.
Yes.
So every time, whether it is a belief of a court or whether the documentation is there.
All the case laws judgments are as per the belief of the court.
And what about this FIR different?
Court will not give any judgment in which he does not believe in the facts.
Sir, I just want to give one humble submission before ending. This question of susamvad between gynecologist and a pediatrician. Recently, new rules are framed. Mumbai Nursing Home Act Amendments 2021. त्यामध्ये त्यांनी स्पष्ट मेन्शन केलेलं आहे प्रत्येक डिलिव्हरी पॉइंट साठी प्रत्येक डिलिव्हरीच्या रिक्वायरमेंट राईट फ्रॉम द साईज अँड एव्हरीथिंग त्यात त्यांनी म्हटलेलं आहे की ऑब्स्टेट्रिशियन हॅव टू हॅव ए रिटन अग्रीमेंट विथ द pediatrician अँड अनेस्थेटिस्ट ऍज पर द टाइम्स. आणि त्याप्रमाणे याप्रमाणे सध्या जे एक्सप्लॉयटेशन होत असतं पिडियाट्रिशियनचं कॉल देऊ आणि कॉल मिळाले पाहिजे म्हणून जे जे म्हटलं ते लांगुल चालन करावं लागतं ऑब्स्टेट्रिशियनचं.
Thank you, sir. You can collect your memento from Dr. Davarkar, sir.
My request to all those delegates who are here and who are going to organize pedicons in the future, please keep in mind the questions at the end of medical legal sessions are never over. So please try to give some more time to the medical legal sessions.
गुड इव्हनिंग सुस्वागतम. गुड इव्हनिंग सुस्वागतम. सगळ्या पाहुण्यांचं आम्ही स्वागत करतो. मी डॉक्टर उद्धव खिल्लारे व डॉक्टर चित्रा कुलकर्णी आपल्या सर्वांचे थर्ड वेस्ट झोन पेडिकॉन व 31st महापेडिकॉनच्या इनॉग्रल फंक्शन मध्ये नारी शक्तीचा पुरस्कार करणारे असे एकमेव रायगड IIT तर्फे सहर्ष स्वागत करत आहोत. सुस्वागतम. अंधाराचे जाळे जाळे मोकळे आकाश तरी खोऱ्यातून वाहे एक प्रकाश प्रकाश. या कवी सुधीर मोगे यांच्या गीताप्रमाणे कोविडच्या अंधाराचे जाळे दूर हटून व कोविड निर्बंधाचे जोखड थोडे सेफ झाल्यामुळे आज आपण सर्व एकत्र येऊ शकत आहोत. पण कोविड प्रोटोकॉल फॉलो करू.
शिवरायांच्या पराक्रमाने पावन झालेली ही आमची कोकण भूमी. इतिहासाच्या साक्षीने उभे असलेल्या गड किल्ल्यांमुळे आणि अष्टविनायकाच्या आशीर्वादाने महड पाली या देवस्थानांमुळे
नारळी, पोफळी आणि सुमधुर आंब्याच्या झाडांनी आमचं कोकण भूमी समृद्ध झालेली आहे. अशा कोकणातील रायगड जिल्हा आणि त्यातील रायगड IIP या संस्थेतर्फे आपणा सर्वांचे स्वागत. नाव वी इन्व्हाइट द डिग्निटरीज ऑन डायस.
मी डॉक्टर जय भंडारकर सरांना विनंती करतो की त्यांनी आजच्या कार्यक्रमाचे प्रमुख पाहुणे डॉक्टर बकुल पारेख सरांना स्टेजवर घेऊन यावे. तसेच मी डॉक्टर हेमंत गांगुले सर जे चीफ ऑर्गनायझिंग सेक्रेटरी चेअरमन यांना विनंती करतो की त्यांनी डॉक्टर GV बसवराज ऑनररी सेक्रेटरी जनरल यांना स्टेजवर घेऊन यावे. I request Dr. Rajendra Chandorkar to escort Dr. Jayant Upadhyay sir, Vice President of West Zone, on the stage. मी दाभाडकर सरांना विनंती करतो की त्यांनी डॉक्टर जयंत पंढरीकर, प्रेसिडेंट MAHA-IP यांना व्यासपीठावर घेऊन यावे.
डॉक्टर प्रमोद वानखेडे, पास्ट सेक्रेटरी रायगड IIP यांना विनंती करतो की ते महाराष्ट्र IIP सेक्रेटरी डॉक्टर सदाचार उजळमकर यांना व्यासपीठावर घेऊन येतील.
मी विनंती करतो डॉक्टर विनायक पाटील यांना की त्यांनी डॉक्टर राजेश बुग, व्हाईस प्रेसिडेंट महाराष्ट्र IIP यांना स्टेजवर घेऊन यावे.
मी डॉक्टर सुनीता इंगळे मॅडम यांना विनंती करते की त्यांनी न्यूली इलेक्टेड प्रेसिडेंट इलेक्ट डॉक्टर उपेंद्र किंजवाडीकर यांना स्टेजवर घेऊन यावे. डॉक्टर सुनीता इंगळे मॅडम यांनी स्थानापन्न व्हावे.
डॉक्टर दाभाडकर सरांना विनंती करतो की त्यांनी स्टेजवर स्थानापन्न व्हावं.
Dear delegates and respected dignitaries, the world has faced an unprecedented situation because of pandemic. As if COVID was not enough, Raigad district had a devastating flood few months back. कोरोनाच्या महाभयंकर महामारीमध्ये ज्या योद्ध्यांनी आपल्या प्राणांची आहुती दिली, लढता लढता ते अनंतात विलीन झाले, त्यांना आपण श्रद्धांजली वाहूया. प्लीज लेट अस ऑल राइज अप. लेट अस कीप 1 minute silence and pray for the departed souls. Om Shanti. Time is ever changing. We have to go ahead. आपण आता पुढच्या कार्यक्रमाकडे वळूया.
थर्ड वेस्ट झोन महापेडिकॉन व 31st महापेडिकॉन या महत्वाच्या कार्यक्रमाच्या उद्घाटनानिमित्त व्यासपीठावर स्थानापन्न झालेल्या माननीय महोदयाचे आम्ही IIP रायगड तर्फे परत एकदा हार्दिक स्वागत करतो. हार्दिक स्वागत. टाळ्यांच्या गजरात हार्दिक स्वागत करा सगळ्यांनी प्लीज. दीप प्रज्वलन हे ज्ञानाची देवाणघेवाण करण्याचे प्रतीक म्हणून मान्यता आहे. जर मी मंचावरील मान्यवरांना विनंती करतो की त्यांनी दीप प्रज्वलनासाठी पुढे यावे.
अतिशय आनंदित होऊन आम्ही हे सांगू शकतो की आपण सर्व उपस्थित मान्यवरांनी या कार्यक्रमाची शोभा वाढवलेली आहे.
मान्यवर दीप प्रज्वलन करत आहे. सगळ्यांनी टाळ्याच्या गजरामध्ये
सर्व मान्यवरांनी स्टेजवर स्थानापन्न व्हावे.
आम्ही मान्यवराचे सर्व मान्यवरांनी स्टेजवर स्थानापन्न व्हावे. मी डॉक्टर हेमंत गांगुले सरांना विनंती करतो की त्यांनी डॉक्टर बकुल पारेख साहेबांचं पुष्पगुच्छ देऊन स्वागत करावं. सगळ्यांनी मी डॉक्टर विनायक पाटील यांना विनंती करतो की त्यांनी डॉक्टर बसवराजा सरांचं पुष्पगुच्छ देऊन स्वागत करावं. मी डॉक्टर दाभाडकर सरांना विनंती करतो की तिने डॉक्टर उपाध्याय सरांचं पुष्पगुच्छ देऊन स्वागत करावं. मी डॉक्टर गांगुले सरांना विनंती करतो की दोन डॉक्टर सदाचार सरांचं पुष्पगुच्छ देऊन स्वागत करावं. येस, डॉक्टर जयंत पांढरेकर सरांचं. मी डॉक्टर सुनीता इंगळे मॅडमना विनंती करतो की त्यांनी डॉक्टर सदाचार सरांचं पुष्पगुच्छ देऊन स्वागत करावं. मी डॉक्टर विनायक पाटील सरांना विनंती करतो की त्यांनी डॉक्टर राजेश बुब सरांचं पुष्पगुच्छ देऊन स्वागत करावं. मी डॉक्टर गांगुले सरांना विनंती करतो की त्यांनी मागील वर्षाचे CIP चे EB मेंबर्स डॉक्टर पूर्णा कुरकुर्णे मॅडमचं पुष्पगुच्छ देऊन स्वागत करावं.
I will request everybody, please stand and give a big round of applause to Dr. Upendra Kinjwadekar, newly elected President of ASEAN.
मी डॉक्टर विनायक पाटील सरांना विनंती करतो की त्यांनी डॉक्टर हेमंत गांगुले याचं बुके देऊन स्वागत करावं. मी दाभाडकर सरांना विनंती करतो की त्यांनी विनायक पाटील सरांचा बुके देऊन स्वागत करावं. मी डॉक्टर चित्रा कुलकर्णी मॅडमना विनंती करतो की त्यांनी सुनीता इंगळे मॅडमचं फ्लोरल बुके देऊन स्वागत करावं. मी डॉक्टर जय भंडारकर सरांना विनंती करतो की त्यांनी डॉक्टर वसंत खालीलकर कलाटकर यांचं IIP चॅप्टर
ID चॅप्टर चेअरपर्सन इलेक्ट आताच सर निवडून आलेले, त्यांचा सत्कार जय भांडारकर सर.
मी डॉक्टर चित्रा कुलकर्णी मॅडमना विनंती करतो की त्यांनी पूर्णा कुरकुर्णे मॅडमचा सत्कार करावा फ्लोरल बुके देऊन. मी डॉक्टर वैभव देशमुख सरांना विनंती करतो की ते डॉक्टर समीर दळवे सरांचं पुष्पगुच्छ देऊन स्वागत करावं. मी डॉक्टर प्रमोद वानखेडे यांना विनंती करतो की त्यांनी डॉक्टर नरेंद्र नारेकर सरांचं पुष्पगुच्छ देऊन स्वागत करावं. मी वैभव देशमुख सरांना विनंती करतो की त्यांना डॉक्टर अनिल राऊत सरांचं पुष्पगुच्छ देऊन स्वागत करावं. डॉक्टर अनिल राऊत सर. डॉक्टर आनंद देशपांडे सरांचं स्वागत मी डॉक्टर वैभव देशमुख सरांना विनंती करतो की त्यांनी
डॉक्टर प्रशांत जाधव सर.
डॉक्टर प्रशांत जाधव सर.
डॉक्टर परमानंद सर. डॉक्टर रमाकांत पाटील सर यांचा सत्कार डॉक्टर जय भांडारकर सर.
Newly elected CIP member.
मी डॉक्टर जय भंडारकर सरांना विनंती करतो की त्यांनी महाराष्ट्र IIP चे ट्रेझरर डॉक्टर अमोल पवार सरांचं पुष्पगुच्छ देऊन स्वागत करावं. तसेच महाआयपी चे एक्झिक्युटिव्ह बोर्ड मेंबर मी डॉक्टर वानखेडे सरांना विनंती करतो की त्यांनी डॉक्टर संजय जोशी सरांचं पुष्पगुच्छ देऊन स्वागत करावं. डॉक्टर संजय देशमुख सरांचं पुष्पगुच्छ देऊन स्वागत करावं.
देशमुख सर. डॉक्टर प्रमोद कुलकर्णी सरांचा सत्कार डॉक्टर जय भांडारकर सर करतील.
मी चित्रा कुलकर्णी मॅडमना विनंती करतो की त्यांनी डॉक्टर बेला वर्मा मॅडमचा पुष्पगुच्छ देऊन सत्कार करावा. मी मॅडमना विनंती करतो मी डॉक्टर चित्रा कुलकर्णी मॅडमना विनंती करतो की त्यांनी डॉक्टर मीना शेख एक्झिक्युटिव्ह बोर्ड मेंबर्स महाराष्ट्राचे डॉक्टर संजय जोशी सरांचा सत्कार डॉक्टर वानखेडे सरांना मी विनंती करतो.
संजय जोशी सर. डॉक्टर रवींद्र बेलोंडे सरांचा सत्कार डॉक्टर वानखेडे सर करतील.
डॉक्टर चित्रा कुलकर्णी मॅडमना मी विनंती करतो की त्यांनी डॉक्टर शिल्पा दुधगावकर मॅडमचा EB मेंबर महाराष्ट्र बोर्ड IIP डॉक्टर शिल्पा दुधगावकर मॅडम. मी जय भंडारकर सरांना विनंती करतो की डॉक्टर सागर वाघ सरांचा डॉक्टर निखिल पाठक
डॉक्टर दीपा फिरके मॅडम. डॉक्टर भांडारकर मॅडम सत्कार करतील डॉक्टर दीपा फिरके मॅडम. एडिटर इन चीफ डॉक्टर संदीप दानखेडे सरांचा सत्कार डॉक्टर जय भांडारकर सर करतील. डॉक्टर शिल्पा दुधगावकर मॅडम. नाही.
We are proud to announce that all these bouquets are prepared by National Association of Blind.
Now I would like to request Dr. Jay Bhandarkar sir, who is organizing chairman of Mahapedicon. He is hardworking and fitness freak, sports person, singer, and part of IIP Ragat to deliver his welcome address.
Hello. Yeah. Good evening. Namaskar. Me, Dr. Jay Bhandarkar, organizing chairman of this beautiful conference with a difference. I welcome on the dais our all chief guest, Dr. Bakul Parekh sir, or SSG Bashav Raja sir, and Pandikar sir, Kinjote sir, my friend, my course student as a singing, and Sadachar, secretary of MahaIP, Boop sir, vice president MahaIP, Pandikar sir, the president, my friend, beloved friend and chief organizing chairman, Hemant Gangulia sir, our VP, Upadhyay sir, and Dabadkar sir, and his VP last year, and all present invitees here, CIP member, executive Maharashtra member and central member. मैं पहले एक शेयर कहूंगा मेरे रायगढ़ आईपी के ऑर्गेनाइजिंग टीम को बिफोर वेलकमिंग यू फॉर दिस कॉन्फ्रेंस. मायूस बहानों का पनाह लेते हैं, मायूस बहानों का पनाह लेते हैं, मंजिलों से खुद ही दूरी बना लेते हैं, मंजिलों से खुद ही दूरी बना लेते हैं. दुनिया में जिक्र सिर्फ उनका होता है जो तूफानों में आशियाने बनाते हैं. Friends, we started 2 years back, and just in 67 days, we organized the whole conference where I finalized this venue. We finalized the venue, and due to Corona period, we lost lot of time. But जब कहते हैं कि मंजिल खूबसूरत है तो रास्तों की परवाह नहीं करना चाहिए. मुझे मालूम है काशी बीच और प्रकृति रिसोर्ट पे आने के लिए थोड़ी दूरी 31 किलोमीटर्स, फर्स्ट 13-14 किलोमीटर्स आर क्वाइट टफ. एवढे चांगला रस्ता नाहीये, पण नंतरचा बाय सीशोर यू रीच हियर. वन्स आर हियर, I assure you, you will witness best of academics, best of hospitality, best of culture event, and best of witnessing the chemistry between the Raigad IPNs as an organizing team. Right. I again welcome all of you here. Not take much of time because I am the organizing chairman also and culture committee chairman also. So I am waiting all of you to present after this event to the launch for the Kokan Dum Dhadaka, that is Kokan ke Rang Raigad IP ke Sang. So I thank you my own team for giving this opportunity to a present welcome speech in front of you. Thank you very much. All the best. Thank you. Jai IP, Jai Maha IP, Jai Goa IP, Jai Gujarat IP, Jai CIP, but inform me important, Jai Raigad IP. Thank you.
Raigad IP style.
Thank you, Dr. Jay Bhandarkar sir. मी माननीय महामेरू कर्मयोगी रायगड IIP चे पितामह भीष्म ज्यांनी महापेडिकॉन राज्यस्तरीय कार्यशाळा रायगड IIP ला मिळावी यासाठी 2006 पासून परिश्रम घेतले, त्यांचे स्वप्न आज सार्थक होत आहे. तसेच रायगड IIP च्या शाखेची स्थापना करण्यासाठी ज्यांचे विशेष योगदान विसरण्याजोगे नाही असे रायगड भूषण प्राप्त डॉक्टर दाभडकर सरांना मी विनंती करतो की त्यांनी रायगड IIP विषयी आपले मत मांडावे. रायगड IIP.
मराठीत इंट्रोडक्शन दिली, मला मराठीत बोलायला आवडेल. आजच्या कार्यक्रमाचे अध्यक्ष डॉक्टर बकुल पारेख, HSG डॉक्टर बसवराज, माझे सन्माननीय मित्र आणि बेस झोनचे उपाध्यक्ष डॉक्टर जयंत उपाध्ये, महाराष्ट्राचे अत्यंत आवडते प्रिय आणि ज्यांनी खूप काम केलेले असे अध्यक्ष डॉक्टर पांढरीकर, डॉक्टर सदाचार, ज्यांचा आपल्याला खरोखरच अभिमान वाटावा की येऊन येणार कोण, डॉक्टर उपेंद्र किंजवडेकर, माझे सर्व डॉक्टर राजेंद्र बुब, माझे मित्र की ज्यांनी या कॉन्फरन्स करता खूप प्रचंड मेहनत घेतली, ते डॉक्टर गंगोलिया, डॉक्टर जय भांडारकर, डॉक्टर विनायक पाटील, डॉक्टर चांदोरकर, आमच्या रायगड जिल्ह्याच्या अध्यक्षा डॉक्टर सुनीता इंगळे, उपाध्यक्षा चित्रा कुलकर्णी, सेक्रेटरी निलिमा भांडारकर, ट्रेझरर संजीवनी मोरे, इथे उपस्थित असलेले सर्व सिनियर. इट इज व्हेरी डिफिकल्ट, सगळ्यांचे नाव घेणं खरोखरच अवघड आहे, पण माझे आलेले मित्र, CIPचे एक्झिक्युटिव्ह बोर्ड मेंबर, महाराष्ट्राचे एक्झिक्युटिव्ह बोर्ड मेंबर, कळदकर साहेब, वैद्य, माझा मित्र डॉक्टर राजेंद्र वैद्य आणि माझ्या सर्व आलेल्या त्यांचे पूर्ण कुटुंब आणि माझ्या सर्व मित्रमैत्रिणींना होतं. खरं तर आमच्या दृष्टीने, रायगड जिल्ह्याच्या दृष्टीने ही अत्यंत अभिमानाची गोष्ट आहे की ही कॉन्फरन्स एका छोट्या, आतापर्यंत मुंबई झाली, पुणे, अमरावती, मला नाही वाटत एवढ्या छोट्या शहरात झाली. आणि मी नेहमी गमतीने का होईना असं म्हणतो की मुंबई पुण्यात एखाद्या गल्लीत, एखाद्या पेठेत जेवढे पिडियाट्रिशियन असतील त्याच्यापेक्षा कमी पिडियाट्रिशियन आमच्या रायगड जिल्ह्यात आहेत. त्यातले अर्ध्याधिक पनवेल, नवी मुंबई ह्या भागात आहेत. आम्ही सगळे स्कॅटर्ड आहोत. भौगोलिक अंतर खूप आहे आणि हे खरोखरच ही कॉन्फरन्स ऑर्गनाईज करणं त्या दृष्टीने अवघड होतं. पण सुदैवाने मी नेहमी म्हणतो की रायगड जिल्ह्यातली इंडियन अकॅडमी पिडियाट्रिक ही एक नवरत्नांची खाण आहे. आमचं सगळ्यात मधलं नवरत्न हे पनवेलला बसलेले डॉक्टर महेश मोहितेंच्या स्वरूपात आणि 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 आम्ही बाकीचे सगळेजण आहोत, नाही असं नाही. पण आम्ही ही जी रायगड IIP फॉर्म केली, मला वाटतं मला थोडस 3-4 मिनिट वेळ, चांगलं बोलतोय मी तसं.
सर 3 मिनिटं आहेत.
3 मिनिटं बेर नका बाजू, जरा जरा कळू दे. आता अध्यक्ष उपाध्यक्ष कोणीच नाही आले काय. तो सगळ्यात महत्वाचं काय की रायगड IIP फॉर्म कशी झाली ही देखील खूप इंटरेस्टिंग आहे. की आधी आमचा असा मैक मतप्रवाह होता की आपण खूप मोठे आहोत, खूप लांबवर आहोत. आपला रायगड जिल्हा हा वेगळा आहे, भौगोलिक अंतर जास्त आहे आणि सगळ्यात महत्वाचं मुंबई आणि पुणे अगदी जवळ आहे. तर आपल्याला ह्या खरोखरच या रायगड ब्रँचची खरोखरच गरज आहे की वी विल गेट एफिलिएटेड टू एनी ऑफ दी ब्रँचेस इन मुंबई, नवी मुंबई और पुणे. पण आमच्यापैकीच काही तरुण मंडळी होती, तेव्हा मी पण तरुण होतो त्या काळी. तर त्यावेळेस आम्ही सगळे म्हणतो की नाही आपण एक ब्रँच फॉर्म करू. त्यानंतर वेगवेगळ्या कॉन्फरन्सला मला जावं लागलं. तिथे वेगवेगळे ब्रँचेस बक्षीस घेत होते. एके ठिकाणी मी, मला वाटतं इफ आय रिमेंबर, मागच्या औरंगाबादच्या कॉन्फरन्सला का कुठल्या तरी मी एक्झामिनर पण होतो की कुठली बेस्ट ब्रँच आहे. आणि मी पाहिलं आणि म्हटलं की रायगड जिल्ह्यातले पिडियाट्रिशियन त्याच्यापेक्षा चांगलं काम करतायत, आपण ब्रांच फॉर्म करू, आपण सगळे ऍक्टिव्हिटी सुरू करू. आणि यू विल नॉट बिलीव्ह की आम्ही जेव्हा ऍक्टिव्हिटी सुरू केल्या, पहिल्यांदा आमच्या काही ऍक्टिव्हिटी झाल्या, पण मला असं वाटतं आमचे PB जैन सर आहेत, धामणकर सर आहेत, शशांक महाजने आणि यांच्या मार्गदर्शनाखाली मग आम्ही हे काम सुरू केलं. आणि ऑसम एकदा आम्ही घेतली, इट वॉज वंडरफुल. मला वाटतं माथेरानला जे कोणी आले असतील त्यांनी जर पाहिलं असेल तर. त्याच्यानंतर आम्ही धामणकर सर मॅन ऑफ प्रिन्सिपल की वो ऑसम जैसा और एक करेंगे. आणि नागोठण्याला मी जनरल प्रॅक्टिस करतात 300-350 जनरल प्रॅक्टिशनर विदाऊट टेकिंग एनी फार्मा हेल्प, मला वाटतं आंबेडकर सरांच्या मार्गदर्शनाखाली आम्ही केलं. आणि ती पण आमची कॉन्फरन्स म्हणा किंवा जे गेट टुगेदर पिडियाट्रिक रिफ्रेशर कोर्स फॉर ऑल जनरल प्रॅक्टिस यशस्वी झाला. आमचा उत्साह वाढला. आणि मग असं करता करता कधीतरी एकदा आमची ती आंबेडकर सर आले होते, पोद्दार सर आले होते आणि मला आठवतं धामणकर सरांच्या फार्म हाऊसवर मग आपण फॉर्म करू. आणि त्यानंतर धामणकर सरांना आम्ही ते हे केलं आणि मग त्यानंतर ती रायगड इंडियन अकॅडमी पिडियाट्रिक रायगड ब्रँच झाली. पण आम्ही काम करत होतो, आम्ही खूप काम केलं. पण नंतर आमचे तरुण मित्र आले, चांदोरकर आहेत, आबासाहेब पाटणकर आहेत, जय भांडारकर आहेत, हेमंत गंगुले आहेत, आणि त्यांनी हळूहळू सूत्र हातात घेतले. एकदा छोटस एक बक्षीस मिळालं, कुठलं तरी पुरस्कार मिळाला स्टेट कॉन्फरन्सला, आम्हाला आनंद झाला. आणि त्यानंतर मला असं वाटतं की आबासाहेब पाटणकर सारखा धडाडीचा उमेदवार गंगोले यांनी तर आम्हाला एवढं कामाला लावलं, जय भांडारकरांनी दफाल सारखी घेतली. आणि त्यानंतर मात्र रायगड ब्रँचच्या या इतक्या ऍक्टिव्हिटीज केल्या. स्टेट कॉन्फरन्सला, नॅशनल कॉन्फरन्सला हा अत्यंत पुरस्कार म्हणा, बक्षीस म्हणा, जे काय त्याचा भडीमार झाला. आणि सलग 2 वेळेस रायगड IIP ब्रँचला, जी अत्यंत छोटी ब्रँच जी स्थापन करावी का नाही असं चाललं होतं, त्या ब्रँचला 2 वेळेस त्या कॅटेगरीचा बेस्ट ब्रँच पुरस्कार मिळाला. मला असं वाटतं की एवढं जर स्पेक्टॅक्युलर काम केलं असेल तर मग आपण स्टेट कॉन्फरन्स का घेऊ नये. आमचे प्लॅन फार दिवसापासून चालू होते, प्रत्येक आम्ही धडका मारत होतो, आम्हाला द्या आम्हाला द्या, तयारी नव्हती. मागे ते एकदा आमची ब्ल्यू प्रिंट तयार झाली होती, पण आपल्याला नाही जमणार हे. आणि मग 2018 साली जेव्हा डॉक्टर गंगुले आमच्या रायगड ब्रँचचे प्रेसिडेंट होते, तेव्हा आम्ही ही काय म्हणायचं त्याला पांढरीकर बीड, आम्ही हे बीड केलं आणि त्यानंतर ही कॉन्फरन्स आम्हाला मिळाली. पण मॅन प्रपोजेस गॉड डिस्पोजेस, अत्यंत अडचणी आल्या. देवाने आमची परीक्षा पाहिली, आम्ही रिशेड्यूल केले की नको आता ह्यावेळेस आपल्याला शक्य नाही. ह्यावेळेस कॉन्फरन्स होती तर हे होईल का नाही आम्हाला शंका वाटत. थर्ड वेव्ह येण्याची शक्यता आहे, थर्ड वेव्ह येण्याची शक्यता आहे. मला वाटतं आमच्यातही बरेचसे थोडेसे मतभेद होते, घ्यावी नाही घ्यावी, घ्यावी नाही घ्यावी. पण एकदा डिसिजन घेतल्यानंतर एकजुटीने आमच्या लोकांनी काम केलं. आणि जसं डॉक्टर जय भांडारकरांनी सांगत होते की बरेचदा त्याच्या उत्साहाला असा कंट्रोल करावा लागतो. आणि जय भांडारकर, हेमंत गंगुले, आमचे तरुण तडफदार सगळे मित्र, आमच्या अध्यक्षा आणि ह्या सगळ्यांनी, सगळ्यांचे नावं घेणं अवघड आहे, ठरवलं की सर हे चॅलेंज आपण स्वीकारायचं. आणि इट वॉज चॅलेंज, इट वॉज चॅलेंज. फार्माकडून चॅलेंज होतं, फंड जमा करणं अवघड होतं. त्याच्यानंतर काल परत आम्ही 2-3 दिवसापूर्वी प्रचंड टेन्शन मध्ये होतो. पाऊस पडला तर काय करायचं, पाऊस पडत होता, वादळ आलं होतं, काय करायचं. म्हटलं डरणे का नाही, जे होईल ते होईल, आपण बघू, जेवढे लोक येतील तेवढे होतील. पण ह्यावेळेस कॉन्फरन्स करायची. आणि त्यानंतर आम्ही कॉन्फरन्स करायचं ठरवलं. या सगळ्या अडचणीवर मात करत, अहो मॅडम आपण आपल्या रायगड जिल्ह्याबद्दल बोलू दे. झालं एक मिनिट, फक्त 1 मिनिट. आणि त्यानंतर मला असं वाटतं की आम्ही आमच्या कृतीतून आम्ही दाखवून दिलेलं आहे की वी हॅव डन सक्सेसफुल कॉन्फरन्स इन दिस. या कॉन्फरन्सला मी तुमच्या सर्वांचं स्वागत करतो. तुम्ही आलात. जर समजा आमच्याकडून काही चुका झाल्या तर मला जरूर माफ करा, आम्हाला माफ करा. आणि आम्ही तुमची अत्यंत ऋणी आहोत की तुम्ही इथे आलात. वी वेलकम यू ऑल. थँक्यू व्हेरी मच. थँक्यू व्हेरी मच.
आपण कार्यक्रमाच्या पुढच्या सत्राकडे वळूया. May I request Maharashtra IIT Secretary Dr. Sadachar Ujgamkar to present his tenure annual report. Dr. Sadachar, please.
इतक्या ओघवत्या भाषणानंतर बोरिंग रिपोर्ट ऐकणं थोडंसं अवघड जाईल, पण ते माझं काम आहे, मला करावं लागेल. नाही, ऐकावं तर नाही गेलं, तो विषय नाही, आता आला तर ऐकावं लागेल. Indeed, it is very a pleasure to me to present this third year annual report as a secretary of the Maharashtra State today. Honorable Chief Guest, Dr. Bakulji Parekh sir, respected guest of honor, Dr. G.V. Basavaraja sir, he is HSG of CIP 2020-2021. Conference Chairman, Vice President, West Zone, Dr. Jayant Upadhyay sir, Maharashtra IIP State President, Honorable Dr. Jayant Pandrikar sir, Vice President, MAHAIP, Dr. Rajesh Bhoop sir, Organizing Chairperson, Mahapedicon 2021. Actually, it was 2020, but it has converted to 2021. Dr. Hemant Gangolia sir, convener of this conference, Dr. Chandrasekhar Dabadkar sir, Chief Organizing Secretary, Dr. Vinayak Patil, Secretary, Dr. Jay Bhandarkar sir, and our own newly elected, vibrant Dr. Upendra Kinzwadekar sir, President-elect 2022. I welcome you all on behalf of MAHAIP and also all the members of organizing team on the dais, and also those who are attending virtually. I heartily welcome you all and my fellow pediatrician friends. It is indeed a great pleasure to welcome you on occasion of 3rd West Zone Pedicon and 31st Mahapedicon 2021 at such a scenic location of Alibag, Raigad. And it gives me immense sense of accomplishment and satisfaction to present to you this annual report. It was wholehearted support and guidance of our dynamic President of Maharashtra State IIP, Dr. Jayant Pandrikar sir, that made me work to the fullest of my abilities. So I heartily thank him, basically, that he has given me so much of opportunities to work on and so much of projects to work on. Don't worry, I will finish it fast. My dear colleagues, as you all know, COVID pandemic influenced each and everyone's life in last 2 years, and so was the activities of our mother organization, Indian Academy of Pediatrics. As it is a famous quote
that often when you are at the end of something, you are at the beginning of something else. And I will fill in the blanks in the above that as we got struck for physical activities at historic lockdown from 22nd of March 2020, we found out the new beginning of a digital era. And for that, I personally thank, and on behalf of MAHAP and all whole nation, Dr. Bakulji Parekh sir and his team for making available digital platform for pediatric fraternity. For whole nation, and a big salute to you, your innovative leadership, sir. Thank you. So with the availability of virtual platform, we continued our legacy of academic sharing, and it is really very difficult to present all MAHAP activities in 5 minutes, but I have tried my best to get overview of it at least. I will request to present my presentation, which I have given to you. Yeah. It is a report of 2020 and 2021. I will first go to the overview of MAHAP activities which we conducted in 2020, as it was not being reported and presented as there was no physical conference. Reaching the unreached was the principle to follow all over the year, and theme was Trust to Transform, which was meaning originated by our beloved President Dr. Jayant Pandrikar sir. First, our dream project was Bal Swasthya Abhiyan, and due to Corona, we converted into digital mode. So we we made YouTube videos of total 30 YouTube videos were uploaded on Maharashtra IP website, and these YouTube videos were mainly meant for the parental education, and also there was a discussion on various day-to-day elements as well as some of the serious elements about the children. Then there was a inauguration of My Query portal also on our website. It was the idea of our Vice President Dr. Rajesh Bhub Sirji, and it got also an immense response on My Query portal site. Then there was a series of academic webinars by the Maharashtra State IIP on digital platform DIP. I heartily thank DIP for providing us that platform. We conducted these webinars on 3 weekdays, that is every week throughout the year till November, till we conducted our first digital conference, Mahapedicon. For that, more than 200 national and international faculties addressed their scientific updates on various useful topics. And most importantly, as our motto was reaching the unreached, and in that sense, we involved almost all districts of Maharashtra IP state, including Bhandara, Gadchiroli, Nagpur, Parbhani, and every district. No district was left to get involved in all these webinars. With also there was a series of some topics that was also conducted. Then came again this vibrant IIP Raigad. We along with MAHAP organized the Grand Bollywood Quiz at that time, and it was well accepted, and it was very well appreciated by all the runner. The winner of that quiz was Aurangabad, and runner-up was Nashik. Then again, academic quiz was conducted. That was the winner was Solapur, and runner-up was Thane. That was called as Pediatric Premier League. That was also associated with IIP Raigad and MAHAP activity. That is associated activity, conjoined activity. Then came the Mahapedicon 2020. That was conducted from 10th of December to 13th of December. First ever digital level conference, state level conference was conducted on digital platform by MAHAP, and it was addressed by more than 150 faculties online. and attended by more than 1,000 delegates across the state. And it has many first of its kind session online, that is moot court, crack the case challenge, debates, pediatric top 10, and also online culture events. That was that online culture events for the first time it was appreciated. Actually, everybody used to ask online culture event kaise ho sakta hai? Lekin it was done. These are some of the flyers of that conference. Then coming to the 2021 activities, with all these digital, we also got inspired by this all atmosphere of digital background. So we inaugurated our own platform, Digital MahaAP, on 18th of March 2021. It was first time in the history of MahaAP an independent digital platform to conduct various academic and non-academic activities. We also inaugurated the YouTube channel, and also we form our own MahaAP Facebook page. It was followed by pediatric nephrology webinar series in that month only, month of March. It was addressed by many esteemed faculties. It was followed by CME on autism, MahaAP in association with IIP Parbani. We conducted the CME on autism. The speakers were Dr. Madhvi Shelke, Dr. Shirish Bhartiya, Dr. Anjali Bangalore. They guided us on very useful topics in our day-to-day practice. It was followed by the talk on case-based approach to autism by our own expert in developmental pediatrics, Dr. Samirji Dalwai sir. Then this is a one flyer which I have taken, branch OB's meeting. For the first time in MahaAP, we conducted almost 3 to 4 branch OB's meeting in 2 years. And just I taken one flyer and one date to know the inputs from the OBs regarding whatever they want, what activities, what type of activities they want, what type of modifications they want, and what are their preferences, what are our lacunae. Basically, we also wanted to know what are our lacunae. So for that reason, we used to take OB's meeting also. And it was one of the major TOT with West Zone we did, that is West Zone TOT of Mission Kovin Uday. It was conducted all over the state, publicized widely, and it was attended by many large number of delegates. And district-wise distribution was made for that TOT, and it was conducted very smoothly by Central IIP. Thanks to the Central IIP, Dr. Januji Upadhyay sir, for conducting this Kovin Uday so immensely and so propagatively. Thank you. Thank you, sir. Then one of the topic, newborn hearing screening, was also celebrated by us in month of March. Then we also conducted one PG clinic, which was widely distributed, propagated all over Maharashtra with IIP Pune. Then there was a preparation for COVID care in children. The major TOT came. Our Honorable Chief Minister, under the guidance of Honorable Chief Minister Dr. Sri Uddhavji Thackeray sir, and Chairman of our Prabhu sir, Chairman sir for COVID Task Force. This TOT was released, and we conducted it almost in all the regions in just a matter of 7 days. Every day we used to conduct these TOTs for that region wise: South Maharashtra, West Maharashtra, North Maharashtra, Vidarbha, and this thing. It was meant to guide the IAPNs, district task force members, pediatricians, doctors, MOs of government health systems, to how to deal with the probable, which was the most probably that time used to mention regarding the pediatric COVID wave आ रहा है. अभी COVID wave pediatric को ज़्यादा, pediatric fraternity को ज़्यादा affect करेगा. So you all know we have gone through all that. These are some of the flyers of that COVID TOT that I am showing you. Then there were the series of developmental behavioral adolescent issues webinar in the month of September, August and September. It was the scientific convener was Dr. Suchit Tambori sir, and many stalwarts attended it, and it was very innovative webinars. Basically, you can go to archive site of DIP and you will find it. if you want to see it again or visit it again. Then pediatric update 2021 series was conducted all over the year, and it was conducted every Saturday consecutively for 18 weeks. And it was addressed by all the galaxy of speakers all over the nation. Even some of the time, some speakers, international speakers were also there. And it was definitely a most popular program this year by us. And a special thanks to Dr. Upendraji Kinzwadekar sir as a scientific convener. Special applaud for that. These are some of the flyers which I am showing you. Basically, with a lack of time, I can't say the names of the topics. Let us go ahead. Then this was another non-academic forum that we created on Mahaip Katta. That is Mahaip Katta. Mahaip Katta was meant to reduce the whatever stress was created by the ongoing COVID. So it was the idea of all our core Mahaip members. Our president, Dr. Jayant Pandrikar sir, took initiative for that, and we started this Mahaip Katta. In that we invited the dignitaries from the musical field who have done the exceptional work in musical field, or artists, or say these historians, then many distinguished personalities, directors of the movies. In that, I am showing this flash to you that we are conducted with whom. That Amar Adke from Durga Abhyasak, then Sudhir Gadgari sir, then Rajesh Mapuskar, the well-known director, then this Ashutosh and Sujata Kelkar, and then many, Madhuri Kanetkar madam, Pratik Gaikwad, Mandar Bharde, Gaitunde sir, Prashant Devasari. And our core members of Mahaip Katta were Dr. Abhinay Daravde, Dr. Upendra Kinzwadekar sir, and then Dr. Shubhda Khirwadkar, Dr. Shekhar Dabadkar, Dr. Deepa Firke. These were our core members of Mahaip Katta. We used to do a lot of meetings and discussion, then whom we can call, because calling is we can have many celebrities whose name we can come to our mind, but making it happen is a little different story. So with this, we conducted, who were possible for us, we conducted that, and it was also very well appreciated all over the Maharashtra. Yes, I am completing. Thank you. Then it was a midterm conference, Capcom 2021. It was the first physical Mahaip meet after dreadful COVID pandemic. It was attended by many delegates, and BLS workshop, many NRP, CPAP, and public forum behavioral issues were the landmarks of that. And then midterm CME Yatma. Very thank you for hearing me patiently, and I think I thank you from the heart, and I thank Raigad IIP also for bearing me for the last 5 minutes. Thank you.
Hello. Thank you, Dr. Sadachar sir. Now I request Mahaip Secretary Dr. Now I request Dr. Jayant Pandrikar sir, President Mahaip, to express his view.
आदिशक्ती महामाये फक्त दुःख विनाशिनी चरणाबुंजी सदारुंजी अंबिका कुलस्वामिनी. या रायगडच्या मायभूमीत, या रायगडच्या शिवाजी महाराजांच्या कर्मभूमीत, शिवाजी महाराज संपूर्ण महाराष्ट्राचं कुलदैवत, या सर्व पुण्यभूमीमध्ये सर्वप्रथम मी आई भवानीला साष्टांग नमस्कार करतो आणि आजच्या कार्यक्रमाच्या भाषणाला सुरुवात करू. आजच्या कार्यक्रमात उपस्थित मंचावर आदरणीय आमचे मोठे बंधू IPP सर डॉक्टर बकुलभाई, आजचे गेस्ट ऑफ ऑनर, एव्हरग्रीन पर्सनॅलिटी आणि कधी त्यांना विचारा सर, बिलकुल एका मिनिटात रिप्लाय तयार असले असे डॉक्टर बसवराज जी. सर आई होप मैंने क्या बोला मराठी समझाया होगा आपको. ओके 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 थोड़ा. President elect for 2022 Dr. Upendra, my friend, my batchmate and Vice President of the West Zone, Dr. Jayant Upadhyay, Dr. Sadachar, Dr. Evergreen personality of Raigad IIP, Dr. Dabhadkar sir, ever young I should say, Dr. Dabhadkar sir, and Dr. Hemantbhai Gangulia, of course, dynamic President of Raigad IIP, Dr. Ingre Madam, Dr. Rajesh Boop, त्यानंतर of course Dr. Organizing Secretary of this conference, जे नेहमीच पडद्यामागे असतात परंतु खूप काम करतात असे माझे मित्र डॉक्टर विनायकजी पाटील आणि डॉक्टर जय भांडारकरजी. इथे उपस्थित असलेले 5 प्रेसिडेंट ऑफ सेंट्रल आयपी डॉक्टर राजूभाई शहा आणि रायगड आयपीचे सिनियर मेंबर डॉक्टर धामणकर सर आणि सर्व उपस्थित इथे ईबी मेंबर्स, ओबी मेंबर्स. मी तुमच्याकरता फक्त 2 लाईन्स म्हणतो. आपण कसं असावेत, न संपणारी एखादी स्वप्नांची सुंदर माळ असावी, ग्रीष्मात पडेल अशी ढगांची सर असावी आणि अर्थात न मागताही साथ देणारी तुमच्यासारखी सर्व सुंदर माणसं महाराष्ट्र आयपीएन्स माझ्यासोबत असावी, एवढंच मागणं मी तुमच्याकडे मागतोय. मित्रांनो, 2020 साली महाराष्ट्र आयपीची धुरा माझ्याकडे आली अध्यक्ष नात्याने आणि मी ती विनम्रपणे स्वीकारली आणि आमची पहिली ईबी मीटिंग इथेच रायगड मध्ये झाली होती. त्यावेळेला खूप सारे स्वप्न होती आणि APJ Abdul Kalam always says that you should always dream high because dream converts in your thoughts into actions and actions into success. So असं वाटलं की तसं होईल आणि तसं करू, त्याप्रमाणे करायचा खूप आम्ही प्रयत्न केला होता 2020 साली आणि त्याच वेळेला बरेचसे प्रोग्राम्स आम्ही ॲज अ महाराष्ट्र आयपीचा प्रेसिडेंट ॲक्शन प्लॅन आम्ही लॉन्च केला होता. परंतु दुर्दैवाने अगदी कोविड सुरू झालं. सगळ्यात महत्त्वाचा मोठा प्रोजेक्ट आमचा होता म्हणजे बाल स्वास्थ्य अभियान, जो प्रोजेक्ट माझे मित्र डॉक्टर समीरभाई दलवाई, डॉक्टर बेला वर्मा मॅडम, डॉक्टर महेशभाई मोहिते आणि सर्व महाराष्ट्र आयपीने आम्ही प्लॅन केला होता आणि आमचं सगळं ठरलं होतं. इन कोलॅबोरेशन विथ गव्हर्नमेंट ऑफ महाराष्ट्र आम्ही हा पूर्ण प्रोग्राम चॉकआउट केला होता. ऑफकोर्स बकुलभाईंचं मार्गदर्शन होतंच बिकॉज ही वॉज प्रेसिडेंट ॲट दॅट टाइम आणि सगळं झालं होतं, सगळं ठरलं होतं. 7 एप्रिलला आम्ही माननीय उद्धवजी ठाकरे आणि शरद पवारजी यांच्या उपस्थितीत आम्ही हे लॉन्च करणार होतो, पण दुर्दैवाने कोविड आला. पण मी इथे सांगू इच्छितो डॉक्टर समीरभाई की मी कालच रायगड आयपीने माझं स्वप्न पूर्ण केलेलं आहे. कारण की त्यांनी काल इथे बेसिक्स पीडियाट्रिक्स फॉर प्रॅक्टिशनर हा जो प्रोग्राम तिथे लॉन्च केला, हा त्याचाच एक भाग होता आणि मी तर म्हणेल की काल हा प्रोग्राम इथे लॉन्च झालेला आहे आणि येणाऱ्या पुढच्या वर्षीपासून येणारे अध्यक्ष हे तो प्रोग्राम पुढे कंटिन्यू करतील असं मी सांगेन. तर थँक्स टू रायगड आयपी फॉर टेकिंग अप दिस प्रोजेक्ट. त्यानंतर मग मात्र अनेक प्रोग्राम झालेत, आपण बघितलेत. महापेढी उत्सव झालं. डॉक्टर सदाचार यांनी आता सांगितलं की महापेढी उत्सव वॉज रिअली ऑसम. खरोखरच आय मस्ट थँक ऑल द टीम, बट आय मस्ट मेन्शन वन नेम, डॉक्टर शिपाज जहागीरदार and डॉक्टर सदाचार who is the organizing secretary for that महापेढी उत्सव. 5 दिवस पूर्ण डिजिटल इव्हेंट झाले, खूप काही छान असे त्यात प्रोग्राम झालेत आणि अर्थातच हे सगळं काही शक्य झालं फक्त आणि फक्त बकुलभाई यांच्या DIP मुळे. अदरवाइज इट वुड नॉट बी पॉसिबल. त्यानंतर 2021 उजाडलं आणि त्यामध्ये मग आम्ही पुन्हा एकदा ईबी मीटिंग घ्यायचा प्रयत्न केला होता, परंतु ती फिजिकल ईबी मीटिंग पण होऊ शकली नाही. पण त्यानंतर व्हर्च्युअल ईबी मीटिंग पुष्कळ झाल्यात आणि मग आता त्या सांगितलंय डॉक्टर सदाचार्य यांनी खूप सारे CMEs झालेत, खूप सारे व्हर्च्युअल आम्ही प्रोग्राम्स घेतलेत आणि आय मस्ट थँक डॉक्टर उपेंद्र किंजवाडेकर फॉर कंडक्टिंग पीडियाट्रिक अपडेट प्रोग्राम्स आणि त्यामध्ये जवळपास आम्ही 20 प्रोग्राम्स आम्ही घेतलेत. We invited faculties not only from India but from across the globe we invited and it was a wonderful academic feast. Then we had this neurology update from which were organized by Dr. Suchit Tamboli. ते पण आमचे इव्हेंट्स खूप झाले. It was well appreciated. आणि मग त्यानंतर PCC मॉड्यूल जे होतं दॅट इज पीडियाट्रिक कोविड केअर, हा जे इन चिल्ड्रन हा जे मॉड्यूल लॉन्च झालं महाराष्ट्र गव्हर्नमेंटचं, त्यांच्या टास्क फोर्सचं आणि डॉक्टर सुरेश बाबू सर त्यांनी सांगितलं की जयंत कसं करायचं. माझी जबाबदारी इतकी होती की फक्त गव्हर्नमेंटला सांगायचं पुढे काय करायचं. आय टोल्ड सर वी आर देअर, आम्ही आहोत ना. अँड देन वी कंडक्टेड दी BCC मॉड्यूल इन ऑलमोस्ट 7 regions. सलग 7 दिवस आम्ही ते अरेंज केलेत आणि वी ट्रेन ऑलमोस्ट मोर दॅन 2700 pediatricians and almost these pediatricians, then other doctors, they trained almost 27,000 healthcare workers that include जनरल प्रॅक्टिशनर्स, दॅट इंक्लूड नर्सेस अँड हेल्थकेअर प्रोव्हायडर्स. तर असा हा एक पीसीसी मॉडेलचा एक खूप मोठा इम्पॅक्ट झाला आणि कदाचित म्हणूनच की काय आमचं जी कोरोना घाबरला आहे आणि थर्ड वेव याला तो आता येत नाहीये असं मी म्हणेन आहे. देन वी हॅड आफ्टर पीसीसी मॉड्यूल we had the beautiful conference which was held at Kolhapur. Initially it was a just one day event आणि त्या तिथे पण असं आम्हालाही वाटलं की जस्ट छोटासा एक दिवसाचा इव्हेंट असेल. परंतु लेट मी कॉंग्रॅच्युलेट द टीम, डॉक्टर नानी बडेकरजी, डॉक्टर दीपा फिरके, डॉक्टर सुनील पाटील, डॉक्टर संगीता कुंभोजकर. त्यांना कुठलीही गोष्ट म्हटली आपल्याला एक आणखीन एक दिवस वाढवता येईल का? हो सर, हरकत नाही. आपण वर्कशॉप घ्यायचे का? हो सर, हरकत नाही. आपण पब्लिक फोरम घ्यायचा का? हो सर, हरकत नाही. असं म्हणत ती मिड टर्म कॉन्फरन्स होती, परंतु इट वॉज ॲट पार विथ एनी महापेडिकॉन. सो कॉंग्रॅच्युलेशन्स टू कोल्हापूर अकॅडमी ऑफ पीडियाट्रिक्स. सेम वी हॅड सीएमई ॲट यवतमाळ, जी आता मागच्या वेळेस झाली. त्यानंतर बऱ्याच गावांमध्ये छोट्या छोट्या सीएमई झाल्या दॅट वी कंडक्टेड नाव फिजिकली. येस, नाव द वन मोर थिंग, नाव द फोर्थ कमिंग इव्हेंट जे आहेत त्याबद्दल मी माहिती सांगेन की आता पुढचं 18 आणि 19 डिसेंबरला अमरावतीला एक महाआयपी स्पोर्ट्स होऊ घातलेला आहे. हे स्पोर्ट्स मागच्या वर्षी आम्ही प्लॅन केलं होतं, अगदी सगळं ठरलं होतं, पण वन्स अगेन दॅट करोना. पण आता मात्र कोरोना येणार नाही याची तुम्हाला शाश्वती देतो, ग्वाही देतो आणि येत्या 18-19 डिसेंबरला आपण सर्व महाराष्ट्र आयपीएनसी अमरावतीला यावं असं मी आपणास विनंती करतो. आणि त्याच इव्हेंटमध्ये आम्ही एक बकुल भाई, हम एक जो ये है मॉड्यूल है वो रोल आउट करने वाले हैं, जो काफी पहले होने वाला था, बिकॉज ऑफ सम रीजंस नहीं हो पाया. अभी सोचा कि फिजिकली लॉन्च करेंगे. दैट इज अवेयरनेस फॉर प्रिवेंशन ऑफ सिकल सेल थैलेसीमिया मॉड्यूल. एक 3 घंटे का मॉड्यूल हमने बनाया है. Dr. Naresh Taide, then Dr. Karle, they have worked on it and beautifully they have made this module and we are going to read out in the coming Maha-IP sports. तर मित्रांनो, असं सुंदर असं एक वर्ष झालं आणि त्यानंतर परिस्पर्श नावाचं आमचं जे बुलेटिन होतं, गेल्या 2 वर्षांमध्ये मागच्या वर्षी म्हणजे 5 त्याचे आम्ही बुलेटिन एडिशन्स काढले. याही वर्षी आतापर्यंत आम्ही 4 एडिशन्स काढलेले आहे. आणखीन एक 5वा आमचं एडिशन होणार आहे. तर थँक्स डॉक्टर संदीप दानखडे and Dr. Sadachar for that. मित्रांनो, दिस इज नाउ टाइम टू से थँक्स, कारण की जरी माझं टेन्युअर 31 डिसेंबरला संपत आहे, परंतु दिस इज लास्ट ओकेजन व्हेन आय कॅन थँक ऑल माय सिनियर्स, दोज हू हेल्प मी. अनडाउटेडली सगळ्यात पहिलं नाव मी बकुलभाई यांचंच घेईल, कारण की माझी टेन्युअरची सुरुवात त्यांच्या या DIP मुळेच सक्सेसफुल झाली असं मी नक्कीच म्हणेन. देन ऑफकोर्स बसवराज सर को कभी भी कुछ भी मांगो, बिलकुल हाँ बिलकुल, ही नेव्हर सेड नो. कधी त्यांनी नाही म्हटलंच नाही. आणि आज मेल टाका, नेक्स्ट डे मॉर्निंग सकाळी डोळ्याचं उठल्या पहिले बसवराजांचं मेल, येस यू गॉट इट, असं सरांचं अप्रोच होतं. सर थँक्यू व्हेरी मच. आय मस्ट थँक डॉक्टर पियुष भाई गुप्ता, आय मस्ट थँक डॉक्टर दाभाडकरजी. आणि मागच्या वेळेस ते अगदी असे मागेच लागायचे, हो हे करा, हो ते करा, आणि ते करून घ्यायचे. सो थँक्स डॉक्टर दाभाडकरजी. अँड आय मस्ट थँक डॉक्टर जयंत उपाध्याय, माय फ्रेंड, who we are working in hand. That's why we have had this third zone west zone pedicon, this Maha-IP 31st Mahapedicon असं आमचं हे झालेलं आहे. I must thank all the EB members of Central IP, all the EB members of Maharashtra IB, and I must thank all the OB members, म्हणजे आम्ही ज्यांना म्हणतो अध्यक्ष आणि सचिव, सर्व ब्रांचेसचे, डिस्ट्रिक्ट श्रेय खरोखरच कुठल्याही संघटनेचं यश हे काही एका माणसाने नसतं, हे सर्वांमुळे असतं. विशेषतः ग्रासरूट पासून ज्यांनी काम केलं त्यांचं असतं. त्या सर्व यशाचं श्रेय मी त्या लोकांना देतो. सर्व जितक्या डिस्ट्रिक्टचे ब्रांचेस आणि प्रेसिडेंट सेक्रेटरी आहेत त्यांना मी श्रेय देतो. प्लीज एक जोरदार टाळ्या त्यांच्याकरता होऊन जाऊ देतो. आणि आमचा अमोल पवार नाही का, बिलकुल पैशाचा सोडत नाही तो, ही ट्रेझरर या पक्का तो. सर कशाला खर्च करायचे, सर काय करायचं याचं, आणि असा हा आम्हाला अमोल मिळाला, ट्रेझरर मिळाला. आय मस्ट थँक अमोल फॉर मेटिक्युलसली प्लॅनिंग दिस अकाउंट्स अँड एव्हरीथिंग. डॉक्टर राजेश बू व्हाईस प्रेसिडेंट, त्यांचं नेहमी मला सदैव सहकार्य राहायचं. आणि सगळ्यात शेवटी डॉक्टर सदाचार, मला तुम्हाला थँक्स मी म्हणायची इच्छा नाहीये, याच्याकरता नाहीये की तुम्ही माझ्यासोबत आहात. आपण एकाच संसाराची 2 चाकं आहोत. एक चाक इकडे गेलं, एक चाक तिकडे गेलं, संसार चालणार नाही, गाडी रुळवून चालणार नाही. त्याच्यामुळे तुम्हाला मी धन्यवाद नाही म्हणणार, मी तुम्हाला मिठीत घेऊन एक सांगेल की नाही, आपण दोघं सोबत होतो, सोबत राहू, नेहमी असं तुम्हाला सांगेल. आय मस्ट थँक माय फॅमिली, कारण की मला असं वाटतं की माझ्यामुळे या बरेचदा ते लोक सफर झालेत. आणि एक माझी जी रूम होती, प्रत्येक वेळेस मी येऊन त्या रूम चालू जायचो. आमची सौभाग्यवतीने म्हणायची गेले स्टुडिओमध्ये, कारण की नेहमी स्टुडिओ ते झालं की व्हर्च्युअल सुरू जायचं, नेहमी ती म्हणायची गेले स्टुडिओमध्ये, कुठे गेले डॉक्टर स्टुडिओमध्ये आहेत असं म्हणायची. एनिवे, थँक्स टू माय फॅमिली ऑल्सो. त्यानंतर आय वुड से की थँक्स टू ऑल दी महाराष्ट्र IAPNs ज्यांनी खरोखरच पूर्ण वर्षभर 2 वर्षभर मला साथ दिली. कळत नकळत कोणाची नावं मी घेऊ शकलो नाही, कारण की वेळेचं बंधन लगेच मॅडम म्हणतील हो बंद करा, म्हणून मी नावं घेऊ शकत नाहीत. But really, I'm thankful to each and every Maharashtra IAPNs, those who helped. My friend Dr. Satish Agrawal sir, ते कॉन्स्टंट सांगायचे की असं नाही असं करायचं, थोडंसं आपण असं पॅटर्न करूया. थँक्स टू हिम ऑल्सो. आणि मित्रांनो, मी इतकंच म्हणेन की द सक्सेस जी काय असेल या पूर्ण 2 वर्षाची, त्याचं सगळं श्रेय तुम्हा सर्वांना आहे. आणि जर काही कुठे लॅक्युनरी राहिले असतील तर ॲज अ हेड ऑफ द ऑर्गनायझेशन प्लीज ॲक्सेप्ट माय apologies for if there are any lacunas on behalf of lacunas in the last 2 years असं मी सांगेन. मी एवढं शेवटी म्हणेन की मित्रांनो, शायरी नुसतीच गावया आलो इथे, शायरी नुसतीच नाही गावया आलो इथे, तुमच्यासारख्या जिंदा दिलांच्या दर्शना आलो इथे. शायरी नुसतीच नाही गावया आलो इथे, तुमच्यासारख्या जिंदा दिलांच्या दर्शना आलो इथे. प्राण साऱ्या मैफिलींचे यांनाच आम्ही मानतो, प्राण साऱ्या मैफिलींचे यांनाच आम्ही मानतो. नुसतेच नाही मैफिलीचे, आम्ही आपणास आपले स्वतःचे मानतो, आम्ही आपणास सर्वस्ताचे मानतो. धन्यवाद. थँक्यू. जय हिंद, जय आय.
May I request Vice President Dr. Jayant Upadhyay to express his thoughts in 2 minutes, please. We are waiting for the great cultural evening.
Good evening. Excuse me, I'll be taking too many names to make my obligations to each and every person very, very clear. Respected Dr. Bakul Parekh, the iconic, visionary president of CIP, who has blessed us, all of us, with his unique idea of DIP. We have all enjoyed academics because of him only. Dr. Piyush Gupta, president of CIP, in his absentia. Dr. Ramesh Kumar, president-elect, in his absentia. Dr. Upendra Kinjwadekar, our own, my elder brother, our own man, president-elect 2022. Dr. G.V. Basavaraj, the mitochondria of Central IAP for last 2 years, and my very good friend, Dr. Samir Dalwai. We know him as a very good speaker, and my good friend and the Joint Secretary of Central IAP, Dr. Purna Kurkure Madam, the Treasurer, the Khajanchi of Central IAP. Dr. Raju Shah, immediate past president, he is amongst us. All the executive board members of 2021, Dr. Nani Vadekar, Dr. Jadhav, Dr. Anil Raut, Dr. Andankar, Dr. Anandesh Pandey, respected all national executive board member, I congratulate them who are elected for the year 2022. Dr. Pramod Kulkarni, Nani Vadekar, Dr. Ramakant Patil, Dr. Sanjay Deshmukh, Dr. Vela Verma. The state presidents, Dr. Jayan Pandrikar, my batchmate and my good friend, Dr. Yogesh Parikh and Dr. Dhanesh Olvaikar, president of Gujarat and president of Goa, in their absentia, I have to mention their name. Dr. Rajesh Bhub, vice president of Maharashtra IAP, Dr. Sadachar, Dr. Manish Mehta, and Dr. Suman, secretaries of Maharashtra, Gujarat, and Goa, respectively. My dear friend, Dr. Amol Pawar, this dynamic treasurer of MahaAP. Dr. Mahesh Mohite, who is the scientific convener of this conference, 3rd West Zone Pedicon and Mahapedicon. The never exhausting team of IAP Raigad. I would like you to give a big clap for this team. Thank you. Dr. Hemant Gangolia, the chief organizing chairman. Dr. Vinayak Patil, the chief organizing secretary. My good friend and my predecessor, vice president Dr. Chandrasekhar Dabhadkar, whom I fondly call Marotrao. Dr. Jay and Nilima Bhandarkar, the evergreen couple of IIP Raigad. Dr. Sunita Ingre Madam, Sunita Vaini, the president of IIP Raigad. All the Maharashtra, Gujarat and Goa branch presidents, secretaries and executive board member, all the teachers, seniors and my fellow pediatrician. I welcome you as the National Vice President of CIP 2021, the conference chairman of this third West Zone Pedicon and Mahapedicon, and as chairman of the scientific committee of this conference. Heartily welcome you for this academic bonanza. Now, this is a unique conference because it is being held on virtual as well as physical platform. It's a hybrid conference. There are 3 halls, one physical, which is also virtual, and 2 virtual halls. The misery and the dreadful scenery of COVID is over, and we are coming together to celebrate this academic feast. Now, West Zone Pedicon is a platform to showcase the talent, to showcase the academic acumen, and to project the new generation of pediatrician, now new generation of academician in front. So this is a unique platform not only for Maharashtra but Gujarat, Goa, and entire India. We have planned. Dr. Mahesh Mohite can tell about it. We have planned few sessions which are entirely for pediatricians who are under 40 years of age. Case challenge is a unique concept which was successful last year and which will be appreciated all across the country. People are waiting for it. I have got telephone calls for that. Coupling West Zone Pedicon and Mahapedicon, we have faced many challenges. Post-COVID time it was. So getting faculties, getting sponsorship, so many issues, solving those problems and protocols. But me with the Maharashtra IIP president, my friend Jayant Pandrikar, with the organizing team, with blessings from Dr. Bakul Parekh, Dr. Piyush Gupta, Dr. Basavaraj, we solved that tangle. I would like, and I'm very thankful because it was a complicated issue, but it was handled carefully and we have shown that we are all together. Unique event in this conference is participation by UNICEF. UNICEF has promised sponsorship for this conference and we are lucky to have 2 sessions. One was today in the morning and second will be tomorrow. There were issues, but they were very effectively solved thanks to CIP office bearer, Piyush Bhai, Basav Bhai, Bakul Bhai, Purna Madam and Samir Dalwai. Participation of MAIP and their support was immense. Now, I expect you, I'm not going to go further. I expect you to enjoy this academic cultural feast for next 3 days, starting from today. And I wish you all a happy conference, a happy academic event, and a happy togetherness. Thank you very much. Thank you. Good night.
Hello. Thank you, sir. Now I request Dr. Baswaraj sir, Honorary General Secretary, Central IIP, to express his few words.
Thank you. Respected our visionary president of 2020, Dr. Bakul Jayant Parekh sir, and Vice President Dr. Jayant Upadhyay, Conference Chairperson, and President-elect of 2022, Dr. Upendra Kinjidekar, our Maha-IIP President, Dr. Jayant Pandrikar, Secretary Sadachar, and Treasurer Dr. Amol Pawar, and respected seniors, our past President of Indian Academy of Pediatrics, Professor Raju C. Shah, Dr. Abhay Shah, Satish K. Tiwari, Dr. Satish Agarwal, Rajendra Vaidya, Eman Joshi sir, and our treasurer Purna Krukure madam, and joint secretary Evergreen Dynamic Dr. Samir Dalwai. First of all, let me explain the origin of this West Zone Pedicon, how the things started. In the year 2020, in the January EB meeting at Hindo Pedicon, our young and dynamic Vice President of 2020, Dr. Chandrasekhar Dhavadkar sir, so very enthusiastically is planned, but the COVID came in the way. But his enthusiasm did not stop. He pursued with the present our Vice President, Dr. Jayant Upadhyay. So really it's coordinated all with an organizing team of Raigad. So just a month back, they were still discussing about how do we go about, because there was a big CapCon in at Kolhapur. So there was almost like in a state level CME, it is like a state conference like thing. So sponsorship was a big issue, but the team Raigad, which is led by Dr. Hemant Gangolia sir, Dr. Sunita Ingle madam, and Dr. Nilima Bhandarkar, and Jayant Bhandarkar, and Chitra Kulkarni madam, Dr. More, and Vinay Patil, and Rajesh Boop, all their worked tirelessly to make this as a wonderful conference with an excellent academic and cultural events is planned, and all the things, all the credit goes to the team Raigad under the guidance of Maha IAP. Coming to the Maharashtra IAP is always in a vibrant, one of the biggest branch in the Indian Academy of Pediatrics, with the stalwarts like Dr. Bakul Parikh sir, Dr. Vijay Avle sir, Y.K. Amdekar sir, and many more. I can take any number of things. They're actively involved, not only the actively involved, constructively contributing to the academics of the Indian Academy of Pediatrics. Thanks to Maharashtra Academy carrying out all the central IAP activities with our executive board member of 21, which Dr. Parmanand Anandkar, Prashant Jadhav, Dr. Anil Rawat, Narendra Nanevadekar, and Anand Deshpande. They've done and taken all the academics to the nook and corner of Maharashtra. Thanks to the team 2021, I'm sure the incoming team, which is going to be there once again, Dr. Purna madam and Dr. Samir Dalwai with Ramakant Pantil, Narendra Nanevadekar, from Professor Pramod Kulkarni, Professor Bela Verma madam. So I'm sure this will be legacy will continue with that. So it is all IAP which is known for the excellent academic. So I'm sure the what is started, it will continue. It will take the IAP into the greater height. Once again, wishing you all the best for this conference. Thank you. Thank you very much.
Hello. Yeah. We just now received message from our president. My best wishes for all my friends from Maharashtra and all organizers, faculty, delegates for enjoying the hospitality at Raigad with fantastic academic and culinary feast. The retreat for not being there physically, but in my heart, I am with you all, Dr. Piyush Gupta. I'm also delighted to note that UNICEF is supporting this conference. Jai IAP, Jai Hind. Also, the President-elect, Dr. Ramesh Kumar sir, has also sent best wishes. Now we move on to the next part, that is release of souvenir of Mahapedicon and Maha IAP Bulletin. May I call upon editors of Raigad IAP, Dr. Neha Singh and Dr. Rajendra Sandorkar, as well as Dr. Sandeep Dhankhade and Dr. Sripad Jagirdar on stage. We request our chief guest, Dr. Bakul Parekh sir, and guest of honor, Dr. G.V. Basavaraja sir, to release the souvenir as well as Maha-IAP bulletin. मी माननीय डॉक्टर बकुल पारेख सर आणि डॉक्टर बसवराजा सर यांना विनंती करते की त्यांनी बुलेटिन व सोविनियर प्रकाशित करावे. आपल्या महा-IAP बुलेटिनचे को एडिटर डॉक्टर सदाचार उजलमकर सर आहेत. आम्ही रायगड IAPians डॉक्टर सदाचार उजलमकर यांना विनंती करतो की त्यांनी महा-IAP बुलेटिन प्रकाशित होण्यासाठी द्यावे.
Souvenir release and Maha-IAP bulletin release. आपण डॉक्टर सुधा चौधरी मॅडम मॅनेजमेंट ऑफ द हाय रिस्क इन्फंट बियॉन्ड सर्वायवल हे पुस्तक पण आज रिलीज करत आहोत, प्रकाशित करत. डॉक्टर सुधा चौधरी यांनी लिहिलेलं पुस्तक आहे.
प्रोफेसर
डॉक्टर प्रमोद कुलकर्णी, कार्यक्रमाला थोडस वेळ होतोय पण सगळ्यांचं माफी मागतो. अजून सत्कार समारंभाला सुरुवात करूया. मी विनंती करेन डॉक्टर हेमंत गांगुले सरांना की त्यांनी डॉक्टर उपेंद्र किंजवडेकर यांचा शाल व श्रीफळ देऊन सत्कार करावा. तसेच डॉक्टर निलिमा भंडारकर मॅडमना मी विनंती करतो की त्यांनी डॉक्टर पूर्णा कुरकुने मॅडमचा शाल व श्रीफळ देऊन सत्कार करावा. डॉक्टर
उपेंद्रचा सत्कार करायचा.
गांगुले डॉक्टर गांगुले सरांचा.
मला साहेब
अरे बसवरांचं नाव आहे. ये उपेंद्र
डॉक्टर सुनीता इंगळे मॅडमना विनंती करतो की त्यांनी डॉक्टर पूर्णा कुरकुरे मॅडमचा शाल देऊ शकतात. डॉक्टर निलिमा भंडारकर मॅडमना विनंती करतो की त्यांनी डॉक्टर बेला वर्मा मॅडमचा शाल व श्रीफळ देऊन सत्कार करा. डॉक्टर निलिमा भंडारकर मॅडम डॉक्टर बेला वर्मा मॅडमचा शाल व श्रीफळ देऊन सत्कार. मी डॉक्टर वैभव देशमुख सरांना विनंती करतो की त्यांनी डॉक्टर नानिवडेकर सरांचा शाल व श्रीफळ देऊन सत्कार. डॉक्टर प्रमोद वानखेडे सरांना विनंती करतो की त्यांनी डॉक्टर नानिवडेकर सरांचा सत्कार. डॉक्टर समीर दरवे सरांचा सत्कार डॉक्टर वैभव देशमुख सरांना विनंती करतो. डॉक्टर आबासाहेब पाटणकरांना विनंती करतो की त्यांनी डॉक्टर रमाकांत पाटील सरांचा शाल व श्रीफळ देऊन सत्कार करा. डॉक्टर रमाकांत पाटील. डॉक्टर वैभव देशमुख सरांना विनंती करतो की त्यांनी डॉक्टर प्रमोद कुलकर्णी सरांचा शाल व श्रीफळ देऊन सत्कार करा. डॉक्टर महेश मोहिते सरांना विनंती करतो की त्यांनी डॉक्टर राजीव शहा सरांचा शाल व श्रीफळ देऊन सत्कार करा. डॉक्टर महेश मोहिते सरांना विनंती करतो की त्यांनी डॉक्टर राजीव शहा सरांचा सत्कार करा. डॉक्टर वैभव देशमुख सरांना विनंती करतो की त्यांनी डॉक्टर संजय देशमुख सरांचा शाल व श्रीफळ देऊन सत्कार करावा.
नानिवडेकर सर आलेत का? मी डॉक्टर आबा पाटणकर सरांना विनंती करतो की डॉक्टर संजय जोशी महाराष्ट्र ईबी मेंबर ते मगाशी नव्हते तर त्यांचा सत्कार करावा. मी डॉक्टर वानखेडे सर सरांना विनंती करतो की डॉक्टर सागर वाघ सर यांचा सत्कार करावा. डॉक्टर आबा पाटणकर सरांना विनंती करतो की डॉक्टर अनिल राऊत सरांचा सत्कार करावा. डॉक्टर सागर वाघ सरांचा आधी सत्कार होईल, नंतर डॉक्टर अनिल राऊत सरांचा.
मी विनायक पाटील सरांना विनंती करतो की त्यांनी डॉक्टर अमोल पवार सरांचा शाल व श्रीफळ देऊन सत्कार करा. ही डॉक्टर मी डॉक्टर दामनकर सरांना विनंती करतो की त्यांनी डॉक्टर नानिवडेकर सरांचा सत्कार करावा. की डॉक्टर दामनकर सरांना विनंती करतो की त्यांनी डॉक्टर नानिवडेकर सरांचा शाल व श्रीफळ देऊन सत्कार करावा.
सत्कार समारंभ आपण आता पूर्ण करून पुढच्या कार्यक्रमाकडे वळतो आहे. सर्व मान्यवरांनी परत स्थानपन्न व्हावे. So the tenure of President Dr. Jayant Pandrikar sir is now concluding, and we are going to witness now the changing of baton to the new president of Maharashtra IAP. May I call upon President Dr. Jayant Pandrikar sir to change the medallion to incoming President Dr. Gangolia sir.
I request Dr. Gangolia sir, Chief Organizing Chairman of this conference, very good organizer, expert in event management, medical legal consultant, past IIP Raigad president, and incoming Maha IIP president to express his thought. But before that, sir के लिए जरा 2 लाइन बोलना चाहूंगा. खोल दे पंख मेरे कहता है परिंदा, खोल दे पंख मेरे कहता है परिंदा, अभी और उड़ान बाकी है. जमीन नहीं है मंजिल मेरी, अभी पूरा आसमान बाकी है. चलता रहूंगा पथ पर, चलता रहूंगा पथ पर, चलने में माहिर बन जाऊंगा, या तो मंजिल मिल जाएगी या अच्छा मुसाफिर बन जाऊंगा।
क्या बात है, क्या बात है।
thank you very much, Dr. Uddhav Khilare, for those star liner. Namaste, my colleagues, dignitaries on the dais, of the dais. Everybody loves to address by his name. So I want to start my speech by addressing the names and not saying as sir. So first change, what I want to do is, respected chief guest, Dr. Bakul ji. No, sir. We will go to our Sanskrit ji and not sir, which is given by the British. So, Dr. Bakul ji, Dr. Basuraj, as already said, mitochondria, Bakul, visionary president, Dr. Jayant Upadhyay ji, Jain ji, and another Jain ji, Pandarikar, Sadachar, Vinayak, Jay, and Rajesh ji, as well as our president-elect 2022, Upendra ji. आणि source of inspiration, मोठा मोठा tower, Dr. शेखर जी. आणि समोर बसलेले बरेच नावं आहेत, सर्वांची नावं घेतली तर 75% तरी मला नावं घ्यावी लागतील. So I will just do my namaste and naman to all the dignitaries who are on the opposite side. खरं तर I do not know whether I deserve this post. I do not know. Actually, this event of Mahapedicon was the dream event of Shekhar ji in 2000 itself, when the blueprint was ready, and that was the first meeting of my as a IP Raigad, and that project is coming true today. आणि डॉक्टर शेखर मुळे आम्हाला हे करायला मिळालंय आणि आय थँक हिम. पण परत म्हणेन मी, दिस इज 11th hour डिसिजन. मला माहित होतं हे, मला गेल्या 8-10 दिवसात समजलं. Because another, I will tell it is an accidental MAHAIP president. माझ्या कारकिर्दीत जेव्हा पण असं वाटलं, मला 3 क्षण असे आले जेव्हा I became accidental president of Karjat Medical Association as a taluka level, accidental president of Raigad Medical Association, as well as 18 मार्च 2018 9 मार्च 11 मार्च 2018 आठवते जेव्हा आबासाहेब, who was the president of IP Raigad, I really didn't wanted to carry because I have passed those years. मला कधी IP Raigadचा president व्हायचं नव्हतं, पण आबासाहेब, because of some health issues, he requested and he said me कि नहीं हेमंत आपको ही करना है. तो मैंने बोला ठीक है करूँगा, मगर खाली IP Raigad president को. पर वो अभी 3 साल से ये हो गया. मुझे डर लगता है सुनीता मैडम और डॉक्टर चित्रा का कि वो 2 मिनट होंगे तो बोलेंगे, मुझे मालूम नहीं, इसलिए I will cut short. I speak very simple things. मुझे कुछ लाइना नहीं आती, कुछ शायरी नहीं आती, कुछ नहीं आती. But one thing I can tell, if I take some work, I will do to the best of that what I can do, and will be the best for the things. We have offered the bouquets to the dignitaries. They are made by the National Association of Blind School. So I will request all the dignitaries, please take this bouquet with them as the memories of Raigad Medical Association and the National School of the Blind, which is at Alibag. So please, and if somebody has given, we have enough of that bouquet, so we don't want it to circulate. So you just take care that they should be given to them. Actually, whenever I became 2 times the president, both of that time I had presented my plan for the year with dates, everything on my first day of installation when I became Raigad Medical Association President and Karjat Medical Association. But this time I'm very sorry and please excuse, I could not put that plan because it was at very short notice. I came to know this thing is I have given that responsibility. But this is the things which came in my mind over last 2 or 3 days. Saat Sutri Karyakram. 7 lines I would try to. I will go for academics. Yes, academics is the forefront. That is the basic of our association to come together. Second is administration should be very strong. If administration remains strong, then the organization flourishes. Third, activities. Activities not among ourselves, the activities in the society, which will increase our image and make us more closer to the public. And I think so there should be the partnership between public, pediatrician as well as government. So what was the thought by the Dr. Jayant Pandrikar sir? The Bal Swasth Abhiyan probably will continue that. The pending programs here are one, and another second, what are the pending programs are there? But we have to take the initiative in that. So that was the third. Fourth, of course, Mahapedicon conference, and probably that Nasik. So Nasik people will be going to the grand conference. So it should be the grand. Social activities is very important. And the most important two activities I always feel is very important for any association, update of our website, which is still not at the website, always the website. Membership drive, we should always increase our member. Still we have our the pediatricians who are not willing to become member. I don't know what is the reason, or we don't know what is the reason why they are not joining. So we have to tap that thing and decide accordingly. And last, charity commissioner update should be always there. I think so these 7 points always to be covered because we are always lagging on that front. Our association with the charity commission should be important. And lastly, I will take 1 minute more. We will try to move to do all the activities with our, this is a theme which was from Mahapedicon 2021, together towards tomorrow. And I think so that thing will also continue and work for in next year, I think so. And as a chief organizing chairman person, I would like to thank all the faculties, all delegates, DIP platform, our associate Medivision event manager, as well as all the delegates for helping out us to organize this wonderful. I think so it will be a wonderful conference. Hope so it will be the best. You will like the things. Some lacunae will be there, but then that please excuse us for that, and I am responsible for that. With that, if I with that I come to the conclusion of my words. आणि असं सांगताना आपण सर्वजण I am open to everyone. Whatever the branches give their suggestions, we will take that suggestion and work out on this. So let us move together towards tomorrow. And Jai Raigad IIP, Jai Maha IIP, Jai CIP, and Jai Hind. Thank you very much.
Thank you, sir. Now I would like to request Dr. Upendra sir to express his few words.
Namaskar, good evening. Respected chief guest for the function, my elder brother, Dr. Bakul Parekh sir, Dr. Basavaraj, our dynamic HSG, my dear friend, Dr. Jayant Upadhyay, the West Zone Vice President of CIP, President of Maha IIP, Dr. Jayant Pandrikar, Dr. Rajesh Boop, the Vice President, Dr. Hemant Gangolia, Dr. Shekhar Dabadkar, Dr. Vinayak, Dr. Sadachar, and all the dignitaries. Of course, we are blessed to have the presence of Dr. Raju Shah and all of you over here. नवलाख तळपती दीप विजेचे येथ उतरली जणू तारका दळे नगरात परिस्मरते आणिक व्याकुळ करते जेव्हा ती माझ घरातील मंद दिव्याची वात. कुसुमाग्रजांच्या या काव्यपंक्तीची आज आठवण येण्याचं कारण एकच की आकाशात तळपणाऱ्या त्या आकाशदीपाप्रमाणे तेजोमय भासणाऱ्या अखिल भारतीय बालरोग तज्ञ संघटनेच्या अध्यक्षपदी आपण सर्वांनी भरघोस पाठिंब्याने माझी निवड केली, त्याच्याबद्दल मनात आनंद होत असतानाच महाआयपीच्या प्रत्येक सदस्याच्या प्रेम, प्रोत्साहन आणि पाठिंब्याशिवाय हे केवळ अशक्य होतं याची मला पूर्णपणे जाणीव आहे आणि त्यामुळे तुम्हा सर्वांना मनापासून धन्यवाद. आपण महाराष्ट्रातली लोक जेव्हा एखादी राष्ट्रीय जबाबदारी स्वीकारतो तेव्हा एक गोष्ट मात्र प्रकर्षाने सगळेजण बाळतात, ते म्हणजे जेव्हा राष्ट्रीय जबाबदारीची झूल आपल्या खांद्यावर येते तेव्हा संकुचित प्रांतिक सीमा, जेव्हा एखादा पुरुष स्त्री हा भेद किंवा ग्रामीण शहरी हा भेद, कोणी गव्हर्नमेंट सर्व्हिस पब्लिक मध्ये की प्रायव्हेट सर्व्हिस मध्ये हा भेद, ही सगळी संकुचित आणि कृत्रिम बंधनं आपोआप गळून पडतात आणि आपण सर्वजण एका दिलाने, एका ध्येयाने केवळ आपले बाल मित्र आणि बालरोग तज्ञ यांच्यासाठी काहीतरी भरीव करण्याचा प्रयत्न करतो. आणि माझी खात्री आहे की ज्या पाठिंब्याच्या बळावर मी इथपर्यंत मजल मारली की ज्याद्वारे जे एक नवी मुंबईच्या कार्यकारिणी सदस्यापासून महाराष्ट्र आयपीच्या अध्यक्षपदापासून आयपी ट्रेझरर पदापासून आज राष्ट्रीय अध्यक्षपदी आपण सर्वांनी निवड केली, तेव्हा या जबाबदारीची पूर्णपणे जाणीव ठेवून मी तुम्हा सर्वांना पुन्हा एकदा विनंती करीन की तसंच तुमचं प्रेम, तसंच तुमचा पाठिंबा आणि तसंच प्रोत्साहन अखंड राहू द्या, ज्याद्वारे आपण काहीतरी आपल्या आधीच्या जणांनी, जसं डॉक्टर बकुल पारेख हे शेवटचे महाराष्ट्रातले आयपी प्रेसिडेंट, तिथपर्यंत सगळ्यांची दैदप्यमान कारकीर्द आपल्या समोर आहेच, तसंच काहीतरी करण्याचा प्रयत्न करूया आणि त्यासाठी तुमच्या पाठिंब्याची गरज आहे. एकच छोटंसं उदाहरण मी देऊ शकतो, कारण आता आपण ऑलरेडी उशीर होतोय, की एक स्टेट एज्युकेशन रिपोर्ट नुकताच जाहीर झाला. त्यामध्ये एक महत्वाची माहिती आली, ते म्हणजे प्रायव्हेट स्कूलमधनं पब्लिक स्कूल म्हणजे गव्हर्नमेंट स्कूलमध्ये the percentage has gone from 70% to 65%. In fact, गव्हर्नमेंट स्कूलचं पर्सेंटेज वाढलं आणि पब्लिक स्कूल, प्रायव्हेट स्कूल मधलं पर्सेंटेज कमी होतंय. हे एक वेळ एवढं काळजी करण्यासारखं नाही, कारण लोकांच्या फिया भरण्याची ताकद नाहीये. पण जवळपास 6% मुलांनी शाळा सोडली या कोविड काळामध्ये, आणि केवळ आई वडिलांना ते आपल्या कुटुंबाचा आर्थिक भार झोपण्यासाठी म्हणून शाळा सोडून त्यांच्याबरोबर कामाला लागलेत. त्यांचं काय होणार याचा विचार आपण केलाय? म्हणजे हा एकच किंवा दुसरा एक माझ्या परवा निदर्शनास आलं, ते म्हणजे चाइल्ड मॅरेजेस. इनफॅक्ट स्टेट लाईक केरला, हाऊ कॅन इट इन्क्रीज इन दिस टाइम? सो दिस आर द फ्यू मॅटर्स विच आय फील एक्स्ट्रीमली इम्पॉर्टंट. आणि आपण केवळ बालरोग याविषयी विचार करत नाही, आपण मगाशी मी म्हटल्याप्रमाणे सकाळी युनिसेफ सेशनमध्ये आपण त्याच्या पलीकडे जातो आणि चाइल्ड ॲज अ होल याचा विचार करतो. तेव्हा आपण हा सगळा होलिस्टिक विचार करून आय एम शुअर की तुमच्या सगळ्यांच्या प्रोत्साहनाने आणि तुम्ही सूचना द्यालच मला, एक काहीतरी चांगलं करण्याचं काम करूया, ज्याद्वारे आपली मुलं की जी 2 वर्षामध्ये जी बरीच वर्ष मागे गेली आहेत, त्या सगळ्यांना पुन्हा एकदा नव्या पाठिंब्याने, नव्या उभारीने ते परत फुलतील याविषयी माझ्या मनात अजिबात शंका नाही. तेव्हा पुन्हा एकदा मी तुम्हा सर्वांचं मनापूर्वक तुमचं कृतज्ञता व्यक्त करतो. रायगड आयपीने केलेल्या अभूतपूर्व कार्याबद्दल. इट वॉज नॉट इझी टू कंडक्ट अ कॉन्फरन्स इतक्या 60 दिवसात, जय म्हणाला तसं, कारण त्यांनी गेल्या वर्षी करायचा प्रयत्न केला तेव्हा झाली नाही, यावर्षी ती होतीये तरी त्याबद्दल तुमच्या सर्वांचं खरोखर एक सगळ्यांना कौतुकास पात्र आहे. रायगड आयपीची टीम, महाराष्ट्र आयपी डॉक्टर पांढरीकरांच्या नेतृत्वाखाली इतकं अप्रतिम काम केलंय, त्यांच्यासाठी एकदा जोरदार टाळ्या वाजवूया. आणि तुम्ही सगळे इतक्या संख्येने इथे आलात, मास्क काढून बसलात, याबद्दल आपल्या सगळ्यांना आता खात्री आहे की थर्ड वेव्ह जवळपास गेलेली आहे. लेट्स कीप अवर फिंगर्स क्रॉस्ड अँड वर्क टुगेदर. थँक्यू सो मच.
Thank you. Now may I request our chief guest, visionary past Central IIP President Bakulji Parekh, to share his thoughts.
Dignitaries on the dais and of the dais. Let me tell you that I will not like to take name of everybody for 2 reasons. One, because we are short of time, and 2, if I have to take name, I have to take name of everybody. So all of you are all my dignitaries. Definitely, as a protocol, I will take name of Chairman of the conference and Vice President of Central IIP, Dr. Jayant Upadhyay, my dear friend. The President-elect 2022, Dr. Upendra Kinjrekar, my younger brother. President MahaIAP, Dr. Jayant Pandrikar. Secretary MahaIAP, Dr. Sadachar. my rock-like support in Central IIP, and as you all call him, mitochondria, Dr. G.V. Basavaraj, and so many other friends, like now incoming president of Maharashtra IIP, Dr. Hemant Gangolia, and the Nari Shakti of Raigad, Sunita Ingle, and Nilima, and all the ladies. I think that is unique. I think one of the unique branch where everybody is a woman, the Nari Shakti. And of course, all of you, my guest from Gujarat, Dr. Raju Bhai and Abhay Shah, and my younger brother and dear friend, Dr. Samir Dalwai, my elder sister, Dr. Purna Kurukure, and all, Vasant Khalatkar, who has been now recently elected as ID chapter president, Jayant Joshi, and so on. If I start taking names, I think it will never end. Mahesh Mohite, I should definitely refer to. And of course, there is one person who always says that I don't know why everybody loves me so much, Dr. Dabadkar. I also love him. Yeah. So first of all, when I was told to be a chief guest today, I was really surprised because I'm one of you. I'm one of you, by you, and for you. I'm in a family. In a family, there is no chief guest. So I'm one of you, and I'm just finishing the formalities which has to be done. That's why I'm here. Regarding this conference, I am sure everybody is enjoying, and it has come to a very good venue. And any conference can be successful when the venue is fantastic, and of course science. The program which I saw, Dr. Mahesh Mohite has taken really tremendous pains in selecting the topics and the speakers, and it was supported by the scientific committee. I think chair of the scientific committee, Dr. Jayant Upadhyay, and all others in this committee has taken a great job. And I'm sure all these topics are going to be spoken by all the galaxy and the stars in the IAPNs. And being a hybrid conference, I'm sure, though physically we are only 200 or 250, but there are 20,000 others who are watching us on the platform, that is the IP platform. Regarding this conference, I like to say that there were lots of turmoils going on since last 2 years, but I'll just try to describe in एक वाक्य से कि नजरें बदलो तो नजरिया बदल जाते हैं, नजरें बदलो तो नजरिया बदल जाता है, सोच बदलो तो सितारे बदल जाते हैं, लेकिन कश्तियां बदलने की जरूरत नहीं है, दिशाएं बदलो तो किनारे मिल जाते हैं. And I think that has led to this Mahapedicon getting converted into West Zone Pedicon. And that's how this is now, West Zone Pedicon along with Mahapedicon. And as all of you know, that any zonal pedicon is consisting of all the states in the zone. So this is Maharashtra state, Gujarat state, and Goa state. And all these three states have been doing great job in last 2 years since the time I'm observing. Even during COVID times, they have done a great activities. And I appreciate that. And I think we should clap for all the three states. Then regarding this particular conference, I think we have gone through all the details and known from all the previous speakers, so I don't have to say much about it. But at the same time, I will like to say that let our Mahapedicon continue the way we are doing every year. It's been a very, very important annual conference of Maharashtra state. And of course, West Zone is always equally important. But being a Mahapedicon, I will say that let's continue the trend every year. And I'm sure Nasik will do a great job in the coming year. I will like to congratulate both the incoming presidents, that is Dr. Upendra Kinjwadekar for his tenure in the coming years, and we are all with you, like what you have expected our support, and you take it for granted that we are always with you. And of course, Dr. Hemant Gangalia, though he feels that he is an accidental president, but I'm sure he'll be a very successful president, knowing his sincerity and honesty. And we are in for अच्छे दिन आ रहे हैं. And I'm sure if there is a teamwork, anything can be achieved. And I'm seeing that great teamwork in Maharashtra, looking at the past election, which we have seen in Central IP, where everybody in Maharashtra was united for our Upendra Kinjwadekar. And I think that has supported him. And I must thank Dr. Amol Pawar. He had taken a great initiative along with all the EB members who were contesting. And I've personally seen every meeting, in 1 or 2 meetings I was there, and the way they were communicating was excellent. So I'm sure that Maharashtra is in for a very big unified state. Dr. Hemant Joshi was, when he had contested, he was telling me that anybody can win if we have enough number of members. Number game is important. So we have to have many more members who are the pediatricians who are not yet members, we should all work hard to make them members and increase our strength from 4,000 to 6,000. And I'm sure that will make us unbeatable. So I think everybody should take up, one should bring 10 more, and let's do very sincerely in next 3 months so that it will help us. With these few words, I will wish all the best. Enjoy the academics, enjoy the cultural programs, enjoy the hospitality of Raigad branch. I'm sure all of us are enjoying already. Thank you very much. Good night.
Thank you very much, sir. Now I will hand over further proceeding, respected Dr. Sadachar Ujignikar sir, to carry out the award function.
I'm again here for our most awaited function, that is distribution of awards for all the district branches of the state. But before that, we have a small honor we need to do on behalf of MAHAIP to these 4 stalwarts that I will quickly take the name of them, and those who are present can come forward. And please, I will request President Dr. Jayant Pandrikar sir, Maharashtra State IIP, to read this small honor. First name is Dr. Satish Dev Pujari from Nagpur. We are giving them the letter of honor on behalf of Maharashtra IIP. And we will publish these letters on the MAHAIP website, so you can go through that. Because lack of time, we will just hand over this letter of honor. I request Dr. Jayant sir to please hand over, felicitate, hand over this thing.
Who has discovered this Pran Setu O2, which is non-invasive ventilator. So it's a really big achievement for us as a pediatrician, MAHAIPians. We believe in Atmanirbhar Bharat and Make in India, and he has made it at a very low cost. So I hand over this letter of appreciation to Dr. Satish Dev Pujari. I request Dr. Anand Butrada, Dr. Sanjay Deshmukh to accept it because he's a part of that team.
Yes, the second is Dr. I request Jayant Pandrikar to felicitate Dr. Hemant Joshi sir. Please, I request Dr. Hemant Joshi sir to come forward. Okay. Yes. Dr. Satish Agrawal sir. I request Dr. Satish Agrawal sir to come forward. सन्माननीय डॉक्टर सतीश अग्रवाल हे अमरावतीतच नव्हे तर संपूर्ण विदर्भात अत्यंत सुपरिचित असे नाव आहे. गेली 25 वर्ष अत्यंत धडाडीने व मनापासून रुग्णांची सेवा केल्याबद्दल महाराष्ट्राच्या दूरवर त्यांचे नाव आहे. पेशंटची अत्यंत नम्रपणे आणि गोड बोलून त्यांच्यावर उपचार करणे यासाठी डॉक्टर अग्रवाल सर्व जनतेत सुप्रसिद्ध आहेत. या व्यतिरिक्त ते अनेक माध्यमाद्वारे समाजाची सेवा करत आहेत. आपण मातीतून आलो आहोत आणि या मातीशीच आपले संबंध असून आपण जीवनात सामान्य लोकांसाठी रुग्णसेवा अत्यंत मनपूर्वक कळकळीने करीत आहात. अत्यंत गरीब मुलांच्या शिक्षणावर खर्च करणे, तसेच या मुलांना वेगवेगळ्या प्रकारचे जीवनाला उपयोगी पडणारे प्रशिक्षण देणे, त्यांना त्यांच्या लैंगिक समस्यांबद्दल माहिती व ट्रेनिंग देणे, तसेच पौगंडावस्थेतील मुलींच्या वर्तणुकीबाबतच्या समस्यांसाठी त्यांनी अनेक शिबिरे आयोजित करून समस्या यशस्वीपणे सोडवल्या आहेत. पुढील काळातही आपण करत असलेले समाज कार्य हरिरीने पुढे चालू ठेवावे, ज्यामुळे समाजातील जनतेला याही पुढे आपल्या कार्याचा फायदा मिळत राहील. अशी शुभेच्छा IAP महाराष्ट्राच्या सर्व सभासदांद्वारे आम्ही देत आहोत. सेंट्रल IAPने त्यांना त्यांच्या कर्तृत्वाची दखल घेत नुकताच FIAP हा सन्मान प्रदान केलेला आहे. त्याबद्दलही महाराष्ट्र IAP त्यांचे अभिनंदन करीत आहे. तसेच अनेक हजारापेक्षाही अनेक 1000 पेक्षा अनेक लेख त्यांनी अनेक ठिकाणी लिहिलेले आहेत. तसेच पुस्तकही प्रकाशित केले आहे. डॉक्टर सतीश अग्रवाल, कृपया आपले अभिनंदन स्वीकार करावे. डॉक्टर जोशी सर, हेमंत जोशी सर आणि डॉक्टर अर्चना जोशी मॅडम. आपण उत्तम बालरोग तज्ञ म्हणून व्यवसाय करत असतानाच सामाजिक बांधिलकी जपणारे महाराष्ट्रातले सुपरिचित आगळे वेगळे व्यक्तिमत्व असणारे जोडपं डॉक्टर जोशी दाम्पत्याचा केवळ एकच विचार आपल्या ज्ञानाने समाज प्रबोधन करणे, मुले, त्यांचे पालक, आजी आजोबा या साऱ्यांना आरोग्य साक्षर करण्यासाठी 1991 पासून आरोग्य ज्ञानेश्वरी दिवाळी अंक गेली 26 वर्षे ते अविरतपणे प्रकाशित करीत आहेत. शाळा, महाविद्यालय, वाचनालय, पत्रकार यांना हा अंक मोफत दिला जातो. WHO पीडियाट्रिक्स बुक सरांनी मराठीत भाषांतरित केले आहे. ते WHO वेबसाईटवर उपलब्ध आहे. त्यांची 12 भाषात बालसंगोपन पुस्तके आहेत. इतकंच नाही तर www.drhag.com येथून सारी पुस्तके मोफत डाउनलोड करता येतात. प्रतिबंधात्मक लसीकरण सार्वत्रिक व्हावे म्हणून मेक नेशन वॅक्सिनेशनची घोषणा सरांनी दिली. जोशी सरांच्या नावे एक पेटंटही आहे. इंडिया पीडियाट्रिक्स व इतरत्र 7 पेपर्स प्रसिद्ध झालेले आहेत. त्यावर आपले नाव अशा आगळ्या वेगळ्या पण वेगळ्या समाजाच्या उत्तम आरोग्याच्या एक कलमी कार्यक्रम आयुष्यभर राबवणाऱ्या ध्येय वेड्या दाम्पत्यास बालरोग तज्ञ संघटना मानाचा मुजरा देत आहे. पुढचं
ऐका ना, या मासिकाने तुमची प्रॅक्टिस वाढेल. प्रत्येकाच्या बॅग मध्ये एक टाकले आहेत, पण मी अजून 700 आणले आहेत. तुम्ही तुमच्या फ्रेंड्ससाठी बॅग घेताना घ्या. थँक्यू. थँक्यू. थँक्यू.
चौथं आपल्या सर्वांच्याच हृदयातलं नाव डॉक्टर चंद्रशेखर दाभाडकर सर. सन्माननीय डॉक्टर चंद्रशेखर दाभाडकर, आजच्या या राज्यस्तरीय बालरोग तज्ञांच्या अधिवेशनादरम्यान आपणास हे सन्मानपत्र देताना आम्हा सर्वांना आनंद होत आहे. आपला जन्म, वैद्यकीय शिक्षण जरी मराठवाड्यामधली असले तरी आपली कर्तृत्वभूमी मुख्यतः कोकण आहे. तरी ती तेवढीच सीमित न ठेवता आपण प्रथमच चला मुलांना घडवूया यामधून संपूर्ण महाराष्ट्र व नंतर सर्वत्र भारत देश पादाक्रांत केलात याचे आम्ही साक्षीदार आहोत. राष्ट्रीय पातळीवर FIAP ही उपाधी सरांना मिळालेली आहे. राज्य पातळीवर इंडियन मेडिकल असोसिएशन लोकशिक्षणाकरता डॉक्टर नाडकर्णी पुरस्कार सरांना मिळालेला आहे. जिल्हा पातळीवर धन्वंतरी पुरस्कार, निर्भीड गौरव पुरस्कार, अनेक वर्ष सातत्याने राष्ट्रीय व राज्य अधिवेशनात व्याख्याते म्हणून ते आमंत्रित आहेत. तसेच 2 वर्षे महाराष्ट्रातून बहुमताने सेंट्रल IAP वर निवडून आलेले आहेत. Yes. धन्यवाद.
So dignitaries and friends, I am really overwhelmed. I was not expecting. काल मी पांढरेकरांना चिडलो, बाजूला जाऊन काहीतरी ते प्लॅन करत होते, काय चालू होतं काय नाही. अरे म्हणलं मग कन्व्हेनर आहे, मला तर काहीतरी कळू द्या. पण पांढरेकर साहेब तुमचा प्लॅन मला आता कळला. आय एम रिअली थँक्यू टू यू अँड यू ऑल. थँक्यू व्हेरी मच. थँक्यू.
सर्व मान्यवरांचे अतिशय आभार. त्यांनी आमच्या महाआयपी कडनं हा सत्कार स्वीकार केल्याबद्दल. तर परत एकदा मी अवॉर्ड सेरेमनीकडे येतो. आपण कॅटेगरी नंबर ऑफ मेंबर वाईज कॅटेगरी वाईज आपण सुरू करूया. लेस दॅन 50 आपण हा जो कॅटेगरी आहे त्याच्यामधलं विनर ब्रांच जी बेस्ट ब्रांच आहे ती आहे यवतमाळ, आणि ब्रेस्ट फीडिंग वीक मधली विनर आहे यवतमाळ, आणि तसेच ORS वीक मध्ये विनर आहे यवतमाळ ब्रांच. कोणी यवतमाळ ब्रांच कडनं आहे का? विदर्भ प्रतिनिधी डॉक्टर then आवड पुढची ब्रांच उस्मानाबाद आहे. उस्मानाबादहून कोणी आलेलं आहे का? उस्मानाबाद, परभणी नाही. सेकंड रनर अप बेस्ट ब्रांच उस्मानाबाद, फर्स्ट रनर अप बेस्ट ब्रांच आणि फर्स्ट रनर अप इन बोथ ब्रेस्ट फीडिंग वीक एज वेल एज ORS वीक उस्मानाबाद. त्यांचे कोणी प्रतिनिधी इथे नाही आहेत पण तरी आपण हे करू. सेकंड रनर अप त्यांना हँड ओव्हर करू. देऊन टाकू. परभणी, परभणीचे कोणी असेल तर गणेश कुलकर्णी दोघांची स्वीकार करतील. सागर कुलकर्णी, सॉरी सागर कुलकर्णी. I am extremely sorry. Name change. Usmanabad and Parbani. Next category 50 to 150. The base branch winner is of course none other than Raigad in base branch, and also the base feeding week the winner, first runner up, and in ORS week again the winner Raigad branch. घर आपल्या घरी सत्कार होत आहे. घरचा आहेर नाहीये, घरचं आपल्या घरी सत्कार होत आहे. महा-IAP आपल्या घरी येऊन आपला सत्कार करत आहे. महा-IAP आपल्या दाराशी महा-IAP आलेली आहे आपला सत्कार करण्यासाठी. मी पण खाली येतो काम. First runner up in this for the base branch category in 50 to 150 Kolhapur. I request representative from Kolhapur's of OBs from Kolhapur's to come forward to receive this award. Kolhapur has won first runner up in base branch and second runner up in BF base feeding World Base Feeding Week and ORS week. Kolhapur team. Next winner is Amravati Best Branch Award, second runner-up Best Branch Award, and the winner of Breastfeeding World Breastfeeding Week, and the first runner-up of ORS Week. Amravati team. Please have a grand round of applause. Second, there's Amravati won the second runner-up in base branch. Next in this category, Solapur has sent all the activities. We have given that branch the appreciation award. Anybody from Solapur? Yes, please. They have reported the activities well, but there were 4 contestants in this category, so they have received the appreciation award in this category for all the base branch, breastfeeding week, ORS week. Next category is one. I request Dr. Hemant Gangulia sir also to join Dr. Jayant Pandrikar sir in felicitating the branches. Next category is 150 to 300. That's winner of this base branch award is Navi Mumbai, and they have also won the ORS week, and first runner-up is BF week.
Really, Navi Mumbai is really great branch. Please give a big round of applause to Navi Mumbai. They have done excellent activities throughout year 2020 and 2021. Dr. Jitu Gai Gawane and Dr. Shahane ji, please.
Navi Mumbai, yes. Most vibrant branch. ऊपर वाले ने कितने भी दिए तो भी अपने हाथ भी उतने मजबूत चाहिए वो झेलने के लिए, और वो नवी मुंबई है। तो नवी मुंबई, then I request the first runner-up in this category in base branch, Nashik. I invite Nashik people who has yes. Nashik has won the first runner-up in base branch and he's the winner in World Breastfeeding Week, and he is a second runner-up in ORS Week. The winner of World Breastfeeding Week also. Next winner in base branch in this category is Aurangabad in base branch, and they are first runner-up in ORS week and second runner-up in World Breastfeeding Week. Aurangabad team, please. Have a grand round of applause for all the winners. They have reported. Actually, in IAP, there is we have to categorize first, second, third, but those who have done the activities are all the winners. Aurangabad team, please come forward. Aurangabad, members from the Aurangabad. And next category is more than 300, and winner is Pune branch. They are winner in all the three categories: World Breastfeeding Week, ORS Week. They have done exceptional work this year, all around the year. Dr. Sanjay Nathu, the president, and Dr. Pramod Kulkarni sir from Pune. Have a grand round of applause for Pune. They are all rounders. All rounder performance from Pune. Great. Then the first runner up in base branch is Nagpur, and ORS week first runner up, and the BF week also second runner up. So Nagpur branch first runner up base branch award. Then the second runner up in this category, Mumbai. सर्वांची ताई मुंबई, महाराष्ट्राची ताई मुंबई. They have won the first runner-up award in World Breastfeeding Week, and second runner-up in ORS Week, and in Mumbai Base Branch Award also. All people from Mumbai, Sadavarte sir, please come up. Samir sir, please come up. Samir sir. Samir sir. Samir sir. Samir. Please come here. We have got the award from Mumbai branch. Please. Your presence is earnestly awaited. Yes, sir, sir. Yes, sir. Sir, यहाँ से also. Other thing, one special award we are announcing this year. Congrats, Mumbai. One special award this year we have announced regarding the Charity Day Award, and that is being won by Kolhapur. Kolhapur people are here. They are left. Kolhapur. They have left, I suppose. And the runner-up in this is Navi Mumbai. Yes. In Charity Day Award. If anybody can call Dr. Deepa Firke ma'am or yes. Congrats Navi Mumbai for winning the runner-up award in Charity Day. And I request Naniwadekar sir to receive the winner award in Charity Day activity. So have a grand round of applause for charitable work done by Kolhapur. Congrats Kolhapur for such exceptional work in Charity Day awards category. Thank you for patient listening, patient presence. I request MOC to take charge and publish the next.
थँक्यू व्हेरी मच. आणि कार्यक्रमाच्या पूर्णत्वाकडे आपण पोहोचलो आहोत. आय रिक्वेस्ट डॉक्टर विनायक पाटील टू गिव्ह वोट ऑफ थँक्स.
Good evening to all the dignitaries on stage, my friends and colleagues. As we come to end of this inauguration, it's my privilege to propose a vote of thanks. I know all of you are, I am just in between you and Bankway, but it's a protocol, so I have to do that. It's my privilege to propose a vote of thanks and acknowledge the contribution of those who worked hard to make this conference a success. Before I begin, I would like to congratulate my friend Dr. Gangolia for becoming the Maha-IAP president. It's an honor for Raigad IAP basically. On behalf of Raigad IAP, I extend a really hearty vote of thanks to our chief guest, Dr. Bakul Parekh sir, who is always a backbone behind us. He has guided us throughout this journey of planning the event. I am thankful to Dr. Upendra Kinjavdekar sir, President-elect, Dr. Basavaraj sir, HFG, for coming all the way to this small place and gracing the event. I take immense pleasure in extending my sincere thanks to Jayant Upadhyay sir. He was instrumental in getting us that UNICEF fund. So we are thankful to Upadhyay sir. I extend my heartfelt thanks to Dr. Jayant Pandharikar sir, President Maha-IAP, who has been helpful us throughout the whole year and making this event a grand success. He was instrumental in getting us that Maha-IAP fund for our conference. Thanks for that. My heartfelt thanks to all the other dignitaries on the stage. A special mention to our mentor, Dr. Dhabadkar sir, who inspired us to do our best and stand as a pillar. With a deep sense of appreciation, we thank all the organizing team for their untiring efforts. I also want to thank all those who worked behind the scene, especially Medivision events and Prakriti resorts. And finally, I would like to thank all the delegates without whom this conference has no charm. Thank you.
I request all the dignitaries to conclude this with the national anthem. Actually, that is a protocol.
Please stand in attention for national anthem.
Janagana mana adhinayak jaya he Bharat bhagya vidata Jab Sindh Gujarat Maratha Dravida Utkala Banga Vindhya Himachala Yamuna Ganga Uchala Jaladhi Taranga Tava Shubha Ashish भारत माता की
Thank you everybody.
परफॉर्म आफ्टर 10 मिनिट्स. पण बरेच जण डिमांड करतात तुम्हारा गाना कब आएगा, तो लो मेलो मेरा गाना आ गया. आपके लिए लवली लेडीज आर देयर, दिस सॉन्ग फॉर देम. आणि पांडेकर सरांना बघतो की त्यांनी मला डान्स मूव्ह जरा दाखवायची या गाण्यावर. आणि या गाण्यामध्ये कोरस आहे, हिची बॅटरी 22% झालेली आहे. मला माहित नाही, ठीक आहे, हे एवढं गाणं तर नक्कीच होईल. नंतर मी लाईव्ह वर जाईल. ओके. त्याच्यावर कोरस आहे, तुम्हाला कोरस घ्यायचं आहे. साऊंड मस्त साऊंड द्या गाण्याला. Yes, are you ready, boys? Sunila madam, please stay over, please. खाली ना तुम्ही. सारा जमाना हसीनों का दीवाना, हसीनों का दीवाना. जमाना कहे फिर क्यों बुरा है दिल लगाना. ए सारा जमाना हसीनों का दीवाना. जमाना कहे फिर क्यों बुरा है दिल लगाना. ए सारा जमाना ये कौन कह रहा है तू आज प्यार कर ले, जो कभी भी खत्म ना हो ओ एक बार कर ले. मान ले मेरी बात, सारा जमाना हसीना दीवाना. जमाना कहे फिर क्यों बुरा है दिल लगाना. ए सारा जमाना जब होश नहीं तो दुनिया में क्या कशिश है. दिल वही है जिसमें कहीं प्यार की खलिश है. मान ले मेरी बात, सारा जमाना हसीनों का दीवाना. जमाना करे फिर क्यों बुरा है दिल लगाना. ए सारा जमाना ला 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 ला. सारा जमाना
या दमदार परफॉर्मन्स नंतर आपण आपला गोंधळ हा कार्यक्रम घेणार आहोत आणि जय भंडारकरांना आपण बराच वेळ देणार आहोत. आपण बराच वेळ देणार आहोत.
रेडी
गोंधळचे पार्टिसिपंट रेडी आहेत का?
वेळ आहे.
गोंधळ की वेळ आहे? समीर रेडी?
रेडी तर हलतो नाही तर मी कंटिन्यू. स्टेज शुड बी नॉट.
समीर
थांबायला नाही पाहिजे स्टेज.
येस रेडी रेडी रेडी.
अरे रेडी
रेडी.
ओके प्लीज. काढावं लागेल कॉर्ड. कॉर्ड काढायची का? येस.
वातावरण निर्मिती झाली
वातावरण निर्मिती झाली आहे. नंतर तुफान ऑर्केस्ट्रा आहे.
महाराष्ट्रात गोंधळ
नाव दिस इज द
लोकप्रतिकार
परफॉर्मन्स गोंधळ. थँक्यू.
लोकप्रतिकाराला धार्मिक दृष्टीने खूप महत्व आहे आणि कुलदैवतेला प्रसन्न करण्यासाठी कुळाचार म्हणून गोंधळ घालण्याची आपल्या महाराष्ट्रात प्रथा आहे. पूर्वी राजकीय आक्रमणांविरुद्ध समाजात वातावरण निर्मिती म्हणूनही गोंधळ घातला जात असे. तर स्वागत करूयात गोंधळाचं. स्टार्ट.
जोगवा. Samir, go to him, explain him. Samir, just go to him. आता समीर रेडी? ये कोळी घेऊयात.
ओके. ट्रॅक इज नॉट देअर. विच इज द नेक्स्ट? येतो परत. येस वी आर मुव्हिंग अहेड. तर आता मला ते ऑर्केस्ट्रा द्यायचं का डायरेक्ट? मग थोड्या वेळाने घ्या. ओके वी आर मुव्हिंग अहेड and I'm calling the orchestra stream on the stage for the beautiful singing. बोलो दाना चालेल चालू करू आपण. Yes, is a from New Bombay. My friend Santosh Gaikwad and team. Please give a round of applause. आणि तुमचे काहीतरी त्यांना मी डायरेक्ट डान्स गाणे घ्यायला सांगितले. त्याला आत्ताच 10 वाजलेले आहेत. 10:30 लिमिटेशन असतं. आय रेडी मॅडम? संतोष, वैभवी, प्रियांका, नरेश आणि दीपक ऑल शुड बी ऑन द स्टेज. आता हा टेस्ट तुम्हाला गाजवायचा आहे. मी थोडा बाजूला नंतर जॉईन होईल. थँक्यू. ऑल द बेस्ट. प्लीज. आता ज्यांना डान्स यूज करायचे प्लीज द बॅक बेंचर पण म्हणूयात. मला वाटतं तुम्ही तयार राहायला पाहिजे. आता जसे गाणी चालू होतील तुझे पाय थिरकणं फार गरजेचं आहे. येस संतोषजी, आर यू रेडी? आय हिअर आय प्रेझेंट द बँड टीम ऑन द स्टेज. Shake. Hello, shake. Hello.
Hello, one song is ready. Go on. Yes. Professional performance, कोकण ची परंपरा आणि महाराष्ट्राची लोक. Please. Sam, ready? Yes. Now that's called professional performance. मित्र प्रोफेशनल परफॉर्मन्स म्हणजे काय असतो हे यांनी दाखवून दिला. माझ्या बाजूने एक स्मॉल रिक्वेस्ट आहे. उद्या IIPच्या DIP प्लॅटफॉर्मवर इवलीची इच्छा हा आम्ही बनवलेला प्रोडक्शन बनवलेला मूवी आम्ही करत आहोत. तुम्ही जर कोणी लॉग इन झाला तर दुपार संध्याकाळी नंतर ही फिल्म दाखवली जाणार आहे. फक्त 25 मिनिटाची शॉर्ट फिल्म आहे. माझे बरेचसे प्रोजेक्ट माझ्या युट्यूब चॅनलवर असतात. डॉक्टर राजेंद्र चांदोरकर हे युट्यूब चॅनल तुम्ही सबस्क्राईब करा. माझी तुम्हाला रिक्वेस्ट आहे, माझे प्रोजेक्ट तुम्हाला आवडले तर तुम्ही शेअर करा. माझ्या वाईफ बरोबर गायलेलं हमसफर हे गाणं खूप छान आहे आणि माझ्या मुलीसाठी गायन हे गाणं आहे. Thank you.
All the best, Rajendra. Dr. Ravi Mahapedicon from Nashik. And she is going to sing one melody. Vaikari, eyes ready? The live performance by her. आपल्यातील तरुण कलाकार आहे. Round of applause, please. वैखरी हिअर, वैखरी सुनावणे. ते गेल्या वेळेस पेढी उत्सवामध्ये पण गाणं गायलं होतं. थँक्यू. ऑल द बेस्ट.
कुछ तेरा ये
What a performance, off-hand performance, big applause. And friends, only 2 songs left from कोकण की परंपरा आणि महाराष्ट्राची लोकधारा. या कोकणच्या परंपरेमध्ये समीर म्हणून आमचे एक मित्र आहेत, त्यांनी खूप मदत केलेली आहे. डॉक्टर प्रणाली यांच्याकडून स्पेशल थँक्स. कोळी गीत, कोकणची परंपरा. महाराष्ट्राच्या लोकधारेला कोकणचा तडका कोळी गीत घेऊन येत आहेत अमित घरत यांची टीम रिदम आर्ट्स इन्स्टिट्यूट यांच्या सहकार्याने. सॅम कोळी गीताच्या नाचाला समोर या तुम्ही सगळ्यांनी यायलाच पाहिजे. डॉक्टर जयंत सगळ्या टीमला पुढे घेऊन थँक्यू. कोकण के रंग IIT रायगड के संग. आणि जे आम्ही तुम्हाला प्रॉमिस केलं होतं ते आम्ही तुमच्या समोर सादर केलं मित्रो. महाराष्ट्राची लोकधारा यापैकी जाणता राजा शिवाजी महाराजांशी संबंधित एक अगदी शॉर्ट गाणं आहे आणि जे 2 मिनिटात आम्ही आपल्याकडे सादर करणार आहोत. पण तत्पूर्वी बॅकस्टेज आर्टिस्ट रेडी आहेत, त्यांना मी विनंती करतो एका तुझं गाणं प्लीज. येस, टेक 1 or 2 songs प्लीज.
Hello. कुणाला
मी हाय कोली सोरीला डोली मुंबईच्या किनारी मारतील कोली हाणले निघून का चल जाऊ बाजारी
मी हाय कोली कोलीला डोली मुंबईच्या किनारी आली हंडा डोली चल जाऊ बाजारी
वेसोच्या बाजारी लोकांच्या नंदरा करतील ग तुझ्यावरी कल्ला ग पारू करते नकरा चल जाऊ बाजारी तुझ्यावरी कल्ला ग पारू चल जाऊ बाजारी चल गो पारू आई चल बाजारची तयारी मावळ्याची टोपली माथ्यावर घेऊ इकूचा बाजारी मी हाय कोली सोरीला डोली मुंबईच्या किनारी मारतील कोली हाणला डोली चल जाऊ बाजारी सरगाने हलवा ताजा है मावरा बारूच्या पाल्यावरी ठिकाणी पाला काटेरी मावर दिसतय सोनेरी सरगाने हलवा ताजा है मावरा बारूच्या पाल्यावरी ठिकाणी पाला काटेरी मावर दिसतय सोनेरी दादा ताजा है मावरा बारूच्या पाल्यावरी बलियो ना तुमा दर्याची हंत मावरा सोनेरी मी हाय कोली सोरीला डोली मुंबईच्या किनारी आरती कोली हाणले डोली चल जाऊ बाजारी तू डोंगरावरी नजर हाय तुझी कोल्यावरी एक विराई तू डोंगरावरी नजर हाय तुझी कोल्यावरी धंदा जीवा उधारी पाठीशी उभी आहे एक विराई पाठीशी उभी आहे एक विराई एक विराई तू डोंगरावरी नजर हाय तुझी कोल्यावरी एक विराई तू डोंगरावरी नजर हाय तुझी कोल्यावरी प्रेम वेळीला या प्रेम वेळीला या प्रेम वेळीला या प्रेम वेळीला दर्शन लागली कानावर आली आणि अंगात भरले वार ही फिरतेची बाधा झाली हे उन्हात होते दर्शन लागली कानावर आली आणि अंगात भरले वार ही फिरतेची बाधा झाली आता अधीर झालो या मग बधीर झालो या आणि तुझ्यासाठी बनून मजलो मागे आलो या काय उडतंय बघत पडतंय चिकट रंगात आलो या झालो गुडगा भाषी गवाडल तुझ्या नावाचं मी निशाण टॅटून गोंधळ आता उत्साहीन झालो गुडगा भाषी गवाडल तुझ्या नावाचं मी निशाण टॅटून गोंधळ असं भरून आलो या आता भरून आलो या जुळून आलो या करून साडी बारी परफ्यूम मारून आलो या हे संध्या परत म्याला जोरात रंगात आलं या झालं डिंग 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 झालं डिंग 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 डिंगाट डिंग 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 डिंगाट डिंग 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 डिंगाट डिंग 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 आता उतावीळ झालं गुडघ्या पाठी ग बांधलं तुझ्या नावाचं ग मी विषय त्यातून गोंधळ आता उतावीळ झालं गुडघ्या पाठी ग बांधलं तुझ्या नावाचं ग विषय त्यातून गोंधळ आलो या आता भरून आलो या तुझ्या घरून आलो या दारी भारी पट्टी मारून आलो या आलो या क्या बात है IIP के रंग IIP महाराष्ट्र के संघ थँक्यू व्हेरी मच मित्र हो यानंतर एक असा जोरात परफॉर्मन्स होणार आहे पण तत्पूर्वी महाराष्ट्राचे लोक छत्रपती शिवाजी महाराज आपल्या महाराष्ट्राचे आणि कोकणाचे आराध्य दैवत एकच मिनिटाचा परफॉर्मन्स आहे फक्त तुम्ही नक्की जरूर तुम्हाला आवडेल तो झाल्यानंतर पुन्हा एकदा झिंगाट होईल येस छत्रपती शिवाजी महाराज सॅम रेडी येस सर्वांनी मागे बघा सर्वांनी मागे बघा स्पेशल परफॉर्मन्स बाय शांता राजा आणि महाराष्ट्राचे योगदान आहे आणि आमच्या रायगड आयोगाच्या आज खरंच 5 वर्ष कार्यक्रम झालेला आहे. अमित कराड यांचं स्वागत करा. शांता राजा छत्रपती शिवाजी महाराज बोला. शिवाजी महाराज की, शिवाजी महाराज की, शिवाजी महाराज की. छत्रपती शिवाजी महाराज यांचा, छत्रपती शिवाजी महाराज यांचा. आज IIT रायगड सगळ्यांची मदत दिलेली आहे. डॉक्टर हेमंत गंगोलिया द ऑर्गनायझिंग चेअरपर्सन, डॉक्टर जय भंडारकर अगेन द ऑर्गनायझिंग चेअरपर्सन, डॉक्टर विनायक पाटील चीफ ऑर्गनायझिंग सेक्रेटरी आणि आमच्या प्रेसिडेंट मॅडम डॉक्टर सुनीता इंगळे, कन्व्हेनर डॉक्टर चंद्रशेखर दाभाडकर, सायंटिफिक चेअरमन डॉक्टर महेश मोहिते, सगळ्यांनी IIT महाराष्ट्राची मनं जिंकलेली आहेत. जोरदार टाळ्या होऊ द्या देतात.
आर यू रेडी फॉर फोक डान्स? हे डान्स करायचा आहे, जोडी पाहिजे जोडी. ही गोमू आहे, तिच्या संगतीनं नाचायचं आहे. प्लीज संतोष. कोणी गीत आहे? हेमंत कुमारजी आणि कुणी गायले? आशा भोसले. प्लीज आय एम सिंगिंग फॉर यू. या गोमू आहे, चित्रा मॅडम, सुनीता मॅडम आणि नवी मुंबई. सगळे इकडे या प्लीज. आणि इकडे इकडे या रे. काशीनाथ घाणेकर व्हायचे तुम्हाला. अरे रेडी काशीनाथ घाणेकरचे गाणं आठवले का? ओके. गो संगती. अरे रेडी. अरे आपली गोमू हुडका रे. येस, हेमंतजी गोमू आणि पांढरीकरजी हे काशीनाथ घाणेकर होत आहेत. येस, आर यू रेडी फॉर द डान्स पोज? ओके. म्युझिक प्लीज. संतोषजी. मी वैभवी सोबत जातोय. आर यू प्लीज. हे प्रॉपर कोळी गाणं आहे. स्लो भारत 50 वर्षा जुनीचं छान बीट आहे गाण्याचं. प्लीज. आर यू रेडी गाईज? 1 2 3. हाय रेडी. चालू ना जा. संगतीनं माझ्या तू येशील काय? गोम संगतीनं माझ्या तू येशील काय? आर संगतीनं कानी तू होशील काय? गोम संगतीनं माझ्या तू येशील काय? आवाज आवडते माझा. संगतीनं माझ्या तू येशील काय? गोम संगतीनं माझ्या तू येशील काय? भोसले विनायक कुठे? थांबू नको. बसायचं नाही आज. 2 पेज 4 झालं तुझ्या. तुझं टप्पावर डोलं कशा कोल्याचं झालं. माझं काळीच बोल त्याचं मासोली झालं. माझ्या पिरतीचा सुटला तुफान वारा वारा वारा. संगतीनं माझ्या तू येशील का? गोम संगतीनं माझ्या तू येशील का? रूपाची नथ मी घालीन ग तुला मिरवत मिरवत नेईन ग तुला रूपाची नथ मी घालीन ग तुला मिरवत मिरवत नेईन
तुझ्या पुतण्याला अश्विनी डोळ्यार म्हार.
संगतीनं माझ्या तू येशील काय गोम संगतीनं माझ्या तू येशील काय
आज संगतीनं तुझ्या मिळणार
अरे संगती
हार. संगतीनं तुझ्या मिळणार हार. तुझ्या कीर्तीची राणी मी होणार हार.
गोम संगतीनं
आज संगतीनं
अग संगतीनं
आज संगतीनं
माझ्या तू येशील काय शांताबाई घेता येईल खाली बली घ्या शेवटचे फक्त 10 मिनिटं आहे थोडं डान्स करून घ्या
क्या बात है.
बताओ कि मलिकान भगत कौन चंचल निगाहों में जिसने बचाई है हलचल बताओ कि मलिकान है मस्तानी चंचल निगाहों में जिसने बचाई है हलचल हवा में उड़ाती है जब वो अपना आंचल जमाने को पल में बनाती है पागल
जमाने को पल में बनाती है पागल
दिल मेरा कहता है बार बार दिल मेरा कहता है बार बार पीने वालों में है खलबले कली बली कली बली कली बली कली बली कली बली कली बली ले गई दिल मेरा मन चले ले गई दिल मेरा मन चले कल बली कली बली कली बली कली बली कली बली कली बली मुस्कुराहट है उसकी है निराली मेरी भी नजर बन गई है सवाली
नजर बन गई है सवाली
बड़ी दिल सी है होठों की लाली चटपटा रही है उसकी है बाली
चमका रही है ये उसकी है लाली
हो गया उसके दुनिया को प्यार हो गया उसको दुनिया को प्यार उसकी उल्फत सभी को मिले कली बली कली बली कली बली कली बली कली बली कली बली ले गई दिल मेरा मन चले ले गई दिल मेरा मन चले कली बली कली बली कली बली कली बली कली बली कली बली
कली बली कली बली कली बली कली बली नायक नहीं कल नायक हूँ मैं जुल्मी बड़ा दुख नायक हूँ प्यार क्या मुझको क्या खबर बस यार नफरत के नायक हूँ मैं हाँ नायक नहीं
कल नायक हूँ मैं। मैं भी शराफत से जीता मगर मुझको शरीफों से लगता है डर। सबको पता था मैं कमजोर हूँ, मैं इसलिए आज कुछ और हूँ, कुछ और हूँ, कुछ और हूँ। हाँ नायक नहीं कल नायक हूँ मैं। जुर्मी बड़ा दुखदायक हूँ मैं।
Hello friends, last 5 minutes. Rock for 5 minutes. Rock. Dinner is at the restaurant. Please join after 5 minutes. 5 minutes. Tapasi, 5 minutes. Last song है. Yes, last patch of 5-7 seconds. तूफान गाना लगाओ, तूफान. हलचल मचना चाहिए.
उड़ी 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 जाए, उड़नी उड़ो के उड़ी उड़ी जाए, उड़नी उड़ो ने उड़ी उड़ी जाए, उड़नी उड़ो ने उड़ी उड़ी जाए।
तारो पकड़ो मलकाय तार के ऊपर छलकाए, तारो पकड़ो मलकाय तार के ऊपर छलकाए, मारा भैया माताए काय काय।
Hello. The last song coming later. Devana Hare Sosana. The organizing team, are you ready to rock? Last song is not here. मेरा दम है बस यही अरमान। अरे डोले 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 डोले। मिट जाएंगे मर जाएंगे काम कोई कर जाएंगे, मर के भी चैन न मिले तो जाएंगे यारों का। मिट जाएंगे मर जाएंगे काम कोई कर जाएंगे, मर के भी चैन न मिले तो जाएंगे यारों का। अरे देखा न है सोचाना।
यहाँ है, मौसम जवा है, आलम यहाँ है, हंसने लगे दियो चलो, वो काला कौवा काट गाएगा सखी बोल, वो काला कौवा काट गाएगा सखी Hey!